All the studies related to fever as a symptom of a disease have been done without knowing the purpose or temperature of fever is. In the current COVID-19 epidemic situation, it has great importance because fever is considered as a symptom of COVID-19. Not knowing the purpose or temperature of fever, how can fever be included as a symptom in COVID-19? In COVID-19, up to 86% of patients have no fever. Why up to 86% of patients with this COVID-19 SARS-CoV virus 2 have no fever? Is it because there is no need for the care of fever, or is it because the disease is free of symptoms? Most of the disease may not have fever. Sometimes it disappears. Then, is fever a symptom of which disease? That is a question. Is the temperature between 38 degrees to 41 degrees centigrade can be a symptom of a disease? That is another question. What is the use of a symptom definition? Is it audible? And can you see my screen?
Yes, sir, it's fine.
Okay. What is the use of symptom definition? That is the question. As any or all other definitions, symptom definition should be describe the symptom scientifically. If it cannot describe it clearly, there is no use of a symptom definition. Symptom definition is the only parameter necessary for a symptom. Symptom definition. A symptom is departure from normal function or feeling which is noticed only by a patient, indicating the presence of disease or abnormality. A symptom is subjective, observed by the patient, and cannot be measured directly, whereas sign is objectively observable. A symptom can more simply be defined as any feature which is noticed by the patient. A sign is noticed by other people. Not even a single trace of symptom definition can be seen in fever definition and vice versa. A symptom has no ability to make other actions. During fever, sponging with water is used to reduce temperature. Then shivering takes place to produce heat. Shivering is a heat-producing action. An action can never become a symptom. Elevation of body temperature is an action like lifting, sitting, and standing. Is elevated temperature a scientific criteria or parameter of a symptom? No, the patient cannot feel elevated body temperature. According to symptom definition, fever is not a symptom. Then what are the criteria to assess a symptom? Nobody knows. Then on which scientific basis can fever be considered as a symptom? Nobody knows. If elevation of body temperature is not a symptom, then what? One cannot be understood directly. The temperature is elevated in the hypothalamus. A mechanical device is necessary to measure elevated temperature in the hypothalamus. According to sign definition, it is a sign. Then arises another question about body temperature. If elevation of body temperature is a sign, then which category will temperature of fever come under? Signal category, like a traffic signal. Everybody can feel. No device is required. In the beginning stage of fever, the patient and others cannot feel the rise in temperature. Elevated temperature or increased temperature never make fever or symptoms of fever. Elevated temperature or increased temperature may create hyperthermia. Different cause of diseases never show same symptoms. Different causes of diseases like virus, bacteria, fungi, venom, horror scene and horror dream, etc. never shows same symptoms. Its actions are different and sometimes opposite. No similarities can be seen between their actions. The symptom of virus, bacteria, and venom are not based on fever. The symptom, signs, signals are shown whenever virus, bacteria, and venom are present in the body. In such a situation, fever is not necessary because fever is not seen in everyone. All the symptoms and signals of hypothermia can be seen in fever too. That means there is a common basic science behind these phenomena. None of the disease or cause of disease require fever as its symptom. Patients who have flu to cancer may not have fever. The symptoms, signs, signals of fever are only seen at the presence of fever. During cancer, the symptoms, signs, and signals of cancer are shown every time. A patient having cancer and fever at the same time, symptoms, signs, and signals of both cancer and fever are shown every time. A symptom of cancer never become a symptom of fever, or a symptom of fever can never become a symptom of cancer. If fever is a symptom, one symptom has no ability to make other symptoms. If fever is a symptom, we cannot call a person a fever patient. A symptom can never cause fatal. We can prepare a table showing symptoms. 1 second. We can prepare a table showing symptoms, signs, signals, and actions of disease, fever, and rising temperature. This table is known as Jacob's table, showing symptoms, signs, signals, and actions of disease, fever, and rising temperature. Left side of the table, symptoms of fever, and middle, symptoms of rising temperature, and right side, symptoms of disease. How can we separate fever from fever condition? Fever condition include both disease and fever. If we deduct disease from fever condition, we will get the fever. So we can prepare an equation to separate fever from fever condition. This table is known as Jacob's equation of separating fever, hypothermia, and disease. Table number 1. How can separate hypothermia from hyperthermia condition? Hypothermia condition include both disease and hyperthermia. If we deduct disease from hypothermia condition, we will get hypothermia. So we can prepare an equation. How can we separate symptoms of disease and symptoms of fever and symptoms of hyperthermia? A fever condition means symptoms, signs, signals, and actions of both the disease and fever are included. A hyperthermia condition means symptoms, signs, and signals and actions of both the disease and hyperthermia are included. We can separate symptoms, signs, signals, and actions of fever and hyperthermia and disease. This is the table known as Jacob's equation of separating symptoms, signals, signs, and actions of disease, fever, and hyperthermia from fever condition and hyperthermia conditions. There is a sharp difference between symptoms of fever and symptoms of rising temperatures. Symptoms of fever include body pain, bitter taste, fatigue to mind and body, reduced appetite, reduced motion, and indigestion, and an aversion towards cold substance, internal and external discomfort, etc. If the symptoms of fever are mentioned above, how can fever be a symptom? That is the question. A symptom of rising temperature include likeness towards cold items, like to drink cold water, feel discomfort while using a blanket, feeling hot, etc. If the symptoms of rising temperature are mentioned above, how can rising in temperature be a symptom? That is a question. Fever never shows symptoms of rising temperature. Jacob's table showing symptoms of disease, fever, and rising temperatures. Left side, symptoms of fever, middle, symptoms of rising temperature, and right side, symptoms of disease. Below that, Jacob's equation of separating symptoms of disease, fever, and hyperthermia from fever condition and hyperthermia condition. Left side, symptoms in fever condition, right side, symptoms in hyperthermia condition. If the symptoms of fever are mentioned above, how can fever be a symptom? Symptom in fever condition, both the symptoms of disease and the symptoms of fever are included. If we deducted symptom of disease from total symptoms of fever condition, we will get symptoms of fever. So we can prepare a question.
Excuse me, sir. Just you can go with slow, please, sir. You can go with slow presentation. Hello.
Yes.
Yes, you can go with a slow presentation, sir.
Okay. Jacob's table showing signals of disease, fever, and rising temperature. Table number 3. Left side of the table, you can see signals of fever. What is the signals of fever? Shrinking blood vessels and skin, shivering, increased sleep, temperature rising in between 38 to 41 degrees centigrade. If the temperature rise in between 38 to 41 degrees centigrade is the signal of a fever are mentioned above, how can fever be a symptom? That is the question. Next, signals of rising temperature, expands blood vessels and skin, body sets, decreased sleep, and increase of temperature, the pressure will also increase. Uncontrolled high temperature, etc. are the signals of rising temperature. Right side, signals of disease, fits, unconscious, delirious, color and smell of urine and stool will change according to disease. Below that, Yakov's equation of separating signals of disease, fever, and hyperthermia from fever condition and hyperthermia conditions. Signals in fever condition equal to signals in fever minus signals of disease. Right side of the table, signals in hyperthermia condition equal to signals in hyperthermia condition minus signals of disease. The equation also mentioned in here. Signals in fever condition, both the signals of disease and the signals of fever are included. So we can prepare an equation. That is already told to you. Signs in fever condition, both the signs of disease and the signs of fever are included. So we can prepare an equation. Yakov's table showing signs of disease, fever, and rising temperature. What is the signs of fever? The firing rate of one sensitive neurons decreases, and the firing rate of cold sensitive neurons increases, increase of prostaglandins, etc. Signs of rising temperature. What is our signs of rising temperature? The firing rate of warm sensitive neurons increases, and the firing rate of cold sensitive neurons decreases. Signs of disease. Numerous signs like pressure decreases and increases, blood circulation decreases. Below that, Yakov's equation separating signs of disease, fever, and hyperthermia from fever condition and hyperthermia condition. Left side of the table, signs in fever condition. Signs of fever equal to signs in fever condition minus signs of disease. There is also an equation also. Signs in hyperthermia condition equal to signs in hyperthermia condition minus signs of disease. Cross-check equations also available. Table showing actions of disease, fever, and rising temperature. Table number 5. What is the actions of fever? Temperature rise between 38 to 42 degree centigrade. TNF alpha cause bitter taste to food, etc. What is the actions of rising temperature? Blood circulation decreases to brain and other organs. Loss of fluid due to dehydration. What is the actions of disease? We can see numerous actions according to disease and the cause of disease. Yakov's equation of separating actions of disease, fever, and hyperthermia from fever condition and hyperthermia condition. Left side, actions in fever condition. Actions of fever equal to actions in fever condition minus actions of disease. Like that, actions of hyperthermia equal to actions in hyperthermia condition minus actions of disease. Checking equations also available. Actions in fever condition, both the actions of disease and actions of fever are included. So we can prepare the equation. In fever does not show any actions of hyperthermia. After analyzing and evaluating the above tables and correlate them, it becomes clear that what is right and what is wrong. In physical appearance, fever is a warning signal. When disease becomes threat to life or organs, the temperature of fever is a warning signal of a disease. Conservative fever treatment, like sponging, antipyretic medicines to remove warning signal of a disease is dangerous. A new fever definition, diagnosis, and treatment is required. If a person who believes in conservative fever definition, diagnosis, and treatment, he cannot recognize these situations. How can we prove fever is not a symptom in COVID-19? The fever is not a symptom in COVID-19 when examined in various directions. We can separate symptoms of fever and symptoms of disease and symptoms of rising temperatures. Like that, we can separate signs, signals, and actions of fever and disease and rising temperature. If we ask any type of question related to fever, by assuming that the fever is a symptom in COVID-19, we will get a clear answer. If we avoid or evade from this, we will never get a proper answer to even a single question. If we do any type of treatment by assuming that fever is not a symptom, the body will upset. At the same time, body will resist whatever treatment to decrease blood circulation. Besides that, we used the symptom definition. No further evidence is required to prove the fever is not a symptom. Benefit of taming the fever temperature as a signal. The purpose of the definition of a signal is to analyze the signal scientifically, to differentiate and also to brief it and understand it easily. If we say there exists temperature as a signal, one can easily understand without much explanation. In such a situation, automatically comes apt word as well as apt definition. That is why it is told to exclude the temperature of fever from symptoms of the disease. Conclusion. Fever is not a symptom in COVID-19 when examined in various directions. Temperature between 38 degree and 41 degree cannot be a symptom of any of the disease. None of the disease or cause of disease require fever as a symptom. A different cause of disease like virus, bacteria, fungi, venom, horror scene, and horror dream never shows the same symptoms. Opposite diseases never shows the same symptoms. Fever has never been scientifically proved as the symptom of a disease. Fever has the properties of adaptation. Fever treatment should be revised according to the warning signal of a disease. A new fever definition, diagnosis, and treatment is required. It is wonderful that a physician having years of experience in fever treatment cannot understand actual fever definition and fever treatment have no relation with symptom definition and diagnosis. In the early days of my discovery, I thought that fever is a symptom of a disease. I never got any answer for even a single question about the symptoms. That induced me to find out the real truth of fever. I can eliminate conservative fever definition, diagnosis, and treatment. If you discard this discovery, it would be an injustice to mankind. I also prepared 8,000 affirmative cross-checking questions which can explain all queries related to fever. The real signs of fever can be termed as the physics of fever. Thank you hearing me patiently so far. If you have any questions, you can contact my WhatsApp number or my personal email ID.
Yes, sir.
I can share my address to others.
Yes, sir. Any questions? Any questions to Dr. K.M. Yakov?
Yes, I have a question.
Yes, madam, you can go.
I still not convinced that fever is not a sign for any disease, because, for example, if somebody have a flu, most of them have when they have a flu, they have some kind of fever. If somebody have a virus infection or somebody have a bacterial infection, they have like a septic fever. So how we cannot consider fever as a part of a disease or a symptom of a disease?
Fever is not a disease in any diseases. If inflammation, I have another paper also, the purpose of temperature of fever, that it cannot be selected in this seminar. If you No, the purpose of temperature of fever, you never ask this question. If inflammation increases, the blood circulation decreases, then our immune system produce extra heat to improve blood circulation. So fever is not a part of disease, it is a part of immune system. It is produced by the cytokines or WBC.
Yes.
Thank you for your answer.
Yes. So you have got another question from Dr. Yes, Dr. Hanus Al Rahimai. The question is Jacob table created by you?
Yes, I am created. This table is also published in a journal also. I will share the link of this paper is already published in a journal.
Yes, you can share through files or we'll be sending to all the participants.
I improved this table is improved so much improved than the journal. Now I can answer any questions and about the fever and its related questions. So I am want to share my screen.
Yes, you can.
Not screen. I want to my address to others. Then you can one second.
Okay, no problems.
Then you can contact me. Okay. The link of the I already shared the link of the link to the invoice meeting LCC. I already.
Yes, I'll be sharing publicly to all the participants, sir.
Sorry.
I'll be sharing this, what you sent to me, I'll be sharing to all the participants.
Okay, thank you.
Yes, can I share to all the participants, sir, if you give permission?
No permission. You can't share anybody.
Yes, no problems. Yes. Yes, any questions further? Any questions to Dr. Kim Jacob? Yes, sir. So just if after completing your work, just to be online, sir, you'll be asking so many questions. Other participants will be joining, and you'll be getting interest to in this meeting as well.
Okay.
Nice. Yes, thank you very much, sir, for participating in this event. On behalf of organizing committee members of Nursing Education Congress 2021, thank you for insight presentation. Looking forward to meet you again next time. As you are the last year participant, we will be grateful to you. You are participating the second time in this year. Yes. So now we ask Mr. Anas Al Rahmi from Amana Healthcare Hospital from UAE to join the event and start presentation.
Good afternoon, everyone. Let me just share my screen.
Yes, sir, you can go.
Okay, so my screen is clear for everyone?
Yes, sir, it's fine.
Thank you so much. So my name is Anas, and I'll speak today about rehabilitation consideration during the COVID-19 outbreak. So our objective for today will speak about rehabilitation and how important that this rehabilitation for the management of the recovery of the people. So our objective for today, at the end of this lecture, the audience will be able to recognize multidisciplinary contribution and post-acute rehabilitation, describe potential rehabilitation requirement and the impairment that associated with severe critical cases and how to be managed. So our outline for today, before we proceed with our topics, we'll speak about COVID statistics. We'll speak in details about the impairment that related to the severe critical cases. And also we'll speak about the role of rehabilitation in the management of patients with severe COVID-19. And lastly, we'll speak about consideration of continuum of rehabilitation. So before I speak about impairments, let's just talk about some COVID-19 background and statistics. So as we know, in last March 2020, WHO declared that the COVID-19 is a pandemic already. And through the studies, actually, the study shows that the person who get COVID, 40% of these people will develop mild symptoms, and the other 40s will have moderate symptoms. So both category will no need for them to be hospitalized. Approximately 15% they are develop severe disease, but this kind of also category still no need for hospitalization. Maybe they can manage at home or in the floors. They need oxygen support. But unfortunately, 5%, which is high percent actually, these people, they will complicate and they need actually hospitalization, especially in the critical care unit, because of course they will get severe pneumonia. Maybe they will have ARDS, respiratory failure, septic shock, another multi-organ failure. So that's why they need hospitalization. So this is our role here, to start early rehabilitation to help these people recover fastly. So in the morning, I check the numbers. So we have now globally 122 million cases active, and death, unfortunately, 2,713,000, and recovered 100 million, around 100 million. So before we go ahead about our topics today, we'll just speak about the COVID pathway. So this is actually from WHO, how we can triage these people. So the patient or the sick patient who's diagnosed with COVID will triage depend on his acuity of illness. So some cases will do home quarantine or hotel quarantine. Some of them, they will be admitted to the floor, and some of them will be admitted to the critical care units. It's depend actually on the severity. So we'll focus on the people who has severe or critical. So why we are doing rehabilitation? Why? What is the objectives from the rehabilitation? So of course, rehabilitation will improve the physical function and compensate the physical deficit. Of course, the patient will have a physical deconditioning and muscle weaknesses. So we are trying to help actually these patients to recover earlier. That's why we need early rehabilitation, as I said. So, as I said, 5% of these people, they will have severe associated symptoms from COVID. That's why we'll talk now about the impairment that happened from the COVID, which will be severe, or most of the time will need ICU admissions. So these are the 7 main the seven impairments. So we'll talk about each one in details and how we can manage it. So first one, which is the most important one, it's the impaired lung function. So of course, patient with COVID-19 will develop severe pneumonia that will lead to pulmonary fibrosis, pulmonary embolism sometimes, immobility for the muscles, and also sometimes ARDS. So the lung is the main organ that affected. So before we proceed about the assessment and the management of this kind of impairment, I need to mention about the IBC measures for the lung impairment. So we need to just remind all our healthcare providers to comply with IBC measures all the time, and especially with the following procedures. There is high risk of exposure with the aerosol generating procedures, such as intubation, extubation, resuscitation, and manual ventilation. So we need to just comply with IBC measures just to protect our staff. So usually when we start the rehabilitation, we'll start with the assessment. Then after that, we'll go ahead with the planning or to do the plan of care for the patient. After that, we'll start to intervene or apply the plan of care. And then we'll continue to monitor this plan if it's working or not, or need to be redesigned again. So for this kind of patient, when we assess them, we'll go ahead first with patient history. We'll check the patient history, pre-assessment, physical respiratory status, if the patient had reported any respiratory difficulties, if the patient got any community infection before. We can also do assessment on the vital signs observation. Sometimes we need further diagnostic assessment like chest X-ray or CT scan, blood gases, auscultation, of course, breathe sound. So once we gather the information, we can make our plan. So just here, I want to mention that as per WHO guidelines, spirometry is not recommended in the first 6 to 8 weeks in COVID-19 patient because of the infection risk. Once the patient is clear or negative, we can use it. It will help us actually to expand the lung and also for the vital capacity. So we did the assessment, and now we will start to intervene or make the rehabilitation program for this patient. So our goals will focus on 5 goals, our principles. We will aim to increase the ventilation. We need all the time to keep the airway clear. We need to support the patient, educate him, and also how the patient can return to his normal life. And of course, we need just to give him some physical exercises and fitness. So how we can increase the ventilation, how we can support the breathing. So of course, deep breathing or deep breathing exercise will help to improve the ventilation, expand the lungs, prevent the lungs from collapsing, and also prevent any further pneumonia. So as I said, we can use spirometry. This will help us. If this is not allowed now, spirometry, we can only use the breathing techniques or huffing. I will speak about it later. Second thing, we can use it, or we can help us. It's the positioning and the support. So there is some positions that will increase the thoracic expansions, such as like, of course, we are aiming to keep our patients in upright positions. These will help actually to improve the ventilation. Second thing, we need to focus about the airway. Airway should be clear all the time. As we know that the patient from pneumonia or COVID will have a lot of secretions or sputum in the airway, and these may increase the pneumonia or increase the infection in the lung. And also, if it's accumulated, maybe it can cause mucus plug, and it will lead to another complication. So that's why we need to teach the patient how he can clear his airway. So we just need to teach the patient about this technique, which is the huffing. So the patient should take deep breath with full expansion, then exhalation forcefully from the open mouth. This technique will help to soften or move the sputums, and then after that, the patient can remove it from his airway. So we just recommend the patient to do 3 deep breaths, then 2 huffs, just to clear his sputums. And also we have the bubble BIB, or positive expiratory pressures. It's like same, but we can use here the devices. There are some devices help us to also remove the secretions. So third thing we need to focus about, it's the education of the breathlessness. Of course, after the patient got COVID, the patient will have breathing difficulties, breathlessness. So we need to educate the patient to stay calm all the time, prevent anxiety. And this is a normal thing for you. You need just to try how to manage it and use the techniques, breathing techniques, position techniques. This will help you to adapt until this over. So as I said, deep breathing, positions, and also the patient can use breast sleep breathing. This help to help the patient to empty their lungs and also expand the lungs actually. So about part of education here, we need just we can just teach the patient to use these positions. These positions can relieve the breathlessness. So he can side lying, it's easier actually for him to breathe, forward lean settings, and also on the chair. These positions will make the breathing easy, and he don't need like too much energy to take the breath. Also, if the patient is walking and he got tired, he can just have a rest with lean standing, or he can support his back on the wall. The lip burst breathing. The patient will take deep breath through the nose, then out from the closed lips. So second impairment that happened from severe COVID cases is the physical deconditioning and muscle weaknesses. Why this has happened with the patient? So of course, patient when he admitted to the ICU, he will get muscle weaknesses due to some drugs like neuromuscular blocking agents, anesthesia, sedations, inflammatory process, metabolic changes, hyperglycemia, malnutrition, and of course, immobility or staying in the bed. This will cause muscle weaknesses. How we can help the patient to get rid of this, we'll speak about it. Another reminder to stick with the IBC measures, hand hygiene, all of the measures we know, all the healthcare provider, even the BT, SLT, all of them need to be strict with these measures. So again, the cycle will start with the assessment, then the planning. So for our assessment, we'll start with the physical assessment. Of course, we can just gather some patient history if the patient has some disease, some CVA, for example, any diseases that prevent actually full movement, let's say. So after that, we can also do a physical examination. We'll do a thorough physical examination to check the strength and the range of movement. And we can also check the balance and coordination. After that, we can know if this patient is, okay, we can do the care plan. Also part of the assessment, we can do observation on the walking, why the patient is walking in the frame or on the edge of the bed. Exercise tolerance, if the patient is can do the exercise or he got desaturation, we need to focus on this. After that, we'll go ahead with the plan. So our plan will be depend on our assessment. So we'll focus on our plan or intervention about early mobilization. Early mobilization, it's very important. Even the patient in the ICU, even if he's intubated in the bed, we can consider this. Early mobilization will help us and will help the patients. We need also to focus about the education. Once the patient is extubated and awake, alert, we'll start this process. Education is very important for these patients. We'll start about functional mobility also. After that, this is like advanced. We can start muscle stretching and strengthening and physical exercise. This is to prepare the patient to go home. So immobilization, as I said, in the ICU, we need to recommend this, to start this in the ICU or critical settings. Of course, once the patient is stable, we can start that. So if the patient was not able to go out of the bed, at least we can do passive movement or active movement. We can have the patient can do active movement in the bed, and after some time he can start to sit out of the bed in supportive chair. He can walking the frame, working with support. This is very, very helpful for these patients. So early mobilization is very good and very helpful. Let's say that the patient is extubated and he's now alert, but he still have like some kind of symptoms from short breath, need oxygen. So here our part is to educate him that what happened with you is, or you need sometimes for the recovery, you will feel fatigue, feel breathlessness. So this is a normal thing. You need just to focus on the breathing techniques and positions. This will help you to recover easier. So as I said earlier, the education about breathlessness, this position will just also remind the patient to use it to relieve the breathlessness and the shortness of breath. So also from our plan of care is to do muscle strengthening. How we can do the muscle strengthening, or how we can treat the deconditioning of the muscle weaknesses. So we need, first of all, to start the active exercise, then after that passive, then we can use some weights, or the patient can proceed with the muscle strengthening against resistance. We can also start with the active range movement exercise. This will help to prevent contractures and will keep the joints flexible. Here, there are some exercises. We can use it actually with the patients. I know this is a part of the therapist, but also the nurses, if we don't have enough therapists, they can do it. They can just teach the patient how to do a full range of movement exercise. This exercise can be done also in the bed or in the chair. So it's a very good exercise that can gain the strength of the muscle again. So once the patient ready or discharged from the ICU and he need to go home, we need to focus about the physical exercises and fitness. We need to monitor the patient if he has any sign of desaturation. We need to teach him how to use the pulse oximeter. What is the normal oxygen rate percent? Sorry. Yeah, in general. So we'll focus about how the patient can go home, how he can back to his normal life, and how to return to his normal fitness. This is some examples how the patient can use it for that will help him actually to gain his fitness again. So this is like advanced exercises. He can also start to walk, jogging or cycling. It's depend on his case. So once he's recovered more, he can he can start by walking then jogging like that. So third impairment that's happened from the COVID, which is the impaired cognition and mental health. Of course, the patient with long ICU stay, he will develop like impaired memory or attention. Most of them, they will develop anxiety or depression. So most of them also, sometimes their central nervous system will be involved. And this is due to maybe some of them, they will get hypoxic encephalopathy, or sometimes the virus will migrate to the brain. Another complication that happen in the ICU, trauma sometimes, exacerbation, anxiety or depression. So all of these things will lead to impair in the mental health and the cognition. That's why our role here to do a full care plan to help the patient to back to his normal life. So cognitive impairment will define as decline from a previous level of cognition function in one or more cognitive domain given the individual age or level of intellectual functioning. So why this cognitive impairment happened with the COVID-19 patients? So it could be to central nervous involvement, neuroinflammation, or actually the virus will transfer to the brain, sometimes hypoxic encephalopathy or sepsis. So our role here to start the assessment and the planning. So we'll just assess the patient for the fatigue, for the anxiety. What is the factors that lead to this? Like some environmental factors, noise, activity, ICU. You know, the environment of the ICU, alarms. The patient there is not getting enough sleep. So we need to assess all these thing, and after that we'll start to make our plan. So our intervention will be to improve the cognitive function. So of course physical exercises will help us actually to improve the cognitive function. So we'll start of course with the physical exercises. As I said earlier, physical exercises are very important for the patient, for the muscles, for the lungs. So even it helps with the improve of cognitive function. Another also thing that can help us here, which is the cognitive activities. Like we can let the patient have some puzzles, memory exercise, readings. These type of activities will improve the cognitive function. Another thing also can help, which is the participating in the daily activities. So the patient, like we can start actually this one if the patient is let's say in the floor. So we can like let him do his daily activity things like teeth brushing, bathing, these kind of things. When he go home, he start to do his activities like cooking, gardening, these things. These will help to fully recovery for the cognitive function. We have the fourth impairment that happened with patients in the severe cases, which is the impaired of communication and the swallow. So as we know, most of the patient, when they have severe respiratory distress, they will get intubated, and we know the complication of the intubation. So patient can develop impairment of the communication actually due from the intubation or respiratory problems. And also swallow will be affected from the intubation, also the mechanical ventilation, and also sometimes if there is direct damage to the nerve or the muscles. So who should I be assessed? Of course, when we speak about the swallowing here, we need a specific person who's expert on this field. So as we know, the SLT here is the one who's doing this assessment. So actually the assessment will be depend on the patient. If the patient is extubated or the patient have still tracheostomy. So there is two, let's say, categories. So for the patient who is extubated already and they are awake, so we can do like for them food trials, or for the patient who was on tracheostomy, we can use the speaking valve, of course, just to check their speaking. So here we need to just to focus about the measures because there is high risk to transfer the virus still. So all the therapist should comply with the measures again. So assessment will start to gather the patient history, observations, and as I said, we'll start with food trials, and sometimes we'll need some imaging. I will speak about it. We need to know the intubation history, how many days the patient got intubated, if the patient has cough or gag reflex, if he got any gastrointestinal infections, mental status. That's very important that the patient should be awake, alert to just cooperate with us during this assessment. I just need to I want to mention something regarding the food or fluid trials. So this one need, as I said, to be done by the specialist which is the SLT. So usually we are starting with pureed diet or pureed food because the risk of the aspiration is very less. If the patient likes to have fluids or juice, we can use it, but we need to use the thickener. Chopped food is not recommended as the aspiration risk is high, and also fluids without thickener is not recommended at all. So here we'll continue about the fluids trials. We need to monitor actually when we give the patient the fluids or the food, the symptoms of choking or the symptoms of dysphagia. So the patient, of course, will exhibit signs or symptoms like changing in the breathing. Maybe he will get choking or gasping. Coughing, of course, this is a sign of the choking or the aspiration. Sometimes pain, it's reported, but sometimes it's okay because he got intubation before, so maybe the pain is sometimes it's normal. If we notice that the patient has multiple swallow bear bolus, this will also we need to be careful about it. So here also same, we'll continue. Just I want to mention something here. When we perform this trial, the patient need to be in upright position, and after even when we finish, the patient need to stay in upright position at least 30 minutes to prevent aspiration. Yeah. So if we still not sure actually about the patient is like 100% can swallow, there is no risk for aspiration, we can use some fluoroscopy or endoscopy images. This will help us to give us the final decision if this patient can be eaten again or not. So as I said, we need the patient to be upright position at least 30 degree or 45 better. Then he need to stay 30 minutes after that. Consistency of the food should be chopped, not recommended in the beginning. We usually prefer pureed diet and also thickened food. Thicker liquid can be used, but we need to monitor the sign of aspiration. We can also here just use some strategies these strategies will help us to give safe eating and drinking. So we needed to use a small amounts, give the patient time. He need time actually, and quiet environment is very important. No stress, no noise. This will help the patient to focus on the swallowing. Do not drink fluids from the straw, which is very important because if he drank from the straw, it's high chance of aspiration. Some education here for this patient. oral care or oral hygiene is very important to reduce the risk of respiratory tract infection or pneumonia. The patient need to, if he can brush his teeth better, if not, he can use oral chlorhexidine or floss teeth, it's fine. Just here also for the patient with denture, they should also clean it after each meal. We'll continue also our education. Breathing exercise, it's very important, will help also in this stage. Vocal exercise also, like singing, this will help the vocal cord. But we need to just remind the patient, don't whisper or yell. The patient should, we need actually to focus here with the dietitian about the patient nutrition side, because patient should be hydrated all the time. So he need to get enough liquids with food thickeners. And also we need to give the patient like full nutrients. We just like full protein, carbs. So this will be need to be, we need to take the help of the dietitian. If the patient has tube feeding, it's still we can give him tube feeding, even though we are trying to feed him. But some of the patients, we are just giving them like small amounts of chopped food, puree diet, and in the evening we can give them tube feeding. So this is okay. So for post-intubation intervention, as I said, avoid whispering, speaking loudly, and coughing. This will tend to strain the vocal cord, which is not recommended. We need to just to remind the patient to stay to have rest and take breaks when he's talking, and also if he's eating or drinking slowly with enough time. Hydration is very important, as I said. So if the patient has a tracheostomy, the nurses should be giving tracheal care actually at least every 12 hours. The trained nurses will give the tracheostomy care, and also they can teach the patient or the family or the caregivers how to do it when the patient go home. For these kind of patients, when we do SLT assessment, we can assess their ability to speech. We can use the speaking valve or voice amplifier. So this will just give us like indication this patient can still talk or not. We need to make sure also here that the balloon of the tracheostomy is deflated while these trials. But if we are feeding the patient, the balloon should be inflated. If we are using the speaking valve, the balloon should be deflated. So fifth, impairment, which is the difficulty of managing activity daily livings. Here, the patient, of course, after all this journey, like from intubation in the ICU, sedation, muscle deconditioning, muscle weakness, it will be for him, it's very hard to go back to his daily life. That's why we need to make a plan for him, how he can managing his activities of daily livings, how he can return to his mood. If he had the depression, what we can do for him. We'll speak about it. So first of all, we'll start with the assessment. Here we'll do full assessment, because we are preparing the patient to go home. So we need to, for example, we can do like shower assessment. You can do shower assessment. The BT or the OT usually doing this. we can ask the patient how he feels himself, if there is facing any issues. Nurses or the caregiver also, they can give information about that. Occupations, if the patient will go back to his work, what he's working. Home environment, this need to be assessed, very important, because sometimes
we have only 5 minutes more.
5 minutes?
Yes.
I'm about to finish, no problem, thank you.
Okay.
Yeah, let's go, let's proceed. So once we finish from the assessment, we just need to give the patient some education and advices. Breathing exercise, as I said, the patient need to be stay calm to prevent any anxiety, and also he need to do full exercise, a range of movement exercise. All of these things will help him to go back to his life. We also can teach him that how he can save his energy, because when we are consuming too much energy, this will lead to take more breaths. So we can just giving them some education. Also here, if the patient need in the home some grapes, rails, bars, we need to do that. Some of them, they need ventilation actually in the home. It's very important. We need to check it, and also in the bathroom or showers to prevent any low ventilation environment. And we are done. Thank you so much for your listening, and if you have any question, you are welcome to ask. Thank you.
Yes. Any questions? Any questions to Dr. Anas Ramai? If you have any questions, just you can text here in the chat box. We'll be asking behalf of you.
Thank you so much to give me this opportunity to take in this conference. Thank you so much.
Yes, thank you very much, sir, for participating in this event. On behalf of Organizing Committee for Nursing Education Congress 2021, we want to thank you for inside presentation. Looking forward to meeting next time in physical event if everything goes well.
Sure. Thank you so much.
Yes,
I will stop sharing my screen now. Thank you so much.
Yes, definitely. Thank you very much, sir, for giving a time to respond to my emails. So next, now we ask Dr. Tracy Royak from Donate El Emirat Hospital from UAE to start the event and start presentation.
Hi everybody. I'm just going to go and get my presentation.
Yes, ma'am.
So is my screen nice and clear for you all?
Yes, ma'am.
Lovely. Okay, well, thank you so much for this wonderful opportunity to be here today. And Dr. Anas, well done on your presentation. It was really enlightening to hear about what you're busy doing with people within Abu Dhabi. So I'm just going to share a little bit of information regarding what we've done in our hospital setting at Donate El Emirat Hospital. And because as we all know, it's incredibly challenging what we've all been going through, never mind keeping healthcare clinicians and people who are all related to healthcare itself up to date with the latest technologies and interventions that we are definitely required on a continuous basis. So the objectives for my presentation is that we're going to be able to discuss the interventions taken to manage education in 21. We're also going to list the different tools that we've introduced, adapted to manage and support education strategies. Now, what I'd really like to do ultimately is just to give you a brief overview of what we've actually done, but at the same time, I'd love to learn more about what you've done in your hospital so we can knowledge share. So just introduction, that I think we all understand that in order to make a very solid health industry that is incredibly efficient, we need to have quality-driven education. This is without any doubt. If you don't have good education, your healthcare industry fails because you're left behind, you're not up to date, you can't get licensed within the Department of Health or wherever you are relying on for the regulations. So the presentations that have been really on for the last day or two is really shown that COVID-19 has been incredibly stressful for everyone. So in response to this, we've obviously had to adapt very quickly because when it hit us very fast. And we couldn't just rely on our traditional standard education. And unfortunately, a lot of us weren't really prepared for this pandemic. So it has given us a wake-up call. But at the same time, we need to look at the positive things that this COVID-19 has done for us to realize that there's so many other wonderful resources that we have that we can utilize other than the normal traditional platforms that we've been working on for many, many years. So our education department has moved to adapt and align certain changes, and it's been quite wonderful because the system and the actual organization has adapted really well, and the compliance has been great. So, excuse me, we have the mandatory education requirements, which are not negotiable, and then we have the non-mandatory education requirements. Now, the non-mandatory could be a little bit flexible. We could delay that a little bit or introduce it when we need it, but the mandatory, of course, has to be very reliable, and we have to be very compliant with that particular requirement. So the ad hoc sessions or trainings that we have are when we found in the system gaps. For instance, if there's been any incident reporting, issues which have been related to patient safety, we look at the gaps, we find out what the problem is, and then we move on to find solutions to fill those gaps effectively so that it doesn't cause a patient any harm. So this is just an example because, as we know, particularly in a very big hospital like what we have a north tower and a south tower. The south tower is coming up very soon. It's just past 100% compliance with the Department of Health. So we'll be getting the patients and getting everything ready there. So we have a large population of healthcare providers where we have to make sure that their mandatory education is always up to date. So I have created a little mandatory passport that everybody has within their learning and development folder. And this basically will help them identify what their needs are as per the requirements within all the organization. And there's also the legend on the back to know exactly which specialty will require specific education. And this is great, particularly when the clinician goes to the the performance appraisal. The line manager will look, have you done this, have you done that? And everything is beautifully compacted and easy to achieve as well. All right. So I think you're all quite used to this traditional based education that you can see in the picture here, where everyone is, they're sitting relaxed and it's very face-to-face. However, this kind of thing was no longer acceptable. We have to have social distancing, and even the Department of Health stopped all face-to-face education for quite a while. I think it was probably for about 4 months. So we had to be very creative and think about what we could do to actually make the change. Excuse me. Okay, so what did we actually do? So first of all, online learning has been there for a long, long time. So has blended learning. But if you don't have that platform already in the organization, you have to start thinking very quickly of what to do. So we started working with the IT team, IT department, in actually developing our own courses, which were actually aligned and suitable for our own people. And that's what was beautiful about it, because we knew what their needs were. It wasn't just an outsourced company. We got them in and it was all like standardized according to everyone else. We actually decided, what do we need within our organization to help our people get the best possible care for our patients. So we, for instance, let me give you an example. We have, I'm part of the PROM team, which is Practical Obstetric Multi-Professional Training, and I'm part of the faculty in the UK in Bristol in the UK. And it's a very much so face-to-face interactive simulation workshop and course. And it normally lasts for 6 hours, and you learn all the different particular obstetric emergencies, you know, working in the team dynamics. And it's very much so looking at the dexterity, how you work, how you harmonize, how you work together, and that kind of thing. So we couldn't do this anymore. We couldn't actually afford to have 6 hours of face-to-face contact. So what we did basically is we took out the theory portion, we put it onto an online platform, and then we actually created a workbook so that they could support the theory, and then they came on to actually do a 2.5 to 3 hour face-to-face to demonstrate their skills, what they learned from the theory. And actually, we might even keep it after COVID, because it actually has been proven to be very, very reliable. And it's a good resource, because at the same time, it doesn't remove that productivity from the clinician itself. It allows them to continue working in the workforce with the up-to-date information. So this presentation really does aim to describe the journey in establishing effective professional development. And as I said, I'm going to certainly share the strategies that we've had. And this is a really good thing, because it also helps to align the healthcare and reducing healthcare-related costs. So my name is Tracy Roke, and I'm Head of Education, and also I manage the student affairs within the hospital. So what innovations did we actually start using? So this is just a list, and I'll explain to you each particular resource that we have in detail. So laminated documents for easy cleaning purposes. So what we do know and what we have learned is that paper isn't really a good thing to use within training anymore, because, you know, you're moving, one person's holding it, you're handing it to other person, so there's cross-contamination going on. So the laminated documents actually help for cleaning purposes. So after each course, we're able to disinfect them after they've been writing on with the non-permanent pens, and that is very useful, particularly with the POM course once again, because there is certain debriefing tools that we have, also checklists to see that the team members are actually fulfilling all the particular priorities within the actual emergency simulation course. The electronic attendance sheets introduced. So today you might know that it's quite difficult when we are doing a Zoom meeting to actually keep the attendance. You often have to take photos or screenshots or whatever it might be, which is quite useful, but at the same time, you still have to have evidence of attendance. So these electronic attendance sheets actually have proven to be quite useful, in the sense that we have a record. They don't have to sign their signatures or put their IDs or whatever it might be. The person who's facilitating the course is able to do that. We also created an online e-registration. So no longer is it paper-based, where you fill the form and send it to education department, get it approved, get it not approved, whatever it might be. They can actually book all their courses online. Now, the Natal Emirate Hospital does offer over 40 courses, whether it be face-to-face or actually online or blended learning. So we have a very, very busy department. We are very focused on making sure that our online e-registration is very streamlined, that people don't get disappointed, that people book on time. We have also a very strict policy in place that actually allows our staff to make sure that they book at least 3 months before. And that proved to be very helpful, particularly with the pandemic, because we had already got people booked in. There was no one going to be expired. There was everything was more organized and a lot more productive. And then your online evaluation. So you might say, well, you know, can be also a tricky thing, sending out a monthly survey, ensuring that everybody gets their surveys and their evaluations formed. So we've actually got a beautiful system in place that actually allows us to have a good evaluation, so that we can look at our deficits. What can we do to actually make our course better? And also our online certificates. So traditionally, education department would do a course, make sure everything's fine, get your evaluation form in, and then only after we would actually generate a certificate and send it out. And majority of our courses are CME accredited with the Department of Health as well. And now this actually, when we do our online courses, which we do have actually built inside, we don't outsource, as I said, these particular certificates are generated immediately. They can then print them and put them in the learning and development portfolio, which actually supports for their performance appraisal once again. And then, of course, we use the Zoom, the room sharing in the Zoom for teamwork and things like that. So this is just a little picture of an electronic attendance sheet, which is very simple and easy just to fill in. And the person who's facilitating the course can do that and keep that in their file or scan it and put it in their folder, wherever, whatever their process might be. So pop-up education. Now, pop-up education is really important because this is where you're looking at the needs and the deficits within the organization itself. So you might find that you've got your traditional, your routine scheduled courses happening, but at the same time, you might need to do a little bit of extra PCR testing, for instance, and then you actually go along and do that pop-up education. So this is a very important pop-up education that we have within our hospital. And what we've noticed with the poster presentations now is that it's actually helped people to become more creative and also allows people who are creative already to showcase what they have. And we do these poster awards every 3 months, and then we have a massive annual one. And we've just recently had an annual one, and everyone gets involved, from facilities to the guys in the biomed, from people who are the drivers, the transport, the bus drivers. Everyone takes part, and we're blown away with the quality of the poster presentations. Absolutely amazing. But these poster presentations, we of course had supported with a quality initiative and evidence-based workshop, so they can understand the tools and the resources that they can use, whether it be PDCA or Focus or Fishbone, whatever it might be, to actually help align what they did. But traditionally, with what we did initially, it had to all be handmade. So they could actually be artistic and craftful and actually work as a team, utilizing their own resources, which is once again also quite cost effective. So this is just another example, and I'm sure many, many hospitals and organizations, healthcare facilities, has done refreshers on PPE, donning, doffing, hand hygiene, sharps, needles, whatever it might be. But we found that we had to retest everyone, their competency again, particularly with the COVID-19, because there's a certain standard within our organization. I mean, I recently went for PCR myself, and I was really quite disappointed with, they didn't, for instance, do the, ask me my full name for the 2 identifiers. When I came to do the test, there was no hand hygiene, they didn't change their gloves. The technique of the PCR I wasn't happy with at all. And I walked home, and only then did it click to me that how important it is, particularly with this, the pre-analytical errors, how we can actually enhance the thing. And I was actually quite proud of the staff. Of course, we do the 2 weekly PCR in our own hospital, one of the hospitals that were really top performers of that. And everything is absolutely to the T, and I'm incredibly proud. And yeah, it's also because of training. How well you train people is the pinnacle of it. So basic and advanced life support has also changed. And I'm not talking about from 2015 to 2020 with the new regulations now. I was just monitored on Thursday for the 2020, and I'm glad I passed, and I now can be a local monitor for Abu Dhabi for any other person who wants to do the 2020 BLS instructorship course. And there was quite a lot of adaptations that we had to do for the COVID-19, and we have like a proper PPE kit on each crash cart. Make sure that every single bag and mask has a filter on it. Make sure that when you're practicing your training, that you're actually using these equipments. So you're testing systems non-stop and having all the appropriate signage and algorithms that have introduced new principles, not only for the 2020, but particularly for the COVID-19 now, because we know that everyone, even if you had your PCR, it was negative 2 hours ago, you're still suspicious. And that's very important, even if you've had your vaccination, by the way. So blended learning, I just love that name because it just sort of creates a sense of very cognitive kind of introduction to knowledge-based retention of knowledge, and at the same time having that good dexterity going on that helps to align people with the best practice. So those two meeting is very powerful, and it really allows us to use our right and our brain and left brains quite beautifully. So for us, what we found when we looked at introducing the blended learning into the organization is that it certainly did reduce the contact time with each other. So at the moment, our COVID-19 task force team has allowed us to have 5 participants per course, and we're only allowed to do live support at this very moment in time. We have put the others on hold unless it is through virtual. It also has reduced actually the course's length. And what it's done with that, because now they can actually do the blended part, the theory part at home, or when they've got a break, they can go back to the course, whatever it might be. For instance, we are busy going through the baby friendly. And as we all know, according to WHO and UNICEF, the course is actually three days long. And that takes a lot of the time up for the participants, right? So now we actually have the 16 hours course online now. I produced a beautiful online course, and now they can actually just go and do the 4 hours or with the lactation consultant, which has been very, very useful as well. Now, what I have noticed is that people come with the knowledge already, so they're not still coming naive or not doing their homework, and they're actually now really focusing on the practicalities of what the practical portion of it. So it's very, the whole dynamics has changed. It also improves concentration time. As I said, easy access, convenient, flexible, and once again, blends the dexterity with the cognitive abilities. So has it actually really made a difference regarding costs? Well, yes, it has. Okay. So ultimately, a blended learning course can be a little bit more expensive to a face-to-face because you have to buy all the, for instance, BLS or ACLS or PALS. We need to buy that component. But at the same time, when you actually look at the cost, the doctor does not have to spend so much time now in a 6-8 hour or even a 2-day course like in ACLS, but they can come and do their 4 hours and then go back to the clinics and actually start generating their income, which is, so at the end of it, it actually does reduce costs quite a lot. There is the demand and the supply. Yes, we do find that the instructors are a little bit more stressed because we do have to schedule rather 2 courses in a day to accommodate the 10 people rather than the 1 that could accommodate the 10 people. But looking at a positive note, it just makes us instructors a lot more experienced. So that's great. So the following courses were developed to reduce the time contact and to align, obviously, education with the best practices. So before we had neonatal resuscitation course, which was, excuse me, 3 to 4 hours, depending if the person needs remediation. I think maybe I'm talking too fast because my throat is very dry. Excuse me. As I said, with the prompt course as well. Then we have the breastfeeding initiative, the art of obstetric, which is the workshop, occupational safety and health, emerging leadership course, and our literarum workshop, which is really focused on the documentation, but it's a very fun course because, you know, documentation tends to be a bit dry at times, and then fetal surveillance. So all of these we've now blended. So the theory is now online and the practical is there when they're ready to actually go and do that. The blended learning actually is in 4 parts now, which is really important. Each course has a workbook. We also have the online theory and pre-test and post-test. We also have the practical experience and then also the ongoing real-time evaluation on the floor by the senior staff to see, do they need anything extra to actually enhance the care? So the virtual learning I've spoken about, the actual courses that we have, as you can see, there's a list here. I'm not going to read them all through to you, but I'll give you an example. For instance, the antenatal CTG on the list, it's number 6 from the bottom. We noticed that there was a little bit of issues related to how we interpret an antenatal CTG. So this aligned it, and now people have, and we also do the CTG reviews and actually lines it with best practice now, which is fantastic. Okay. Training space, we have got a new tower going up now. So we've, you know, in the busy of renovation, we've had an issue with training space, but now we're absolutely happy and sorted with our training space. It also helps to make sure that where you're working, it's efficient. The space must be a good quality space as well. because of the physical distancing, you need to make sure that you do have all those safety features as well. This is just a little example how we innovated the corridor to actually do our training while our training room was being reinvented, kind of thing, to ensure that we had 45 people and good space, good cleaning environment. So outcomes is that we actually managed to save, before pandemic, we were doing over 1,000 hours. During pandemic, it was actually halved by 488.5 hours. Okay, so we actually had a total saving of 533 hours, which is equivalent to 56 working days, nearly 3 months. So in conclusion, education absolutely cannot be stopped, and it is an important part of a vigorous healthcare science evolution. And we need to adapt and take advantage of the changes that force us to move forward. And even though COVID-19 has been a disaster, terrible, it actually has pushed us to actually start investigating, looking at being more innovative with education. These are just a few of my present references, and I really hope you have a great and bright, beautiful day ahead. Thank you. That's me.
Any questions?
I finished.
May I continue?
Yes, any questions?
Any questions?
Any questions to Dr. Tracy Roy? If you have any
Guys,
questions.
I asked you to tell me more about what you're doing. Come on, let's share.
Hello. Hello.
Hi.
Hello, doctor.
Hi.
Thank you for your nice presentation. It is interesting because we have no other option. It is because normal pandemic, so we have no another option to continue our education. But in developing country, there is different challenges. We started this online teaching for our MSCC students, but we are faced a lot of challenges, such as accessibility of internet and electricity, even if economical problem of the students. Some students have no smartphone and PC, so we have faced a lot of challenge, even to start on MSc students. What challenge you are faced and how you are overcome that problems? And if you are comparing these types of teaching methodology with the traditional one, what good outcome it has when you are comparing with the traditional one? It is my question. Thank you.
I'm incredibly humbled by what you're saying, because I really feel, particularly in the Middle East, that we are incredibly privileged and we have wonderful resources out there. This country really does spoil us, if I can use that word. And we don't really appreciate what other countries go through, particularly if I am an educator in a rural area of South Africa where there isn't any, because I'm from South Africa, there's no electricity. What do you do? What do you do? And I really want to know from you or other people, what do you do? Because I've been in this country now for 16 years, so it's sort of my home, you know, and it's just so wonderful. And I can just imagine how the students are, particularly school students, what they're going through and how challenging it is for them to actually just, I think even with us, you know, at home kind of thing, people who do school, you know, teachers, homeschooling, whatever it might be, you have your parent to help you, to guide you, to support you, or even you have your colleagues to come together and to teach what you've been doing, whatever it might be. Whereas a lot of the people in the rural area, they don't have that opportunity because their parents are busy working. So I'd love to hear more about what people think, because for that, I don't really have a right answer to answer that because I don't know. Regarding the second question, what I've noticed, particularly with the evaluations, that people actually are enjoying this type of training and education now. It's starting to settle and they're starting to feel comfortable. I mean, to be honest with you, before I'd get the nurses, because, you know, nurses tend to feel sometimes they're quite scared or shy to speak in conferences, particularly educational conferences. And now I've actually got 2 nurses coming to speak at a conference on Zoom. They feel a lot more comfortable speaking online, you know, compared to a huge big hall where it's quite traumatic and you feel quite exposed. So there's so many wonderful advantages, you know, that are there that we just have to look and appreciate. So thank you for your wonderful questions.
Any questions?
Yes, please. I have a question. Thank you.
Hi.
Okay. Good day, Dr. Tracy. It was a very interesting topic. Thank you so much. I'm Elizabeth. I am from South Africa in Gauteng.
Wonderful.
I'm a lecturer at University of Johannesburg.
Oh, wonderful. Wonderful.
Yes,
Thank you.
this was very challenging for our students. I must say, I think because of the lockdown, which was sudden, and the sudden shift from contact to online, it was even more disastrous for the students than it was for us as lecturers. At our university, we are using Blackboard Collaborate Ultra, and that is how we're conducting the lessons. They have not gone so much into Zoom, but we do have a lot of Teams, and they are only starting to settle this year. But I must say, I applaud you for what you have got there because it was so much of a challenge for our students. Data had to be provided for them. Some of them, the places where they are working or staying, the network was bad. So even doing the assignments online was a challenge. So how did you go around with the availability of data for your students to be able to provide the assignments and the assessments? Because we had challenges that it was just too much for us. Only now in 2021, they are starting to find their feet, but last year was a disaster.
Yes.
Thank you so much.
Thank you so much for that, Elizabeth. I can truly feel for you. So I'm actually also faculty member for a nursing college. So I go once a week to Fatima College, Health Science, to actually teach the nurses healthcare assessments. We do use Blackboard for them, and it's a really great platform. You know, they can get all their tools and resources and teaching assessments, whatever it might be from that. So we're quite blessed as well, like you, to have that. But as you say, it takes time for people to get into it, right? Now, in the hospital setting, in the hospital setting, it has been challenging, particularly those routine annual competencies, because we've got so many. So we have quite a good Elizabeth, and that is we have education links. Now, so education links will actually meet quite regularly. They will go out, and these are resource people who actually have been sort of made a level at a level 4 of being a teacher or a resource person within the hospital setting. And that has actually allowed us to make sure that all of their mandatory education, particularly with those little competencies which are mandated, are achieved. And as I said, I shared a little bit earlier with you the mandatory passport, what we have. And we also have, like, for instance, how do I track the online education? So now we have a wonderful tracker where they actually fill it in, what they've done, the date, and they've signed it. I mean, we do work a lot of integrity. People need to have this integrity. You know, if you don't have you fail. And that's your problem about ethics and professionalism, right? So great. Thank you for that. And I do honor you for your position, because what makes South Africa great is people like you.
Thank you so much. Thank you so much for your lovely student.
Any questions?
Can I ask a question?
Yes, definitely, madam. You can go.
I want to ask what the platform you use to do the evaluation form, because before I do any presentation, or educational session, I have to submit the pre-evaluational form and post-evaluational form. And it's very nice if we are using paperless and going online to do the statistic at the same time. So what the platform you use, Monkey, Google Form, or what you are using exactly? And for the lady from South Africa, I have the same issue with the nurses cannot access online. So what I did, the video presentation, and if they cannot have online, I can give it to them in a flash memory to see it at home.
And then I think you're going to be talking a little bit later, so I'm quite excited to hear your talk because you seem to be very wise to what your questions are. So basically, at the moment, we're still working a little bit on getting that platform to a more productive way, because often the thing I hate about, sorry if I can use that word hate, is paper-based, is people often fill it in, it gets filed, and it never gets looked at. Isn't that right? So this platform really would work on a system where it will pop up to me as an education, head of education. I'll be able to look at it itself and then actually work on seeing what I can do to actually improve the course itself. So at the moment, we're actually working on when they do their registration itself, they will get an actual evaluation form there to keep. Once they get the evaluation form, they've done the workshop or course, and then they'll send that form back to me. So, we can also use those, on the Zoom, there's that where you can ask questions for pre-tests and post-tests as well. There's an option on the Zoom link itself to actually create some questions that they can answer just before, and you get the results immediately as a bar chart. How many people got it right, wrong, whatever, and you can discuss.
Yes, like a statistic.
Yeah, the statistics, yeah. So that is the biggest challenge for us, is the evaluation. But there's no ways that we can use the paper-based anymore, because particularly DOH, Department of Health, they have to have evaluations. You know what they're like, right? Yeah.
But I think Microsoft Teams, they don't have this tool to do the statistic questionnaire like Zoom, SurveyMonkey or Google Form. They don't have this.
Yeah, there are some challenges with that. But we don't really use Zoom like some other hospital settings they do. And I know they use Teams because of the security aspect. And no one can just, you have to have all the emails programmed in first. So I maybe can work with you. Maybe you can leave your number there and we can work together and see what we can do to actually make this evaluation a lot more streamlined.
Yeah, yesterday I even suggest to, I forget what her name, from Canada, that as a nurse educator, why we don't meet once, every 3 months to talk about what the challenge and how we can share all the information to work out as a nurse educator, as one unit.
Well, definitely, if you don't mind sharing, and even Elizabeth, and then
I will share it in the chat, my mobile number or my email.
Thank you.
Yes,
that will be very interesting to share, because from my point of view, our assessments are online. They take so long to complete the assessments. That's the first one. You find that by the time you've done your auto submit, the assessments only come later. When you do your marking, most of the marking, you find only one question has been answered, and then some of them actually sent via email, which makes your work double. Though it's on PDF, but you find that it delays your feedback process. So it will be very interesting to share what you are going through so that we can be able to come together as the nurse educators and try and see what you've got that side to share with us.
I think it's the easy way to pick one platform, Google Form or SurveyMonkey, and you can send for them the info for everybody the pre-assessment and post-assessment, and as they answering, they can be the statistic showing at the same time. So you are not doing double work of looking to the answer and see how many and how many percentage. It will be easy. But it's only new, and I'm reading a lot about it. I'm still also learning what is the best.
Yeah, okay. So we'll discuss this a little bit later.
Yes, that's fine. It's fine.
Thank you so much. Thank you so much.
Yes, it's. Any further questions? Just you can text here and chat box will be asking, because we need to follow the timetable according to sessions.
Thank you.
Yes, definitely. Yes, thank you. Thank you so much, madam. Thank you for speaking up in this meeting and providing your perspective. Thanks for sharing your tips with us. Looking forward to meet again next time. Now we ask Dr. Jelena Rogenvik from University Hospital for Nigeria from Croatia as one of the keynote speaker of this online event to join the event and start presentation.
Hello, everybody. Well, I'm sure, can you see this or not?
Yeah,
I just want to,
Yes.
maybe slideshow like this, it's better. Okay. Well, I'm completely sure that my presentation will not raise a lot of discussion as the last excellent one. But the other thing that I'm sure is that I will not stop in 5 or 6 minutes as it was supposed for schedule. So what I'm talking about, I will talk about actually the life about ones being cured for childhood cancer. I'm pediatric oncologist from Croatia. And we are very proud when we talk to people who are not in the field that the treatment outcomes of pediatric cancer is one of the most successful stories, not maybe in the history of oncology, but in the history of medicine, with approximately 80% of children being cured. These excellent numbers are results of intensive, more and more aggressive chemo and radiotherapy, well-designed, multi-centric, multi-institutional, even intercontinental clinical trials, stratification of patients to the risk groups and risk-adapted treatment, and very, very good supportive therapy. Can you hear me?
Yes, yes.
Thank you. So we will have in the general population more and more survivors of childhood cancer. It is estimated that approximately one of less than 1,000 individuals between ages 20 and 40 is survivor of childhood and adolescent cancer. Childhood cancer survivors, though being cured of their primary malignancy, often experience late effects secondary to the cancer itself or to the anti-tumor treatment. What are actually late effects of childhood cancer? Late effects of childhood cancer are defined as any chronic or late occurring outcome, physical or psychosocial, that persists or develops beyond 5 years from the diagnosis of the first neoplasm. From my point of view, I'm a kind of older pediatric oncologist. These numbers are striking. That means that 2/3 of survivors have at least one chronic health problem, and 1/3 of them have severe health condition. This slide is just to show you actually that any organ system can be affected late by radio and chemotherapy. Not only morbidity, but the seriousness of late effects is evident in studies of premature death following cancer treatment. You can see on this slide the lifespan of cancer survivors, females and males, in comparison to the general United States population. Oh, as far as I know, this is one of the best studies about survivors and their mortality, which included more than 20,000 survivors. So they found that the standardized mortality rate is almost 11, that it is highest in children treated for brain tumors and acute leukemias, and that it is higher in survivors who were treated at very young age. Most common causes of death were actually cancers, or it was relapsed primary cancer, or it was second neoplasm, followed by pulmonary toxicity and followed by heart problems. When they were looking about the type of second malignant neoplasm, the most frequent were sarcomas, osteosarcomas and soft tissue sarcomas, followed by 2 types of carcinomas, breast and thyroid, and then more rare skin tumors, brain tumors, and second leukemias. When they analyzed the type of the first cancer, so it was striking, the patients with Hodgkin's lymphoma had the highest rate of premature death, followed by Ewing sarcoma and followed by soft tissue sarcoma. Let us leave mortality and let's pass to long-term morbidity, which is usually classified or subdivided in groups like medical morphological problems, medical functional problems, cosmetic consequences, psychosocial consequences, sexual dysfunction, which is not only infertility, and the problem that is raising inability to find employment and insurance funding. The mechanisms of late damage vary a lot, from surgery and radiation to chemotherapy. We have to keep in mind that the consequences of radiotherapy or chemotherapy may be enhanced by another anti-tumor treatment option. This is, I would say, maybe the common slide about organs that can be affected by radiotherapy. As you can see, almost all organs, I would like to point: brain, heart, lung, bone, like premature termination of growth, thyroid, and gonads. This slide actually is a summary slide about chemotherapy late effects. And for actually audience, for this audience, I would like to stress that, again, not almost, every organ can be affected, that various drugs can affect various organs or the same organs, and that the type of damage can be the same about various drugs, and the same drugs can have very heterogeneous late effects. So the challenge of today's pediatrician oncology is to enhance the cure rate while decreasing the risk of serious treatment-related illnesses. That means not to sacrifice the health of the patient, but to take a lot of care about the quality of life. That's not only thing to think about. As long as new therapies are used, it's possible that there are some unknown adverse effects identified. Besides, we are now witnessing of very late effects, even my generation of therapy, up to 30 or even more years after treatment. Well, I'm European, that's why I will talk about the field in Europe and about European statistics. Every year in Europe, 35,000 children, adolescents, and young adults are diagnosed with cancer. 15 in children less than 15 years, and 20,000 in adolescents and young adults aged 15 to 25. Don't be, actually, it is from 15 to the end of 24. What is estimated today? What about European policy and stakeholders? They estimate that almost 500,000 European citizens are survivors of childhood cancer. So it is really a kind of public health problem. We are aware that the number of survivors are likely to continue to increase, and improve of their quality of life is to be done. To address this, in Europe, like 12 years ago, one network was created, was established, we call it PanCare. So it is a pan-European multidisciplinary network of health professionals, survivors of pediatric malignancy and their families, that collaborate to reduce the frequency and severity and impact to quality of life of late side effects of therapy, with the aim to ensure that every survivor in Europe of childhood cancer receives an optimal, I would like to say, long life care. Actually, I prepared what I think is that maybe is our major result. It is so-called survivorship passport. What is survivorship passport? That is a document to be given to every individual patient after the elective end of the therapy of the primary cancer. It is in paper and electronic based form. It is written in a simple way in the lay language. It contains, I would say, general information about cancer and about treatment. Not only information, it provides as well advice, guidance, recommendations on patient-specific long-term follow-up of possible late effects to that individual patient. And it is translated to all languages of the European Union. I will try to hurry up a little bit. So you have database, you have follow-up guidance, and you have so-called IT cloud, which is actually seen to the patient himself or herself, and to the treating physician. I'll, in the next few slides, try to show you now some kind of general outline of what it looks like. So we have demographic data, we have diagnosis, we have frontline treatment. We give to the patient, well, if in our situation, more often first to the parents, the passport and guidelines as well. I will maybe talk a little bit later about tumor type. Actually, we use ICC is International Childhood Cancer category, and ICD is International Classification of Disease. So we usually opt for this childhood cancer category. So that means that classification table must be uniformed. For chemotherapy, we use generally accepted ATC codes. For radiotherapy fields, we included a lot of radiologists, a lot of radiotherapists. They actually suggested us this scheme by anatomic region and ICD topography and so-called special sites. We actually, I think, were marked as very good. So we received quality certification and security certification to go on because it's really a delicate question. It is what it looks like. It has multilingual facilities because we are more and more aware that people are moving and transferring a lot. So it is like it looks like. I'll not go into details about demographic data. A lot of fields are mandatory. About diagnosis, you cannot go on if you don't fill the all obligatory fields. So cancer category, I touched this point before, is according to this ICC diagnostic group, while cancer diagnosis is based on another morphology. Cancer site, then some additional information on more and more obligatory genetic markers of the disease, some maybe associated syndromes, some other comorbidities, or any other medical or other condition. A lot of actually information about frontline treatment and checklist, about chemotherapy. So you can type, as you can see on this slide, it is a generic name, and then it goes out all names that the drug is on the market. So radiotherapy as well, if stem cell transplantation was, and then it is like a kind of summary and events after elective end of therapy. The passport has so-called color code. That means, as I actually pointed out, we want to give guidelines to follow up. So it has strong recommendation, actually the follow-up that should be performed, or moderate, that it is reasonable to perform. Weak recommendation may be considered, for example, to do colonoscopy every 2 years. Not recommended, that we know that there are more harms than deficits, and there is a minor group of recommendations that there are not enough data to give any. We actually wrote and published a lot of brochures I give you here an example of cardiomyopathy screening, about breast cancer screening, but we have a thyroid, infertility, and pulmonary screening as well. Patients usually are given a printable treatment summary. So it is how it looks like. For example, in my hospital, we had not, till I don't know how many years ago, electronic based. So for example, for one patient, for one survivor who was treated for acute lymphoblastic leukemia, it took me around 4 hours if the clinical course was eventful. But just to have an idea, the treatment, for example, of pediatric ALL, which is the most common pediatric malignancy, is 2 years. So that is my last slide. What we think now, actually long-term or long life follow-up for these patients, childhood and adolescent cancer survivors, should be standard of care. Thank you very much for your attention. This is a group of people that was involved in a lot of projects. So it was a big work that lasted for a couple of years, but I think what we are proud of, survivorship passport is now included in the health system of Italy and Austria. So national health authorities recognize them very, very well, and now it will be included in Latvia. Thank you very much again.
Yes. Any questions?
Yes, I have one question.
Yes, madam, you can continue.
Just like last week, I was attending stem cell therapy and bone marrow transplant for kids and adults, and he was speaking about the patient advocating group or the patient and family group, that they created this group, patient who sick and received the medication, or parents that they have kids who treated with bone marrow transplant, that they be a part of the treatment and they have their own voice, share with the medical team how they would like to receive the treatment and what is the pathway. Do you have like this team in your organization?
I cannot hear you. Could you maybe, Inovine manager, can you maybe briefly repeat the question?
Okay.
Just you can text here, madam, if you have any questions, just you can text, we'll be asking behalf of you.
Okay.
Okay. Okay, I can answer you immediately. So just put the question. Thank you very much.
Hello, doctor.
Hello.
Hello, I'm Sisai from Ethiopia.
Okay, thank you.
I have some question regarding for your presentation. It is interesting and nice presentation because you are addressing an address issue, especially it is an address issue in developing country like Africa. It is unthinkable doing just like this for oncology patients because even the professionals are not well aware on this, and they have a little professional who have oncology courses, and even it is unaddressed even in the curriculum. So you are doing a good, it is based experience if you are sharing for the country, just like these countries who have no knowledge and different deficiency. Even if the survival is in developing country, it is around 50 up to 45 survival or cured from these oncological and cancer-related problems. The main challenge that faced, most of the patients correlate this issue from cultural and religional issues. They are seeking, rather than medical or health facility, they are seeking traditional treatment. Is this a challenge in your country? Because they are seeking traditional treatments rather than health professional, and they are coming late when they are metastasis every place. And it is the main challenge for our country. How do you overcome just like these problems, especially health seeking related issue? Thank you.
Well, I will like maybe to answer you in three parts. First one is long-term follow-up about treatment for childhood cancer. So don't be ashamed. Can you imagine that, for example, very, very developed countries in Europe, like Belgium, have not structured follow-up care? It was recognized like 10 or 12 years ago in Europe, and now we are really moving. How we are moving? We have a lot of stakeholders. We have patients and families. We have legal authorities. So it's maybe a power that can go on. Otherwise, besides, usually a doctor is not interested in this point. As you can imagine, no money is here. No drugs, nothing, just a lot of hard work.
Yeah.
So when you think about our countries, for example, in my country, I'm still fighting with health national authorities to include it in the system. The other thing is, we have not structured in Europe. Who will take care of these patients? Is it pediatric oncologists? Most probably not, because these people have grown up. Are there adult oncologists? They don't want to do that, because when you look at the cancer in general population, 98% are adult cancers, 1 or 2% pediatric cancers. What does this mean? That adult oncologists are overwhelmed with adult cancer patients. When you look at the general practitioner or family physician, I should say, defend them, they don't have a lot of time to take care about this subpopulation. So the solution is so-called long-term effects clinics, which is a process to go on. About the other question, maybe maybe I have 2 points. One is childhood cancer is actually biologically aggressive neoplasm. That means that more than 2/3 of patients at diagnosis have a spread or metastatic disease. It is for leukemia, which is 1/3. It is for brain tumors. When you look at the primary care, they are very rare. They don't think about it. So it is a kind maybe of overall problem. The other thing is about traditional medicine. Of course, not as far as in your country, but it is written, it is documented that parents of the patients in 80% of cases use so-called CAM, complementary and alternative medicine. So it's not a big deal that they took it as a kind of additional medicine. The problem is that very, very, very small minority that opts only for traditional medicine. Thank you.
Thank you, doctor. Thank you.
Thank you.
You can hear my voice?
Yes, you can go with slowly, madam. Yes, you
Doctor,
can.
you can hear my voice?
Yes.
Yeah. So last week I was just online in BMT program annual meeting, 47 annual meeting. And I noticed very nice idea. I would like to ask if your organization follow this idea by have like from the donor or the parent of the patient who are oncology patient or even patient who receive those treatment, they make for them like patient advocacy group. Like they can be in the meeting with the doctor and nurses and they speak about what their struggle, how would like to be their treatment give to them. Do you have like this group to empower the patient and increase the quality and safety of the patient and understanding of that disease and therapy?
I will respond to what I heard, because I hear a kind of a double voice. So maybe it's something with my computer. Yes, we have supportive groups, and of course, everybody is welcome. What we face the problem is that not a lot of professionals are interested in this. So for example, PanCare, as I told you, it is pan-European network. It's not a group. We have twice a year regular, now they are online, but they were really in person. So they were contact meetings that actually we tried to managed in a number of cases, a lot of people from different fields. So we have psychologists, social workers, a lot of patients, a lot of parents, actual patients and ex-patients, and all kinds of professionals. So yes, the answer is yes.
Thank you.
Thank you.
Yes. Any further questions to Dr. Jelena Rogan? Just if you have any questions, you can text in chat box. We'll be asking behalf of you. If you have any problem from your side, just like internet problem. Yeah. Yes, thank you very much, madam. Thank you so much for speaking up in this meeting and providing a unique perspective. Thanks for sharing tips with us. Looking forward to you meet again next time. Now we ask Dr. Safia Oz from Gaziantep from Turkey to start the presentation.
Hello everyone. Is there any technical problem? Can you hear me?
Yes, you can. Just you can start your presentation. Just you
Okay,
can.
thank you very much. Now again, hello everyone. First of all, please give me the introduce myself. I'm from Turkey, Gaziantep. It is the south part of my country. You know, my country has a very strategical importance because of the geographical condition on the world. Now, if you're ready, I want to start my presentation.
Just you can share your PowerPoint presentation through share screen.
Okay, I'm ready to present it.
Yeah, it's fine.
Okay, now effects on metacognition and ruminative thoughts, levels of metacognition training, or in brief, the MCT given to measure depression patients. You know, PhD lecturer, Faculty of Science, University of Gaziantep, Professor, PhD, Faculty of Health Science, University of Gaziantep, Safiye Özgüç, and Derya Tanrıverdi. Depression is a common mental health disorder that is leading the cause of disability and premature death worldwide, affecting all age groups and all areas of life. The next one, being one of the 5 leading causes of life years lost with disability and causing premature deaths, it affects almost all societies in the world and increases the global disease burden. That is mean depression can be seen all around the world, all different countries. Such has different problems, social, economical, educational, maybe. The other one is, it is known that a number of factors have played a role in the progress of major depressive disorder, which has affected more than 3 million people in the world. That is a very high, huge people around the world. According to the cognitive theory developed by Beck, depression is essentially a cognitive disorder. Individuals who are susceptible to depression have negative notions for A, themselves, and the second, future and the outside world that have taken place since the first years of life. These negative notions first cause negative judgments, then negative thoughts, and finally negative attitudes. Actually, there is a hierarchical system. First, person can damage their own selves and their maybe family, their daily life. The individual initially perceives and thinks the negative aspects of any situation. The cognitive approach focuses on the content of thoughts rather than cognitive processes in the treatment of depression. However, in recent years, this approach has been interpreted as a limited understanding. Actually, there is a Okay. As an extension of this, emphasized are the importance of metacognitions that focus on the relationship between the individual's maladaptive cognitive strategies and thought control on emotions and behaviors. Metacognition is not only one's thought about their thoughts, but also their thought about how emotions and the control over them are determined. In the metacognitive approach, the individual's cognitive processes are emphasized apart from the cognitive content. Research indicates that metacognitive beliefs are related to depressive rumination, and negative beliefs about rumination may mediate the relationship between rumination and depression. Purpose of the study. This study was conducted in order to determine the effect on metacognition and ruminative thinking levels of the DMCT given to depression patients. The next one is, now we used some different methods. The study is carried out in the pre-test, post-test, and randomized experimental design to detect effect of metacognitive training applied on metacognition and ruminative thought levels. Total of 62 patients diagnosed with depression, including 32 experimental and 30 control groups, composed the sample of the study. The data were collected by personal information form, personal information form, metacognition questionnaire, and the last one, ruminative thought style questionnaire. Metacognition questionnaire 30. The questionnaire was developed by Cartwright, Hatton, and Wells. The adaptation study of the MCQ 30 to Turkish was done by Tosun and Irak. The questionnaire is answered on a 4-point Likert type rating scale. The scores to be obtained from the questionnaire range from 30 to 120, and a higher score indicates an increase in pathological metacognitive activity. Items in the MCQ 30 are divided into 5 factors. These are: the first one, positive beliefs; second, uncontrollability and danger; third one is cognitive confidence; the fourth one, the need to be controlled thoughts; and the last one, the cognitive self-consciousness. Cronbach-Alpha reliability coefficient of MCQ in the study was alpha equal 0.88. Ruminative thought style questionnaire. The questionnaire was developed by Brinker and Dozos. Its Turkish validity and reliability study was conducted by Karatepe. This questionnaire consists of 20 items to measure ruminative behavior. In the 7-point Likert type questionnaire, people can score between 1 and 7. The Cronbach-Alpha reliability coefficient of the scale in the study was alpha equal 0.86 for the pretest and alpha equal 0.93 for the post-test. Metacognition training was applied once a week as a group training as a total of 8 sessions. Inclusion criteria in the study: volunteering to participate in the study, residing in the city center, not having a situation preventing communication, being in the age range of 18 from 18 to 65, being outpatient follow-up with a diagnosis of depression according to DSM-5 criteria, receiving depression treatment for at least 6 months, being literate, not being included in any metacognition training program for the disorder for the last 5 years. Exclusion criteria from the study: those who are diagnosed with another comorbid mental illness, patients with mental retardation or dementia that makes cooperation impossible, illiterate ones, patients who do not consent to interview inpatients. The next one is, in the first interview with the patients in the experimental group, they were informed about the training, and the training days and hours were determined. Then metacognition training consisting of 8 modules was applied to the patients in the experimental group once a week in 2 modules. Each session of metacognition training was applied as from 45 to 60 minutes. The sessions consisted of an average of 3 or 6 people and were conducted as group training. The next is, before starting the research, written and verbal permissions were received from the research center. In order to conduct the study, an approval was obtained from the Clinical Research Ethics Committee of a university. During the data collection, individuals signed informed consent form for the study. The principle of respect for autonomy was followed by stating that they are free to decide whether to participate in the study or not, and leave whenever they want, even after participating in the study. And the principle of confidentiality and protection of confidentiality was followed by stating to the patients participating in the study that their information would be kept private. The next one is metacognition training in the treatment of depression. Metacognition training in depression has been developed as an easy-to-apply group intervention program. The purpose of metacognitive training is to reduce the severity of depressive symptoms by changing the patient's cognitive biases with a metacognitive perspective. And the results: when the patients in the experimental and control groups were compared in terms of socio-demographic characteristics such as age, gender, educational or marriage status, difference between the experimental and control groups was not found to be statistically significant. In terms of their introductory characteristic, and both groups were homogeneous in terms of these characteristics. Here are some numerical information. Intergroup comparison of MCQ and subdimensions with RTSQ pre-test and post-test mean scores of experimental and control groups. Now here are the information related to the previous chart. The difference between the mean scores of both metacognition questionnaire and the ruminative thought styles questionnaire in the pretest between the experimental and control groups wasn't found statistically significant. It was found that both groups were similar in terms of metacognitive characteristics. Are you with me?
Yes, yes, you can continue, madam.
Oh, okay, I'm sorry. It was found that both groups were similar in terms of metacognitive characteristics and ruminative thought styles. In addition, there was no significant difference between the pretest mean scores of the metacognition questionnaire sub-dimensions of the experimental and control groups. Both groups were found to be homogeneous in terms of metacognition characteristics sub-dimensions. When the metacognition questionnaire post-test mean scores were compared, it was seen that the MCQ mean scores of the experimental group were significantly lower than the control group. There was a significant difference between the groups in the metacognition questionnaire post-test mean scores. Post-test mean score of the ruminative thought styles questionnaire was found to be significantly lower than the control group. In addition, in the post-test mean scores of the ruminative thought styles questionnaire, a significant difference was found compared to the pretest. The mean scores of the metacognition questionnaire subdimensions decreased in the post-test compared to the pretest, and the difference between the total mean scores of cognitive self-consciousness and the need for control among these subdimensions is statistically significant. Here is a chart. Okay, 1 second. The in-group comparison of MCQ pretest and post-test with RTSQ mean scores of experimental and control groups. Here is experimental groups and the last control groups. There are some numerical information, and here are detailed information, the previous chart. Metacognition questionnaire mean score of the patients in the experimental group was lower in the post-test compared to the pretest, and the difference was statistically significant. Similarly, in the in-group comparison of the numerative thought style questionnaire, it was found that the difference between the pretest and post-test mean scores was statistically significant. In the in-group comparison of metacognition questionnaire subdimensions of the patients in the experimental group, the mean scores of all subdimensions decreased in the post-test compared to the pretest, and the decrease in all subdimensions except the cognitive self-consciousness subdimension was statistically significant. Now, as a result, conclusion, metacognitive training has been found to be effective in treating depression. It has been determined that metacognitive training is effective in decreasing the pathological metacognitions and ruminative thought levels of the patients. In the treatment of depression, it is recommended that metacognitive training be considered as a component of depression treatment. And that's all. Thank you very much for your attention. Thank you very much for your participation. If you have any questions, I am ready to answer it related to my topic. Are you hear me? Are you with me? Can you hear me? Is there any technical problem?
No problem,
Yes.
I hear you.
Okay, that's all. I think if you don't say or ask any question, that's all for me. Thank you very much for your attention, and I am honored to be here with you. This is the first time my online presentation, so thank you very much. Please forgive me if there are any problem related to my accent or my language.
Hello. Yes, yes. Hello?
Sorry, excuse me, sir.
Yes, yes. Just
I'm here. I'm listening.
Yes,
Yeah.
Yes, we have small technical problem. Any questions? Any questions to Dr. Sophia? Any questions? Yes, thank you very much, madam. Thank you very much for speaking up in this meeting.
Thank you very much for your participation. I am honored to be here.
Yes. On behalf of Organizing Committee member of Nursing Education, we want to thank you for instant presentation. Looking forward to meet again next time. Yes. Now we ask Dr. Mohammed Shaban from Health Point Hospital from UAE to join the event and start presentation. Yeah, Dr. Shaban, you can start your presentation. Hello. Hello, Dr. Shaban. Do you hear me? My voice? Just be.
Good morning. How are you?
Yes, yes. Thank you.
Hello, can you hear me?
Yes, sir. You can continue your talk.
Yes. Hello, is it clear for everyone?
Yes, sir. Just you can start sharing your PPT.
Okay, good. Okay, let me start sharing. Okay, where is it? I'm here right now. We can go ahead. Here, I'll go back. It will be here. So, can you see my screen? I share it.
Yes, sir. Just you can enlarge it.
Enlarge it?
Yes.
Oh, sure. Rejoice.
It's fine, sir. But okay. Yeah, it's fine.
This is more working like this, but can I make it in that way? So at least I will be able to.
Okay, it's just you can adjust it according to your.
Okay, for any audience, if they have anything, please let me know.
Yes, just you can start.
Okay, Bismillah ar-Rahman ar-Rahim. Good afternoon, everyone, or good evening, or good morning, according to your time. It is my pleasure to meet you. My name is Mohammed Shaban. I'm the clinical educator, and I'm the head of the education department in the Health Point Hospital. It is my pleasure to meet you. Actually, I'm starting on this online lectures since 1 year or 1 year plus right now. So because once we hearing about the COVID, immediately we go from the like actual training to the like online training, but in the same time we're still doing the actual training or face-to-face training for some practical practical purposes, for example, new practice or new knowledge. Okay, but like for the general online, for the general knowledge or sharing the ideas or sharing topics, we go for the online. So it is my pleasure to meet you. We will start today my topic with something that currently now all of the humanity they need it. It is not only for the medical health people or for the healthcare providers or for the patient. No, for I believe for everyone they need right now, and something they call an emotional intelligence during COVID-19. So I will talk generally about the emotional intelligence, then I will go specifically for the emotional intelligence for during the COVID-19 or during the pandemic. Just keep in your mind one important thing. I will rush a little bit because they told me I have only 20 minutes. So I will rush a little bit. So feel free later on. This is like I try to cut how much I can to adjust or according to the time limit I have. But later on, if you need any further my big lecture, feel free. I will send it to me. Send to me through the chats or through the email. Immediately, I will send it to you, plus the references that I got it from. So, welcome everyone. My objective for today: identify emotional intelligence, know the difference between the emotional intelligence and the emotional content, and learn how to use assertive communication to express your needs and feelings appropriately. So, if we will come immediately for the definition, it is easy and simple. So the ability to understand the needs and feelings for oneself and the others people, manage our own feelings, responding to the others in appropriate way. It is kind of the intelligent, but like here, if we will come and see what it is, this kind of the intelligent, it will be socializing intelligent. So that means it is my intelligent, the one that I grow up with or that I born with. Okay, it is the same, but the emotional intelligence, it is to understand the other's feelings and working according to that. So this is the way that the people they will love to deal with. Right now we will come and see the major differences between them. Then after that we will go and see why it is crucial, I can say it, during the like working environment. Let's see right now the emotional intelligence, which they call it also emotional content, like it is kind of that emotional intelligence and personality. So if we will see it right now, the comparison between them, intelligent quotient, which it is not change and stable over the lifetime. And the personality also, it is doesn't change and stable. But the emotional intelligence, it is flexible and it will be able to change. So right now, I will understand that for me, I can be flexible in my emotional with the others during or particularly in the working environment, and I can work according to my emotions or feelings toward the others and understanding the others' emotions and adapt for serving the working place. Let's see right now why it is an important. As what we can see here right now. So, sorry, the screen, it is a little bit. Okay, so 90%, why emotional intelligence, it is important. So 90% of the top performers have a high emotional intelligence. And emotional intelligence or emotional content, it is responsible for 58% of your job performance. And the people with high emotional intelligence make more than 29,000 more annually than their low EQ colleagues. So that I understand from here, it is really an important thing that to have. And one of the things that I was reviewed before 3 days of the conference, I found through a resource in the LinkedIn, okay, one of their courses as well. They say like it is about 75 to 85% of the people who are really more successful in their work, they are depending on their emotional intelligence rather than their their IQ, the natural IQ. So it is really an important thing. It is really a crucial thing to have everyone. Now, let's go ahead and see here. So what is the advantage for strong emotional intelligence? Deeper personal relationship, a great adaptability, increase a personal insight, great influencing of the others, fewer impulsive decisions, reduce stress, improving social skills, increasing confidence, and set of the skills that you can use to draw the best from yourself and the others. And we can easily find a big example about that through the if you will see the people who's talking or used to talk on TED, talk, or the people, they are the celebrities, they told you like we are like a normal people, like, but we understanding how the working environment, how the things are going through, and we work through according to that. So this is kind of high emotional intelligence. Right now, how to comparing those high, we will come in details. So so the three component of emotional intelligence, which it is the awareness of one's own emotion. I need to understand my own emotion. Then the ability to express one's emotion appropriately. Not all of our emotions it is good. Many of our emotion it is like mixed with the something that we deserve appreciate and something that we deserve blaming. So it how I will be ability to adapt with that. And third thing, the capacity of the channels emotional into the pursuit of the whole worthwhile objective. Now, if we will see of that, so there is here something they call personal competence and social competence. Okay, what I see and what I do. What I can see, it is self-awareness. What can I do? It is self-management. What the social competence, which is social awareness, what also they can do, it is relationship management. Let's go in details right now. 4 skills of the emotional intelligence. We will start immediately with the first one, which it is self-awareness, which it is personal competence, as what we mentioned earlier. So it is the ability to accurately perceive your own emotions, stay aware about your own emotion, and then as they happen, keep on the top of how you tend to respond to specific situation on people. And here I quote one of the sentences of the Mr. Thomas Keller: the greatest of faults is to be conscious of none. So right now, I understand that I have a short temper. For example, I have a short temper for if I were repeating my order twice or thrice. So this is, I understand this one. So I can identify my problem right now. I have a problem. I'm not a perfect. I know that. Okay. And another example, if, for example, if I am talking and somebody will cut my speech, also I can be angry. This is something bad. Why? Because the people, they could finding a mistake on what I am saying, or like they can't find something not correct, and they need to immediately correct it because you are talking in public or you are talking in the meeting in an important subject or an important topic. So the people, they can understand and they can feel you that there's something wrong, and you must feel that things for yourself before the others. So improving the self-awareness, how it will be happening: know ourselves, track and backtrack your emotion in a difficult conversation or a meeting, as what I mentioned. Use peer sharing, peers or the supervisor. No shame to us, guys. We grow, we learn every day until we die. We are still learning. We are not perfect. We are humans. Correct mistakes. So at least whenever that I'm asking somebody about his opinion, this is not something to put me down. This is something to put me greater. Why? Because I can judge myself, but I cannot control the other's mind to judge me. Okay. And on your action, take a full responsibility for what you are say and do. So now self-management, it is the ability to use the awareness of your emotional to say a flexible and positively directed of your behavior, managing your emotional reaction to all situation and people. Plato, he say the first and the best victory is to conquer self. Now, we back to the same examples. Now, I feel that I tense, I'm not feeling happy. I will say, guys, would you please keep the side talking later on after finishing the meeting? Or guys, is it my order not clear, so you are asking me to repeat? Let me know, so like at least I will telling you in another way. So at least try to self-managing what you say, and like try to find out if this one maybe you are wrong. So I will give myself other chance also for a better action for the others. Now, emotional trigger. What are the triggers that make you want to blow an emotional gasket? Now, I want to ask everyone, what do you think, guys? What do you think? The things that it is make you like angry or make you what it is trigger your emotional? Hello, can you hear me?
Yes, sir, you can.
Yeah. What do you think, guys? What are the things make you trigger your emotions? You can put it on the chat if you like.
Yes. What are the triggers that make you want to blow an emotional?
Like,
yes,
like crowded or like.
Answer?
Yes, Hanan.
If somebody no respects your idea or think down of it.
Agree, totally agree. What else? Not appreciated your efforts as well?
Yes, especially in education. If I am a student or a nurse and somebody not appreciated my offer, this just gets me emotional because they think everybody in the same level. Everybody has their own personal ability to learn and time. Somebody fast learner, somebody slow, somebody need to repeat 5 times. And if you are as a nurse educator don't know this, you will have some issue with your patient or student.
Okay. Ladies and gentlemen, let me tell you something important right now. For me and like Hanan, we are educators. I know also there is Anas and there is other people also, and some of the attendants also, they are educators or working in the education department, or somehow they are managing the education. Let me tell you something right now. During the pandemic, okay, usually according to the like hello, can you hear me? Yes. Okay. During the pandemic, each educator at least trained thousands of people. Are you agree, Hanan? Are you agree, other educators as well? Do you agree?
Yes.
Yes.
Definitely. Okay. Right now, what do you think about those people? Or not all of us, we have the same IQ level. Not all of us, not all of the education, not all of the nurses or healthcare providers, they are in the same IQ. So that means sometimes you need to repeat twice, thrice, or more. Sometimes you need to repeating your email 6 or 7 times. Sometimes you need to repeating the same explanation about the procedure 100 times. Okay, and the mistakes it will be happen. So that means if we don't have an emotional intelligence, we will increasing the stress above them. Why? Because they are facing frontliner, the patient or the COVID patient. So you can believe everyone he have an ideas. I will carry this virus to my house. I will be affected. My kids, my husband, my wife, or. So you can believe right now how they are feeling. Back to the topic. Right now, so what I can find right now here, it is like emotional red flag and the breakdown. So angry, door slamming, email, letter bomb. So those kind of the things we can find in a daily practice. Why the people they are expressing how they are like feeling and anger or upset through those things. Passive aggressive behavior, holding grudges and getting even withdrawal and isolation. A lot every day we can even seeing those things. Right now we'll come back for the social. So it is social awareness, which it is level number 3. It is ability to accurately pick up an emotional in others people, understand what it is really going on, and understand what it is the others people are thinking and feeling, even if you don't feel the same way. One of the time that I was giving a training, I can see a lot of people or the majority of the attendees, okay, they are in stress. Okay, which it is obviously for them they are in stress. So like whenever that I'm giving my training, I train by practice. Okay, come on guys, let's do this one. Immediately I will show for them. But the people, they are in stress, so they cannot get what you want to say for them. So I can realize that's one from their hand movement, okay, from their eyes, keep right and left, from they are putting their hands in that way, or they are keeping on mobile for a second, then back, then second, then back. So this is kind of the clear thing that they are in stress. So I hold the training for a while. I was asking them, come on guys, let's talk frankly, what's going on? So they told us, like, we are right now, we are in stress because we don't have, for example, N95. I believe that at the beginning of the pandemic, majority of the hospitals don't have. But for us, alhamdulillah, we have, and like it is fine. But and somehow they are like, some faces are small and some faces are big, so like it is not fitting for them 100% until during that time. So like we emailing the management, and the management responding fast, and the same day they're bringing the mask, and everything was excellent. So like you can realizing those things from the people. And number 4, so the empathy, social. So before that, so social awareness of require and empathy. Empathy, it is ability to see the world from the another point of the view, and identify and understand another situations, feelings, and motivation. So improving the social awareness, spend an extra time observing, asking, and listening. And this is one important thing for the leaders and the educators, to be close to their team. I believe majority of the people right now who is with us on the meeting, or the speakers, they are holding positions in their institute. So this is kind of the thing that they are need to follow. Maintaining an eye contact, which it is a lot of people they can understand, and reading your eyes. I believe this is one of the greatest things that everyone can do it. Give the speaker your full attention, at least keep an eye and facing him face to face. Play and summarize. Try on their shoes. Put yourself in their place. Put yourself. Keep thinking. If I were you, what I will do. So think in that way. Suspending your judgment. Don't judge. And emotional intelligence, there is no judge. There is help, assist, but there is no judge. Read body language, as what example I told you about it, and decipher emotions in a speech too. Then relationship management, ability to use the awareness of your emotional of the others to manage interacting successfully, ensure a clear communication and effective handling of conflict. So improving your relationship, seek to build a high quality and high trust relationship. Try to discover what role of the emotions are you playing, and if you are sense of tension or of the other emotional reaction in your personal body language or speech, ask a question to seek to understand. Be quick to settle disputes, differences of opinion, and misunderstanding. Right now, what skills do employers want? Right now, all of us, we are employees. What do employers want from us? Good communication, listen and oral communication. Resilience. When the others talk, let us listen to them. Personal management. Okay, self-control and self-confidence. Motivating, team player, and conflict management. There is a sign of the high emotional intelligence, which it is handling a criticism without denial, without blame, without any excuses. Right now, any leader, really, guys, really, with all of the experience that we have right now in this career, the leaders, they will not blaming. Okay, they will find for you an excuses. They will find for you a chance, or they will find for you why you are did this one. They will not deny their responsibility. Okay, I make a mistake. This is my own action right now. I need to handle what I'm doing. Okay, and the excuses, that's it. Like, what happened, it is happening. No excuses, no blaming. Go ahead and let's find out what we can do. So, open-minded for me as a for the sign of the high emotional intelligence, open-minded. I have an idea, but the others also, they have an idea. I need to listen for them and listen carefully for them. Okay, if they have a good ideas, always think that, guys, One brain will work well, two brains will work very well, three brains and group of the brains will working excellent. So keep in your mind this one, keep open-minded. Okay, be a good listener. Good listener will help you to understand a 60% to 80% of the message. Okay, and you analyzing, then it will be able for you to give the correct answers. Okay, and don't sugarcoat the truth. Okay, my wife, it is not a bakery, so just be the, I don't sugarcoat anything. If you ask for my opinion, I'm going to tell you the truth, not what you want to hear. Okay, be straight. Now, we are educators. If you are not willing doing things well, or if you are not doing the procedure well, don't use like to say no, you don't know anything, or don't say you are great. No. Say, I think or I believe right now you need to improving this part of your skills. Let's go ahead. He might feeling not happy of what it is, what it's happening, but at least our patients, they are safe, and which it is very, very important. And this is what we need always to save. Okay, and apologize when wrong. All of us are human and all of us make mistakes. Just if you find yourself doing something not correct, say I'm sorry. Okay, sign of low IQ. If you'll have low degree of IQ, no self-awareness, no empathy, oblivious to own emotions and emotions to the others. So Paul in sheep, son of low IQ, Paul in China shop. Do you know that, guys? Paul in China shop. Hello.
Yes, sir.
Guys, Paul in China shop. That means that this Paul, he's like in China shop, which it is crowded of the people. They leave him, okay, and he destroy all of the place. All of the place. Why? Because he is an anger, and finally he's a Paul. Okay, so he wants to destroy everything, like what is happening in the things in the Spain and their festivals. Okay, so this is the same Paul. They put it there, and it is destroying everything. So the example of that, whenever that you're finding an angry employees, he is there, he can destroy everything, all of the relationship that he built it for years and years. Okay, in one situation he can destroy that. So this is a sign of low IQ, emotional intelligence, lashes out. So he will say a lot of the things which is not correct, which it is just to releasing his stress or just to releasing what he feel. Okay. Also find others to blame for the most of the issues or his team, and this is what the things like we pray to God to finishing from the institute or for the hospitals or wherever, that it is really right now not the time of blaming, it is right now time of working together to improving the things. So 5 skills to develop emotional intelligence: rapidly reduce stress using your character, so to influencing the others. Emotional awareness, as what we say about the 4th step. Non-verbal communication. Okay, use gestures, it will be helping a lot. Use humors and the play, it is like a big rule really. Resolve a conflict positively. If you have a conflict, sit together, listen him until the end, be kind, be understandable person, and take an initiative. Don't wait the things to be complicated. So right now we will talking about the things during the COVID-19 emotional intelligence. So why it is important? So the coronavirus pandemic, it is proving to be the greatest test of the emotional intelligence in the generation. As the axiom goes, when the time it is performance has come, the time of the preparation has passed. So the high IQ leader, okay, as what you can see there in the poster. Then we have also working flexibility. One of the things that it is really helping the people right now to using, which it is working flexibility, as what we can see right now. Before, majority of the employees, they are in their institution and working there. Right now, during the COVID-19, the working is like more flexible, so we can see the difference between the percentage there, who's working from home, who have a schedule, and who's working in the institute. We can seeing a big differences in the numbers. Okay, now for us as an educators, what it is our rule right now. So lead by example through the influences are not through the positions of power. Right now, for me, I'm an educator. I use for all of the things of the training. Okay, alhamdulillah, by the God's grace, I got the trust of my leaders, and I'm not train only my institute. I train another 7 institute or 7 hospitals right now in Abu Dhabi, Al Ain, and some other branches as well. Okay, now when I train the others, I train them here in the venue. Okay, after that I went them to the site of practice. Like for example, for swabbing, I was fully wearing full PPE, and I go ahead with them and to show for them how to do the swabbing, observing them for the first or second or third week. Then after that I leave them with their team leaders. This is one of the examples. By the vaccine, I train them. Then I'm the first one who got the vaccine. Okay, in the hospital. Why? Because finally this is kind of role model. If you want to be really like a kind of influencing the others, you should starting with yourself. Educating nursing manager and the staff nurses about the emotional intelligence and the tool of they can use it. Alhamdulillah, I started also with this one in my institute, and I shared it with the nursing team leaders, nursing managers, and nursing office. So alhamdulillah, we got a great job with that. And guess what, guys? Like the people right now, usually the people, they will quit the work because of the stress. Alhamdulillah, no one resigned from our institute. And even though like we receive a lot of great feedback from the others who want to join our hospitals, because we are understanding the nurses. Okay, develop the list of the staff who's a clinical leadership characteristic that they would like to be a focus on the building on the others, such as a care, compassion, courage, commitment, communication, and competency. Guys, we know our employees, and whenever that you are really a good team leader or educator, you can identify this is a smart guy, this is like he can catch up fast, this is a person who is, excuse me.
Yes, sir.
Somebody take the screen from me.
Oh my God. Yes, yes, sir. Just you can start again, sir.
Okay, can you see?
Yes, sir.
Okay, organize workshop and emotional intelligence, encourages staff to remaining aware of their own emotional well-being and that. And this one, with this one also, we make like a schedule, weekly a schedule with our psychologist in our hospital. Plus we open a free and confidential consultation with our nursing leaders and with our psychologists as well. So like we help them in the more way. So 5 tips of the leading with the emotional intelligence during the pandemic. First, balance your thinking and feeling brain. Don't allow your emotions to hijack your behavior. As a sport of psychologist Stan Bisham, he said, if your emotions are in charge, you will never fully know yourself and you will never reach your potential in a performance environment. So we can see right now how we will balancing our things and feeling. If that doesn't mean that if I will be angry, I need to shout. No, guys. We have guys who give us a brain to balance the things and to control. So for that reason, we are an adult. For that reason, we are calling something they call a professional. Professional people, they know how to adjust or work as a professional. Okay. Second, create a psychology safety, create a psychological safety in the organization, which as a mediation variable accelerates performance. So we can see right now the safety and the danger one. So like comfort admitting mistakes versus fear of admitting mistake, learning from failure, blaming others, everyone openly shares idea, It is likely to share different views, and this one, because I believe, because the people of disrespect. Okay, and finally, better innovation and decision making, common knowledge effect. Third, welcome dissent. I'm not the top in the life, so there is other opinion which can be better than me. So like they are welcome. Why not? So it is your job to stimulantly increasing intellectual friction and decreasing social friction. You need to diversity of the thought, constructive dissent, and create creative operation to solve problem and find a solution. Then stop ridiculous, and this is one of the important thing, guys. Sometimes conflict can be happen, but without ridicule. So that I mean, no disrespect. For me, this is kind of disrespect. We need to stop totally. Why? Because this one will make us a negative work environment, which will leading everyone that a lot of mistakes and make a lot of employees go and run away from this institute. So it is a fear of inducing behavior that shut people down. It is triggered to self-consoling instinct, which it is cause people to retreat into mood of personal risk management. So I have a personal risk management. I will not sharing my ideas. No, not in that way. Why? Because I'm thinking about the others. They can laughing on me. No, no, it is not in that way. So stop it immediately. As a leader, you need to identify those toxic people who might like destroy all of the hard working that you built in the personality and professional grow up for your employees by their ridicule. So like start immediately to stop this one, identify those people, keep them away. And finally, be nice and accepting mistake. Again, all of us are human and all of us make mistake. Ask yourself, are you personally prepared to accepting the other mistakes based on the humanity and learning mindset of the behavior develop? So what? I can make a mistake. I need to be nice with them. This is an extraordinary situations that it is happening right now. This is something not every day happening in the pandemic. So at least I need to be nice with them, understand their feeling, and finally they are human. They can make mistakes, but at least with a good training, with good understanding, with a frequent meeting, with good listening skills, and with a productive working environment. Okay, so all of these things can be working together and preventing the mistakes. Thank you so much. Any questions?
Yes, any questions? Any questions? You can text here in chat box. We'll be asking you. No questions, sir.
Yes. Okay, it's my pleasure to meet you guys, all of you. Thank you so much. Thank you for your good listening skills. Again, just one important thing that I want to highlight it. Usually those emotional intelligence, we giving more and more examples. And this one, it is sometimes we are taking 2 or 3 days of workshops. So I try my best to minimize it and squeezing as much as I can to make the things like able to catch why it is very important during the pandemic. Thank you so much. It's my pleasure to meet you all. Thank you.
Yes, thank you so much, sir. Thank you very much for speaking up in this meeting and providing a unique perspective. Thanks for sharing your tips with us. Looking forward to meet again next time.
Inshallah.
Yes. So now we ask Dr. Pirbox Jukio from People's University of Medical and Health Science for Women from Pakistan to join the event and start presentation.
Thank you, sir. Thank you very much. I'm starting. Bismillahirrahmanirrahim. And good evening from Pakistan to every one of you. And my name is Pirbox Jukio. I am from Pakistan, a Sindh province and a rural area of Sindh province. I belong to People's University of Medical and Sciences for Women, Pakistan. Today, my talk is about my Current study, revitalizing broken dreams, first year female student nurses' perception regarding their decision to join nursing as a career. From the topic, you may have thought that this is a very old topic, but I assure you that this is a very new topic in context of our region,
Excuse me,
our rural.
the kid the behind you is disturbing you. Just ask him to go.
No, go. Oh, yes. Sorry. My little daughter.
Yes.
Okay. ठीक है. May you have thought that this is an old topic, but going from Pakistan's perspective view and living in a rural area of Pakistan where nursing is very new, then this topic is very important. For this, I have conducted a qualitative study. Introduction is this, that the candidates for higher education pick nursing as a career, although they might know its low professional status in the society. From Pakistani perspective, nursing is not regarded as a suitable as a socially proper image holder profession. But even the enrollment in the nursing program in Pakistan in rural areas increasing. One reason maybe there is that there is a job security. In our country, in our regions, there is a there is a lot of number of people jobless, and they are now finding nursing as their alternative to join as a job, secure them financially. Second reason is joining nursing, that the peoples may not meet their primary objectives, means they are wanting to go in any other field, but they failed and joined nursing. Admission nursing was supposed to be easy, although it is a low pay job in Pakistan and extensive workload. There are maximum job opportunities. The public image of nursing in a society is very low, and it detracts individuals to join nursing. The professional nursing image in Pakistani perspective is documented is very poor, and a lack of public acknowledgement, appreciation for profession, poor working conditions, lack of respect from doctors, and limited autonomy for role performance, according job related special could be the reason for low social image of nurses. Keeping in mind those things, those concepts in our society, I decided to conduct a research that how to improve nursing image and nursing enrollment in Pakistan. Therefore, I conducted a qualitative study with 4-year bachelor nursing students. What was the methodology of my research? It was a qualitative research to explore nursing students' perception regarding their decision to join nursing as a career. Semi-structured 3 open-ended questions were used. The questions were: why did you decide to take admission in the undergraduate BS nursing program? How do you feel now as a nursing student after securing admission here? And tell me the reason you will leave nursing if there is another opportunity from any other university or program. Then the data collection method was focus group discussion. 2 focus group discussion. Each focus group discussion included 8 members, 8 students, 8 participants. And students were newly enrolled first year BSN students of 2018-19 batch. The study was conducted at People's University, and the ethical review committee later approval was get from the ethical review committee of People's University of Medical and Health Sciences. Informed consent was taken. Objective of the study were told to all the students, all the participants, and they were told to express their feelings. Some of the focus group discussion rules were also told to them. Then the principal investigator started data collection, moderating the focus group discussion. See, okay. We analyze data through thematic analysis, in which we write down, first of all, we write down, took the notes of the interviews, focus group discussion, then write it on a paper, transcripts, and then read it. All the authors read it carefully and developed themes. What were the results? Results was that there was four constructs or four themes comes out of this, and one theme is main theme. Four themes are broken dreams. Second is an opportunity to continue education. Third theme is to be a nursing student. And fourth is nursing is my destiny. All those themes combine and make a main theme, that the revitalizing broken dreams. Now I am simply going to explain how we reached at the final conclusion that this is the revitalizing of broken dreams. Okay, broken dreams. First of all, the students told that their own wishes and their parents, father and mother's wishes were that you will become a doctor. You will become a doctor. And they appeared in admission test for MBBS doctors, but they could not secure their admission in MBBS. Therefore, their dreams were broken. They were disappointed. They were disheartened. Their parents' wishes were not complete. Therefore, it was very big barrier in their life. But then they saw advertising of BS nursing in different newspaper, and their father and mothers encouraged them that if you are not selected in MBBS, then you may try for nursing, because it is also a healthcare profession. And nurses are also a doctor. Doctors also treat patients, and nurses also care patients. So this is a humanistic interaction. Therefore, they find this opportunity as a continue to education. And second thing was there, that in Pakistani scenario, most of the girls, after doing their 12 or intermediate, don't try to continue their education, and they are married. So their the girls' education level, the literacy level is very low. But from this perspective, we came to know that there are students.
I think the kid is disturbing you, sir.
Oh, sorry, my daughter. Sorry, little daughter. Okay, okay. So what the participants told, that they developed encouragement to come out. They did not stay at home, but they find an opportunity. If they are not going to be MBBS doctors, then they find another opportunity to be to continue their education, and they break this barrier of not to continue education. Third, okay. Third is now how they are feeling, nursing students. They are feeling excited, satisfied. They are thinking that this is a very different place, and they.
Hello.
Yes, and they should work hard to be a good nurse. Now they are happy, excited, satisfied because they have decided to continue their education, and they have thought that this is the best place. This is the best place to continue their education. And as a woman, this is a good opportunity to be self-sufficient in their future prospects. And third one, if they get positions, they rewarded, it will give them self-esteem and increase self-esteem and self confidence. Fourth, our my fourth question was, will you continue nursing education or not? They said no. We will continue nursing education because it is a very encouraging profession, and society should change attitude to the nurses. Teachers are providing them good learning environment, and we are looking is step forward for our success. These four sub themes developed in a main concept of revitalizing broken dreams, because first of all, they have limited educational opportunities, and from limited educational opportunities, they were deserted because they did not secure their wishes, their educational status according to the wishes and their parents. But revitalizing broken dreams or energizing themselves is a concept that they have put themselves once again to continue their education. Sub-theme sheds lights on the parts of wishes constructed on their interest and parent interest to be a doctor. But because and doctors in our society are appreciated and valued, and nurses are not. But nurses have thought that now there is a time to change the perception toward the nursing. And second is theme is an opportunity to continue education with the support of the parents and relatives, because they did not want to discontinue and become a housewife. They want to be a professional nurses. They want to earn on their own. They want to share their responsibility, economical responsibilities after their marriage. So they want to be professionals. And there are many job opportunity in nursing in the country and abroad. So so this is very good that they are continuing their education. And when their feelings are excited, happy to be a nurse, it will be better because it will mold them to be a good person and good nurse. If they think that we are doing nursing because of the pressure, then they may not be a good nurse, because extrinsic motivation is not as good as intrinsic motivation. So from this point of view, excited, happy, we have concluded that they have a good intrinsic motivation to be a nurse, which is very good for therapeutic relationships. And the last but not the least is the to decide that nursing is their destiny. And when they think that nursing is their destiny, then this formal nursing learning, education will improve their maturity, technical skills. If they don't consider nursing as their destiny, then they will not be up to the level of goodness. So personal maturity and emotional growth are achieved through self-awareness. Self-awareness means self-actualization, means it is beyond the physical and security needs of the person. In this way, they may recover from their broken dreams, re-enjoy themselves, and through social development, social support, we can develop a good human nurses. Conclusion, my 3 points. Nursing is a dynamic and growing field in Pakistani context, and especially the remote areas of our country. Remote areas means since remote area, Nawabshah, Sakkar, Larkana, which are away from Karachi. But there was a social image, negative social image prevalent, that nursing is a low category job. Therefore, the increased enrollment and maturity of the students and good learning environment around the corner is proving that the people's and social image toward the nursing is improving, and they must be open to their chance, and nursing is one of them. They should avail chances of nursing. They should not detract from nursing because of only the social image. To improve social image in our context is very important, and we are doing this through this research. There is a need to work for improvement in the current image of nursing among masses at the gross level. Now, next step is our research is that how we can improve nursing image in the public, that parents allow their children with satisfaction and willingness to join nursing as a career. This is the article I have published, we have published, and today I have presented as a thought process, because of in which environment we are working. It is a very underdeveloped environment from educational point of view, and nursing is much neglected in our area. But inshallah ta'ala, we will work for the improvement of nursing image, and nurses will be an autonomous and professionals in the near futures. In Pakistan, government has declared 2020 as a year of nurses. So I hope we will improve with you people's support, because you people are working already, but we are now working this time. So this my effort is must be conceptualized or understood is an effort to improve our nursing image in Pakistan. Thank you very much for your kind listening and listening.
Yes, sir.
Okay.
Yes, it's fine.
Hopefully, I have discussed thoroughly my research paper.
Yes, sir. So, dear participants, just we
Thank
have
you very
shared
much for your
yes, we have shared the PPT of
yes,
the Dr. Jukio. You can share from the chat box. We have sent the PPT.
I have shared, and I have also shared on WhatsApp this PPT.
Yes. Thank you very much, sir. Any questions?
Thank you very much.
Yes. Any questions to Dr. Jukio?
Yes.
Actually, we are getting a disturbance from your side, sir.
Oh, yes. Okay. Thank you. Once again, I am very pleased and thankful to you that you have given me a chance to to share some of my ideas on this forum.
Yes, thank you. Thank you very much, sir. Thank you very much for speaking up in this meeting and providing your, thanks for sharing your tips. It's a general topic. Looking forward to meet again next time.
Oh, thank you very much.
Yes. Now we ask Dr. Mary Estella Bester from Georgia Southern University from USA as one of the keynote speaker of the Day-2 is going to start the presentation.
Good morning, good afternoon, good evening, wherever you are. I'm pleased to be with you. And I'm Estelle. I'm in Georgia, in the US. Please allow me to give a little bit of context, background to this discussion. I'm going to look at some challenges and what we did about those challenges. And then the future, I think nobody has the answer, but I will share that with you. To allow you some context, I started off in Cape Town, South Africa, where I was 20 years. So at that time, we had distance education, we had telematic broadcasts. I moved to Jeddah, Middle East, Saudi Arabia, and there we had quite a number of students who did their education abroad, and I was able to give them support. And then in Statesboro, Georgia, I joined in 2017 with both face-to-face and online classes. In saying this, one would think that with the exposure I had to distance education, online, etc., that it would become easy when we were told to go online. So just over a year ago, we got our first email saying if students or faculty have to go in quarantine, we need to accommodate them. And the requirement to have our syllabus, our course material available in our learning management system. So that seems to be quite an easy job to do, because up to that time, we were in any case asked to put our stuff online. A week after that first announcement came the second announcement. We will not have any face-to-face classes or instruction for 2 weeks. That included one of our spring break weeks. And the announcement, we are moving online. So everything will be online, and I can assure you that at that point in time, I felt like, can I sit on the couch and just let this summer go by? Because I think the reality already kicked in. So it was at that point that I realized technology, it's either going to be a friend or a foe, a challenge or not. And that's when I went into the literature and I found the technology acceptance model, because what I was trying to do, I was trying to find things that could help me, not just to put the actual technology out there for the students, but how can I make it more acceptable for our students? And this technology acceptance model is actually not new. It's already described quite well in 2003, but allow me to look at the things of the ease of use, the perceived usefulness is going to determine the student's attitude. The attitude is going to determine whether the person intends to use that attitude, and that actually will lead to use. So between the actual perceived ease of use and the actual utilization, you can see that there's a long way to go. So everything that then went into my course, I was looking at the TAM to guide me of what I can do to make it easier for my students. And I think the other thing at that point was this quote that I read from Jeffrey Benjamin, in every challenge lives a greater opportunity. And that really was something I put it on my desktop for some time. So what about the learning management systems? Well, we have got, like most of you, whether it's Blackboard, WebCT, Moodle, Canvas, etc. And we have got, my gradebook was working. I've got content modules. It's very easy to share news, emails, items, discussion boards. So actually, the learning management system was supposed to make it very easy for students to go online. However, when we look into the research, it is no news that the use of the LMS is different when you do it online versus face-to-face. And I think that was one of the biggest problems, that people started using it just as a resource repository. I was listening to some students that would tell me, oh, we just downloaded 25 files for one class. Another thing that Holmes and Prito Rodriguez said in 2018, well before the pandemic, was that students and faculty see learning management systems totally differently. And then I realized the other thing, that I assumed at the time when we had to go online that students know very well how to navigate the learning management system. Just to find out that students know how to access their grades, how to put their personal preferences to know when something new is posted. The next thing that dawned on me is what about the web accessibility? Those of you who are from the United States know that everything that goes online is supposed to be compliant to the Americans with Disabilities Act. And I realized that many of my videos, much of the stuff that I post, not necessarily meet these criteria. While this has been something that is emphasized during online courses, we found that in the face-to-face courses, there was less emphasis on the ADA compliance. Now, I don't know how many people would actually participate in this, but this is just one of the things that I have been using. So if there's anybody out there who would be prepared to just sort of put the response in, it's total anonymous. I can't see who answers what. If there's anybody that want to go, you could either just sort of scan the code, or you can actually just go to slido.com, that's the number. And can I ask our meeting coordinator, would you be prepared just to sort of open it and put a response there? Okay, let's then move on. And the other thing that we said is that platforms are very easy to use. And we started off with WebCT, Google Meet, and Zoom. These were all for the online courses. I don't know if you, but we have tried all three of them. Currently, we are also using Zoom, the same platform that we use here today. Now, back to what I've said there about the online access, the platform we use. Two of the things, and I think it's not strange for you, is the difficulty in access with connection. And I think many of us maybe were surprised to realize that people really struggling And then another thing that we realized was there's a lot of competition at home for access. And I want to read this letter. It was actually email I got from a student saying, "Dear Dr. Bester, I apologize for my poor performance on the exam. Both my parents working from home. My father was rushing me to get finished as he had to do a conference call and our internet was not strong enough for both him and me to be online at the same time." And these are just a few of the things that we discovered. Another thing was that all of us told our students, you have to have webcams. You have to be able to access a secure server to be able to do your test. And it wasn't strange that during the COVID epidemic, and this one was published on 9 April last year, that there was a total webcam shortage, and it was actually becoming too expensive to buy. So these were like realities that stopped us from just easy and seamlessly going online. Well, I survived spring. We all survived spring, and we were quite happy about that. And then, just as our spring semester ended, we got the next email to say, well, you know, we're looking for 3 options for fall. Online, hybrid, meaning both online and face-to-face, or fully face-to-face. And then the next one was, but although we want to go face-to-face, we have got COVID caps for our classrooms. And that made us it was mandatory that we could only get some students in the class and then some have to be online. And then when we thought fall coming and that we go back to fully face-to-face, we were told, well, spring 2021, where we're now in, is going to look exactly like fall 2020. So that is when I really started in preparing for fall, saying we need to look at some things of how we can do it better. And the first thing that I was looking at is, how do I get to know my students? And how do my students get to know each other? I think it's not a surprise that part of the isolation of online learning is that students can't get together. And because they can't get together or feel they can't easily get together, is a missing opportunity for that discussion on the learning material. So how I did it then is I decided to go to Flipgrid, and I will just show you something. And I posted a small video. It was 1-minute video on the online, the learning management system of what I would like them to do. And I said, well, I'd like you to just introduce yourself, whatever you are prepared to share with us. Now, those of you who don't know Flipgrid, it's a free software. You just can go to flipgrid.com. You can make your own educator login, and students need to post their videos. The videos maximum 10 minutes, but if you have an activity that's longer than 10 minutes, you just tell them to post 2. The good thing of Flipgrid, other than it's no cost for the educator and for the students, the good thing there is that you can monitor responses before you open it up for other people, for the students to see. And I think the good thing there is that it gives me a feeling of being more comfortable that if there's anything that's unethical or not according to the university standards, then I could block it from becoming available. And the screen you see in front of you relates to, first was the introduction, and although it was not mandatory, 53 of the 56 students did post the introduction. And then I had another activity online about health history. So for those of you who are looking for an easy way to get students to do something, I really recommend this Flipgrid. I also used it where I posted the video for students, for senior students on med-error, and then tell them to identify what the errors were and how they would prevent that type of error. Now, I just blocked out for confidentiality the actual pictures of the student. And this is another thing that I really liked, is because they post videos, it was a way for me to start learning about the students. And here you can see how students started commenting on each other. So somebody, for example, would say, oh, I like to run, I've done athletics. Some would say, oh, I like to drink coffee after class. And then a discussion would follow, and people would say, oh, you know what, I also graduated at high school, etc. I posted this about 3 weeks before the actual course started, in trying to, for the students to start to know each other, and all of them really appreciated this. And by the time the class started, it was really interesting to note that there was already this feeling of we are together. Another good thing about this Flipgrid, and I'm not getting paid to promote Flipgrid, please understand that I just think it's really a neat app out there. The other thing is you can also privately send an email to a student. This particular one was, for example, a student who shared some information about the fact that she was actually new to the country, relatively new, did her freshman year somewhere else. So I would then send a personal email to her and try to relate to the student of where he or she comes from. So with that challenge out of the way, I had another problem, and that was, how do I get my students' perspectives or ideas? Because I'm sure many of you experience this feeling of sitting in front of a screen, nobody have got their webcams on, and you have got no idea of, am I talking above them? Am I talking below them? Do they even know what I'm talking about? Because initially, many of the students, all that they wanted were recorded PowerPoints. So what I then did is to sort of try to encourage them. And here's just the idea for you of how it felt when you just see these people are online, but you're not sure if they are participating or not. One of the things that I tried to do was like to see if somebody would come up with sharing anything else. And I just love this one. This was a photo of a student who shared the bunny outside the room while we were actually having a class. So I think it's very important that while we have a presentation to give, we have got material to share, that we also try to find common things about our students.
No.
Yes. Yes, is there any problem?
No, madam, just you can continue.
Okay. The other thing is, for example, I want to show you here. I just love this photo, and I've got permission from the student to share this photo. And I would react about the company that the student had and how nice the student was watching the lecture with a little doggy. So try to find something, even when you're online, of something to share with the students. Now, I showed you earlier when I tried to have like a Slido a thing to get your opinion. We know there are a lot of polls available. There's some available in Zoom. I like the idea of the word cloud, and that's why I like the slido.com. And then from time to time, I would just sort of put it up and say to the students, like, here it was. Actually, it was the last day before spring break. And I would say, how are you feeling today? And for those who don't know, the word cloud works. The more similar words get in caps. So this is really like just trying to find ways for the students to become more actively involved. My next one was very similar, but how do I get my students more engaged? Now, this one was a very interesting situation. The first thing that I started with was virtual escape rooms. And for those of you who know, it's just sort of putting it on a Google Doc on forms, and they have to answer something correctly to get to the next question. Now, initially, I just started with escape rooms, and then I realized that sometimes you have to offer students something. So I would offer them like 0.2 bonus points for each activity. And it would be surprising how many students then started participating, realizing that bonus points cannot help students to pass a course, but it can help them to improve their grades. The next thing was like group work breakout rooms. Now, in spring, students didn't like it at all. They would actually send me emails and told me that they don't like it, they don't understand it, and just give the PowerPoints and go on. And then like in fall, it really sort of improved, but maybe also because I became more comfortable with breakout rooms. And this is, for example, a document that we did with breakout rooms in the spring. And each group would get a certain number of questions and activities to do. Initially, it was daunting because, as you can see here, at the same time of having a group in class, I would have also breakout rooms. And then the good thing of the breakout rooms is that you can actually go into that particular room and ask the students to give you if they've got any problems, etc. But like by spring this year, I can tell that this technique really works very well. I would have, if we would have been perhaps a different audience, and I think there's one of the lessons that these type of things not necessarily work online, but this would be another thing that I would then ask them, for example, after a breakout room, as part of a type of a debriefing, I would ask them, what problems did you experience in completing this? Another thing that I decided to use more was ebooks. Now, I don't know how many of you use like these various of these ebook apps available. Our students get access to ebooks as part of their payment when they pay their books. Now, just to give you a little bit of example of how we can use it, is like I get the students to follow me, And then the green that you see here highlighted are actually me making those highlights. And then the good thing is that you can add a little note. It could be something you want them to really understand. It can be something that you want them to sort of follow through. It can be even an example of how you can assess a particular thing. Now, ebooks again has been in literature for years and years, but I think the pandemic really created for me an opportunity to say, how do I get students more involved with doing that intense studying of the material instead of just sort of try to learn the PowerPoint. So in going to that, it would be interesting, or would have been interesting to know how many of you actually do use ebooks during your classes. I really would recommend you to start using that. So what about the future? And this basically sums up my journey from last year when COVID started, changing the way we do our business. It's like like my first semester that I tried the breakout rooms and students were very negative, so that didn't work. So then I would just say, so try it again. For example, how do I make that breakout rooms differently, the group work, than in the past of just giving them one question? That brought me to the point of having a shared document where they participate actively and they can see what their colleagues are writing, and then to find that it works. So finding that success. So I do think that when we look at the technology available for us, and I want to go back to the TAM that I started with, is it is unfortunately that one size doesn't fit all. We need to try, we need to see if something happens and successfully, and if not, we must try something else. So in conclusion, what I tried to show you that the technology is out there, but we need to be careful just to try this new technology and not look critically at what impact it has. If the student doesn't perceive it as helpful, if they perceive it as difficult to participate in, you're not going to get their buy-in. And if you don't get their buy-in, you're going to end up as an educator saying, oh, but I have taught a lesson. Yes, I've taught a lesson. But the actual answer is, did the student learn anything? So with that, thank you. And then for those of you who would be interested, I can also share it. I actually had quite a lot of references that I discussed previously. So thank you, and I will stop sharing now. Any questions?
Any questions?
Hi, thank you so much. This is Tracy from Las Vegas, Nevada. And my question is, you mentioned escape rooms, and I've seen that demonstrated at a nursing conference. So I just wanted to know how actually you did it. Didn't mean to put on my video. I'm on my walk. So
hi, Tracy.
Good morning.
Tracy.
I love your accent.
Okay, the accent obviously is a South African one, mixed with the Arab one from when I was in Saudi Arabia. Tracy, you know what? If you want to, and I put just my email again here in the chat box, investor@georgiasouthern.edu. if you're welcome to send me an email, and I can take you through the whole process, because it's really quite easy. I've got a lot of information that I can show you how to do the virtual escape rooms, and I can also share with you one of the professional organizations I've got part of, where these escape rooms are already available. So great question. I was very scared in the beginning because I thought it's very complicated, but once you've got the hang of it, it actually becomes fun.
Yes, and that's what our nursing students want. And I truly and desperately want to help our nursing students know that learning can and should be fun. And whenever
Yes.
I have offered additional opportunities to increase their grade, they always jump on it. So I would love to see your ideas. Thank you for offering your email, and I'll email you to get that information.
And I can share with you, and we can have a quick Zoom, that I can actually show you some of those that I already have done.
That would be great. Thanks so much. We have quite a few escape rooms for the public here in Las Vegas. And of course, it's a very physical activity. But I love the ones that the clues are often medication calculations or case scenarios where, of course, we're really exercising their brains. So thank you.
Thank you. I've actually seen one where you can click on like a male or a female that will give you a clue, and you need to have that clue. So it's actually very exciting.
Yes. Any questions?
Hello. Yes, I have.
Yes. Any questions? You can go, sir. You can go.
Okay. Hello, doctor. Thank you for your nice presentation. It is excited me because it is nice, not only for this COVID situation, but also it is important for the future situation, especially as the former presenter has presented. It is difficult for attending education especially for nursing, for upgrading, especially in developing country. It is difficult to upgrade ourselves from MSc to PhD, from BSc to Masters. So it may be one opportunity for us to learn through these mechanisms. So what you plan to expand this online learning beyond COVID-19? What you plan? And also it is not enough time to attend this complicated technology. So if you possible, if you arrange other online meeting, and if you are giving for us a short workshop, it is better for me. So thank you for your nice presentation. I'm excited. God bless to you. Stay safe.
Thank you, Dr. Sishai. First of all, I want to tell you that I am actually one of the BBT persons born before technology. So I can assure you I'm looking for easy technology. So that is first of all my first criterion. Can I understand this technology, and it must not cost anything additional to the student. And as you know, all universities are struggling, so it mustn't cost the university anything more. And all the technology that I have presented today, I'm going to keep using for my further classes, even though we even if they say we're going fully online. Another thing I want to mention is what I did the second semester, what I didn't do in spring, was I spent about 40 minutes in class and online with the students with their computers, and every piece of technology they had to practice. So that really helped, that students knew exactly even things like how to put a message in a chat box, how to share a file on Zoom, etc. So I'm sort of looking at other technologies, but the most important thing is I do hope to go into more research to say what the students want. And students really appreciate what every educator has been doing over the time. I was really surprised to see the appreciation of our students. But I would be welcome. You've got my email and I can share with you all the resources that I have, that I use, and PowerPoints that I made, like for Flipgrid, etc.
Yes.
Thank you.
Any questions? Any further questions to Dr. Mary Estelle Besto? If you have any questions, just you can text in our chat box. We'll be asking behalf of you. Yes. Thank you very much, madam. Thank you for speaking up in this meeting and providing your perspective. Thanks for sharing your tips with us. Looking forward to meet you again. Looking forward to meet again next time.
Thank you. Thank you all.
Now we asked Dr. Dion Martin from the successful nurse owner from USA to join the event.
Hello?
Yes, just be online, sir.
Okay, shall I start?
Yes. Meanwhile, just we asked Dr. Sise Shivazin from College of Health Sciences from Biharan from Ethiopia to start the presentation.
Okay, first of all, I would like to thank the coordinator of this situation, because I am learning a lot of things from this conference. There are a lot of experts who have different experience. We learned different things from them. By saying this, I'd like to thank all audience for your active participation and your experience sharing. So by saying this, I am Sisai from Deborah Brown University. I'm an assistant professor on pediatric nursing. So I will present our finding on knowledge and practice iodized salt utilization among pregnant mother. So it is our presentation outline. On introduction part, as usual, this iodine is one of the most important micronutrients, which is especially important for thyroid hormone, T4 and T3. So it is also important for metabolic rate and physical and mental development. And it is also one of the most important things that is absorbed by healthy adults. The deficiency that is occurred due to this iodine deficiency is the major public health problems in the world, as well as in every place, including Africa and Ethiopia. So the incidence is around 29% of the cases are happened worldwide, and it may cause preventable mental retardation in childhood situation. The majority of this iodine is
just we
absorbed.
Yes, student, we don't see your PPT on the screen.
It is not observed?
No, sir.
Not yet?
No.
Okay, I will share now. I will share now. Sorry.
Just you can share through share screen.
I'll
Yes.
Now it is.
Yes, it's fine.
Okay, sorry for the situation. So iodine requirements regarding this iodine, most of the iodine that is absorbed by thyroid gland. Not only this, but also the other thing that is happened in iodine. The iodine, the much iodine is excreted from urine. So most of the time the tests are done using this kidney test. And the other thing, around the world, there are around 2 billion people are affected by this iodine deficiency disorder. From these, 38% are globally, and in Africa, there is around 350 million Africans are at risk of this iodine deficiency. When it comes to in Ethiopia, there is around 35 million people are at risk for iodine deficiency. From these 50,000 annually, prenatal deaths are occurred in our country, Ethiopia. Not only this, but also in 2011, 50% of households have iodine access, iodine salt access. And nowadays, that means around 2016, research says that around 89% of Ethiopians have iodized salt in their homes. And even if there is around 50,000 stillbirths related to this iodine deficiency, and when you are observing the goiter rate ranges from 40% to 59% of the community have iodine deficiency related goiter. And in our country, Ethiopia, there is around 40% of the prevalence, high prevalence of this goiter in the community level. And in Ethiopia, it is also critical public health problems with high prevalence of endemic goiter. Iodine deficiency is the leading to multiple adverse effects on growth and development, especially in pregnant mother and childhood. Most of the children may develop this neurological disorder. Most of them may develop mental retardation. So, and in obstetrics, they may have poor outcomes like spontaneous abortion, prematurity, and stillbirth are the major problem that is faced after this iodine deficiency. And the birth outcome may be congenital anomaly, decreased intelligence, and neurological criticism are the major problem that is faced after this iodine deficiency. And this iodine deficiency is preventable brain damage and preventable mental retardation may be happened. So recommended dietary allowance in iodine, iodized iodine in different forms, most of the country given in iodine and iodized salt. So children 0 to 6 months needs 15, and children 6 to 6 years need around 19, and 7 to 10 are around 120. And when you are observing the pregnant mother, need high iodine during their pregnancy and lactation. The increment of this iodine, one, the T3 or the production of T3 is increased by 50% during pregnancy and lactation period. So the mother should increase the intake of iodized salt, and also the mother transfers this T4 to their fetus, and also they have increased excretion of this iodine through their urination, through kidney. So most of, as indicated here, most of the population, the rare persons have developed criticism, the severe forms of this iodine deficiency, and the other have brain damage, around 26 million worldwide, and mental retardation or mental impairment, which is unobserved and less health seeking have on mental impairment, educational and so on. So it is a main challenge in developing country like Ethiopia. And when you are observing the coverage of this iodized salt utilization, it might be vary from region to region in Ethiopia. It is lost from 63 up to 474, and it may extend up to 89 in city town. So pregnancy outcome, what we said, they may have abortion, stillbirth, congenital and pregnancy-induced hypertension, and also postpartum hemorrhage and fetal distress may be happened. And there is goiter, what we are said. So we are advocating 1 teaspoon iodized salt contain around this 400 micrograms of iodine. We are encouraging the mother, do not encourage moms to eat more salt. Rather, we encourage to consider buying iodized salt, especially when buying from SHOP. The objective of this study to assess knowledge and practice of iodized salt utilization and associated factor among mother, to assess their knowledge, to assess utilization factor, and what is the main factor. The methodology what we are using, community-based cross-sectional study were conducted. The sample size were calculated by considering this issue, margin error, 95 confidence interval, 10% compensation and design effects since we are using multiple stage. Then finally, we are calculating around 457 participants were engaged in this, and logistic regression was assessed, and 95 confidence interval, binary and multiple regression was calculated. So the association was determined based on p-value less than 0.05. And when we come to the result, a total of 457 pregnant women with 91% response rate were engaged in this. The mean age of the participants were this 30.9 years, and higher proportion were from rural area, around that is 88% of the participants. The majority of the mother was housewife, so it is also the problem. Knowledge of, when we are assessing the knowledge parts of the participants, around 1/4 of the respondents have not heard about iodized salt from different sources. They did not buy the iodized salt, or they are not knowledge whether the salt have iodized or not. And generally, when we are assessing the knowledge part from the questionnaire by doing mean, around 42.2% of the pregnant men had good knowledge on iodized salt. The rest have no knowledge on iodized salt. So the study conducted in other area, Sudan, 56%, South Ghana around 90.4, and Mongolian around 96, and in Tehran around 26% of the respondents have knowledge. A study done in Ethiopia in other place that indicated around 48% and 32%, 33% have knowledge on iodized salt utilization, and it is knowledge parts. On when we are assessing the knowledge part, there is around 62% of the participants have good practice on iodized salt utilization. There is around 11 questions that is asking these knowledge practice parts. The participants have good knowledge on this issue. And the study in India showed that around 64% and 73% have good knowledge on iodized salt utilization. Other study done in Ethiopia, that is around Addis Ababa, the capital city of Ethiopia, showed that 76.3% have good practice of iodized salt utilization. The most determinant factors are educational status. As you are observed, more of our participants are housewives and non-educated. So at secondary and above education status, more likely practice proper utilization of iodized salt when it is compared with non-educated or uneducated mother. And economics or income, mother who have less than 500 birr, Ethiopian birr, have less likely practice iodized salt utilization when compared to these two are the main factors that were found in our study. And on conclusion, the knowledge and practice status of pregnant women towards iodized salt utilization were low, and ethnicity, income, and level education are the main factors that affect iodized salt knowledge and practice. We recommend policymakers should review the program which used upgrade the level of iodized salt utilization, and the federal, regional, and zonal and world health office should give attention regarding community awareness about iodized salt utilization. So it is sample reference that we used. And if you have any question, welcome. It is what we do in short parts. So thank you for your nice presentation or nice attendance. Thank you.
Any questions?
Yes, hi, this is Dr. Long calling again from Las Vegas, Nevada. And I wanted to make sure I understood correctly did you say that you are recommending that your population does not take added salt, but rather biotin? I work also as a family nurse practitioner in an endocrinology practice in Las Vegas, Nevada. And we found often that biotin creates some changes in our TSH, T3, and T4 values. And so before they would get their blood tested, we would have them stop any biotin that they were taking. What were your thoughts and practices about that?
Okay, thank you, doctor, for your nice issue. So, as you know, in our country, it is difficult, especially to test for iodine. Unless they have no goiter, they are not determined as a patient who have iodine deficiency. So, where they are coming at critical point when they are goiter plus 2, plus 3, and so on above, rather than testing for iodine test. There is no testing themselves for these micronutrient deficiencies. They are coming after complication. I got you? Hello?
Yeah, I go on. Go ahead.
Okay.
Any questions further? Any questions to Dr. Sise? Yes. Thank you very much, sir. Thank you very much.
Thank you. See you. Goodbye.
Yes. You were in logging to since last 2 days.
Okay.
You are asking a lot of questions.
Okay, I have.
Yes.
I will attend. Okay, thank you.
Thanks for sharing your tips with us. Looking forward to meeting you next time.
Okay, see you.
Yes. Now we ask Dr. Ginner Churchill from Columbia University School of Nursing from USA to start the presentation.
Everybody can see that?
Yes, ma'am. Fine.
Okay, thank you. So today my talk is going to be on something that we all know is so important in teaching new nursing students. And that's the importance of developing their critical thinking and nursing education. And it's been especially challenging this year with COVID. They've had limited clinical experience, but there are many ways that you can still develop their critical thinking even with that limited experience. So just to go over, I think it's pretty interesting when we look at the word critical, what it means. It does mean to question, make sense of, and analyze. And what it also does is when you're critical, you not only examine your own thinking, but the thinking of others. The actual term critical can have a negative connotation as well as a positive connotation. It can be thought of in a negative way to describe thinking negative way, but it also can be used to describe thinking that portrays a process in which one challenges one's thinking and thinking of others. And that's what we're constantly doing with our students. One of the issues is that nursing has primarily relied on definitions of critical thinking from other disciplines in its origins in social sciences. So the American Psychology Association, or looking at the definition for teaching before we've really even had our own definition of what critical thinking is. As early as 1932, the National League for Nursing recognized critical thinking as an important concept for nursing education. So it's been around a long time in recognizing the importance that they need good critical thinking to provide the best patient care. And based on the way critical thinking is addressed, there is a limited understanding of meaning as it continues to exist within our own discipline. So we know that why critical thinking is important in nursing. And we can see this even more so now, especially what we're seeing in the hospitals with the patients who are admitted with COVID. There's many of these issues that we really have to address. So nurses are constantly confronting complex problems, and their decisions require critical thinking in order to identify patient needs and implement best practices. And I'm sure many of your students are now seeing patients on the units that are sicker, more acute care, have more complex problems. I know than I did when I was in the 1970s, practiced as a staff nurse. And one of the issues I also bring up is that with children, is which I teach is pediatrics, they can't convey to you many times what's wrong. So that it's so important that you use your critical thinking skills to get to the base of the problem, be able to implement the best practices. This, I think, is really important. Of course, we all know that learning is a lifelong process, but it's important that we teach the students how to think and not just what to think. We know that we can't teach them everything they need before they get out and practice, but we can teach them how to think, and teaching critical thinking is one way to do that. One of the things that's also happened is technology can overshadow the compassionate art of nursing. So critical thinking can create nursing systems that do use technology within a humane and caring environment. We have to really make sure that the patient is our focus and not the computer. Advances in healthcare leave nurses faced with many ethical and moral dilemmas. I mean, we're faced with that many times in pediatrics, many times decisions that have to be made for the child, decisions because they are not able to make their own, or they are depend on their guardian to make those decisions. And as well, decisions you're seeing being made during COVID. It's been very difficult, and nurses are being faced with more and more ethical and moral dilemmas. And of course, we hear this all the time, evidence-based practice. We need critical thinking for evidence-based practice, and it supports critical thinking. So you want to search and evaluate evidence in making decisions to provide the optimum treatment in an intervention. And critical thinking is important when using this. So these are two prior definitions. One is from the APA, and the second is from is one that they use in teaching. And if you look at both of these, when nursing develops a critical thinking definition, they draw from both of these definitions. I'm not going to read them this way. It gives us more time to have questions and go through some of the instruments we use to engage with the students and develop critical thinking. But you will see here, this is a critical thinking definition specific to nursing. And what this definition has done is taken from the APA, is taken from teaching, and developed our own definition of critical thinking. So critical thinking in nursing is an essential component of professional accountability and quality of nursing. So it's not only the care that you're giving the patient, but it's holding yourself accountable for that care. Exhibit these habits of the mind: confidence, contextual perspective, creativity, flexibility, inquisitiveness, intellectual integrity, intuition, open-mindedness, perseverance, and reflection. And they also practice cognitive skills of analyzing, applying standards, discriminating, seeking information, logical reasoning, and predicting and transferring knowledge. So what's interesting is that they're talking about qualities as well as how to apply your critical thinking. So this kind of talks really about that definition we had. What are the critical thinking skills you need to develop in a student, and what are the virtues? We hear that a lot in nursing, virtues of critical thinking. So the critical thinking skills that a student has to have and develop is questioning, analysis, synthesis of the information, interpretation, inference, both inductive and deductive reasoning, intuition, evaluation, application, and creativity. I tell my students all the time, and granted, I've been teaching pediatrics for a while, and I've been a pediatric nurse and nurse practitioner for 42 years. I can't stress how important creativity is. The virtues of critical thinking are, they have to have independence of thought. So I always tell the students, you go in open-minded and you make your own interpretation. Don't base it on what someone else has told you. You have to use your critical thinking skills. Intellectual curiosity, courage to make those decisions and use the skills that they're developing to do critical thinking. Humility, empathy, integrity, perseverance, fair-mindedness, and open-mindedness. Those are all virtues that we have a tendency just to teach the skills, but we also have to look at those virtues and enhance those virtues in our students. Now, in order for critical thinking to work, there has to be many things working together. There has to be students, educator, the education system, and the environment or the atmosphere. One without the others is going to be very difficult to really engage and develop those critical thinking skills. All of these together can make successful critical thinking skills in students. So other things that can influence critical thinking is our cultural background. Maybe there in certain cultures, there's not as questioning, let's say, a instructor or a provider on reasoning why something may be done, may be part of their cultural background. So you look at their cultural background. Could there be some language barriers? Does the student have a lack of confidence? Remember, we saw their courage. Is there a lack of confidence that has them a little bit nervous about asking those questions that they need to ask that are important in critical thinking? And a lot of them are focused on getting the right answer and afraid of making mistakes. And they should not be feeling that. So the educator, it's really important the educator be open-minded, flexible, supportive, and approachable. You know, I can't tell you times where I've had a student who maybe with the instructor they didn't feel was approachable. So they are afraid and lack confidence in order to ask that question and give their input on what they think may be the best practice for that patient. You want them to value and trust the student's opinion. You want the instructor to have good questioning skills that stimulate critical thinking in that student. And also, we always reinforce to our instructors that they have to show behaviors that show role modeling, facilitating, guiding, and prioritizing. We tell them all the time, these students look up to you. You are their role models. So you have to remember that when you're working with them in the clinical setting. This also is the education system. It's important that the education system values cultural sensitivity and incorporates that into everything in education. We don't want to have a power relationship between the teachers and the students. So that's important that be stressed, that the student cannot feel that they're intimidated to ask or confront a teacher or an instructor because they feel this type of power relationship. We have to provide well-planned lectures that provide students with acting learning opportunities. So I know this has been brought up in prior presentations. So whatever that be, we do things like Jeopardy. We do Jeopardy with different systems. We do a lot of case studies, interaction that way. Simulation lab. This is engaging and is active learning. And to value the importance of CT and teach as a separate subject. And the VCT is critical thinking. So the atmosphere has to have a positive learning environment and atmosphere. And that really goes along with having open-mindedness, providing an environment where the students feel safe, where they feel safe asking questions, where they feel safe giving an answer, even if it is the wrong answer. It has to be culturally non-threatening. And as we said, that has to be a priority in the schools, is that there's cultural sensitivity, not only within the administration, but also to promote that within the student body. Be encouraging with your students, be encouraging to be engaging, be encouraging to ask questions. Make sure, again, that it's a safe environment, that they feel safe and they're not going to be ridiculed if they ask a question or give an answer that's incorrect. And you want to make the environment free for discussion and expression of thoughts. These are all together, these are important to help develop critical thinking. These are many different teaching methods that are used in many universities. Not only in universities, it's used in the business field, it's used in schools to help really develop critical thinking. Some of the ones, we're going to only talk about a few today, but there's reflection, concept mapping, you have case studies, simulation, context, which is really part of simulation, the nature of the world in a given moment. You're practicing that when they're in simulation. Problem-based learning, journal clubs is great. Sometimes we do journal clubs as part of our post-conference, and the student who is going to present at post-conference will send out an article, and the students have to read the article, and that becomes part of the discussion in the post-conference. Clinical logs, role modeling, multiple choice exams, believe it or not, still can, if they're correctly worded questions and challenging questions, more of application questions. So they take, what I do is I will give them a short case. They have to decide what it is that child has, and then from there, use their critical thinking and prioritize what needs to be done for that child. And student-based rounds is something that's fairly new. And what it has, and the studies have shown that it really helps with developing critical thinking skills. And this is something we developed, they put into the pediatric clinical rotation about 3 years ago, and they really love it. So this is just a little bit more information on those different methods. We have reflection, and I'll share with you some of the reflections that we have. One of the things that we do, and we started this a few years ago, is that we have students write reflective narratives. And what it really does is gives them an opportunity, first of all, to really acknowledge the impact they have in the clinical setting. Because many students, feel like, ugh, what difference am I going to make? I'm probably just going to be a pain in the neck. Well, when they sit back and write a reflection, they really realize the impact they had. And the other thing with write and reflection is they learn to take care of the patient as the patient and not just a disease. What we also do with the reflections after they're handed in, students who feel comfortable will read their reflections in class, and then we have a lot of discussion and participation. So it's been an absolutely wonderful experience, and I'll share some of those reflections toward the end. We all know about concept maps. I will share the concept maps with you. I'm sure many of you are familiar with concept maps, but that definitely is tremendously helpful, not only in helping the student develop their critical thinking skills, but it also gives their instructor an idea if they are able to put these concepts together. So they may see them in the clinical setting, but are they able to take all of this and put it together? And the concept map really helps with that. Case studies we do on a regular basis in didactics. Instead of covering a topic with a lecture, many times we do it with an interactive case study. And that has been really, the students really enjoy that. And sometimes we'll do case studies where they're acted out. So even though they're not in the clinical setting, or maybe not even in simulation, but we can act it out in the classroom setting. Context really goes along with what I had mentioned before. It goes along with simulation, and it's really students describe the patient's story in that given moment. So this is done in the simulation lab, where many times it surrounds a case study. So it helps with understanding reasoning for the student's decision and how to practice change in the future as a result of this experience. And that's used in simulation. And problem-based learning is group learning, and there's different roles for each student. Case studies are one of the things that we use. And what happens is the group formulates questions, they gather and appraise information from a variety of sources, and are taught how to fit this new information into expanding knowledge. And that's part of exactly what we do with evidence-based learning. And part of the way I do that is with an evidence-based paper that they write. So here you're all probably very familiar with concept maps. Concept map starts. So we have the students have a whole patient database where they go through and they fill information out with meds, lab values, physical assessments. So when the instructor goes to look at the concept map, they have that information to base their concept map on. So they know if the student is really has that ability to get it and bring it together. So the concept map starts with the chief medical diagnosis in the middle, and then we tell them to prioritize their concerns. And with those, you have a nursing diagnosis. So here you can see this one is altered nutrition, fluid, and electrolyte balance. So what they have to include in there is their subjective and objective data that supports the fact that they think the number one concern for this patient is altered nutrition and fluid and electrolyte balance. What you then do after that, so after they complete the concept map, they are then asked to take the 3 of the top nursing diagnoses and develop a short nursing care plan where they will put diagnosis, outcome, goal with their interventions, what the response was, and an evaluation of their responses. So this has been really helpful in really seeing, because they really have to think critically. You know, altered nutrition and fluid and electrolyte balance. Okay, their NPO. What are their electrolytes? What's their urine output? So what's their weight? All of those things go into why did you choose this as one of your priorities? I wish you could see this a little better. This is the student nursing rounds that we've developed. And on the right side are guidelines for the student nursing rounds. And one of the reasons we started like this is, you know, sometimes there's downtime on the unit. And so instead of having the students just hang around, that's why I first started it. But I also had done research to find that this is very helpful in developing critical thinking skills. So this is an S-bar, which I'm sure many of you are familiar with. So they take the S-bar that they have where they've gotten the information about their patient in change of shift. In there, I have some different, there's red, this is one that's specific for nursing rounds. So they have an S-bar, they fill it out, but then they have, during the nursing rounds, there is these in red, you'll see other things that have to be included when they're presenting their patient. So they round from room to room, they will present their patient, one student will present the patient, and what they'll do at the end is the students can ask questions to that student presenting the patient as well as the instructor. If the parent feels comfortable having the students come in and meet the child, they will first go in and meet the child before the student presents it. And then what we ask them at the end is to do an interpretation. I don't know if many of you have this issue, but we do have a problem with the students actually understanding what an interpretation is. And we're talking about a nursing interpretation. So we give them a template of taking all that information you got, the subjective, objective information, and give an interpretation and what is going to be your priority today for taking care of that patient. And this has been really, the students love it. The last thing I'm going to talk about is the clinical narratives. And this has been something we started about 3 years ago. And at Columbia, we have a master's in narrative writing in medicine. It's open to any of the schools of healthcare on the campus. So I have worked with the person who has developed that program in what they call an interprofessional education organization. And we have, that's really another whole topic, is that we have a very strong interprofessional education committee that promotes working with other healthcare providers on the university campus. And we do a lot together. So one of the things is that she has developed is this narrative writing. So I've worked with her and learned from her about narrative writing. And I like this quote: narrative writing helps the student discover the balance between art and science of nursing and allows them to take responsibility for how they practice. When they reflect on what they did, that helps them decide how they practice. These are some these are just parts of some of the narratives that the students have written. I give them guidelines, and there is a rubric that they have because it is part of their didactic grade. But the rubric is more for them to what to follow when they're writing a narrative. I said, I don't want a nurse's note. This is a 4-year-old child who presents to the ER. I want you to really pick either an experience with a patient, experience with the family, an aha moment you had about yourself, maybe something that you had seen as an interaction maybe between the nurse and the patient that just really made you feel like, wow, I know this is what I want to do. So I'll just read one of them. I think it was really a very moving one. And I'll just read the last one quickly. As I stood in the sidelines watching this scene unfold, jumping to assist when requested and stepping back when not, it became so evident how frightening it must be for a patient, especially in the midst of such a critical situation. For the medical and nursing staffs, a situation such as this rapid response is routine, just another day at the office. But for the patient and his or her family, this is potentially a huge deal, and they will almost assuredly remember the event in exquisite detail for a long time. Observing the staff in the room, the dozen or so of whom spanned the gamut of professionalism, I could predict who Lauren would remember for skillfulness and compassion, and whom she would recall a little less fondly. Now, Lauren is an alias, it's not the patient's name. But it was really, I mean, I find I get to learn a lot about the students. It is really very stimulating in the classroom. Many times I have to bring a box of tissues because some of the stories they share are stories about children who have really had a huge impact on the students' experience, and really made them reflect and realize how important their job is. And it also makes them realize things like, wow, you know what? I'm pretty lucky, because I tell them, you leave your baggage at the door. When you come into the floor, your patient is your priority. So this really, really has helped them, and it has helped all the students. So I'm going to end with just talking some barriers to teaching critical thinking in nursing. And we need to work on these barriers, because critical thinking to me is the basis of all nursing. Lack of accepted definition and making it difficult to apply critical nursing to standards of practice. We're getting there. You saw from that definition that was there earlier. But again, we've got to make our own definition. System problems such as lack of faculty time, to develop appropriate teaching strategies, okay? Because it takes more time to develop these strategies for critical thinking. To try to balance the content with the critical thinking. How do I make sure they get this information? But also, how do I provide those activities to promote critical thinking? Students' attitudes such as resistance to active learning and focus on grades rather than learning. And I'm sure many of you hear that. Yes, this is, I'll sometimes do a case study that the information is not going to be on the test, but it's information to promote critical thinking. It's engaging. And they want to know, okay, is this going to be on the test? And instead of looking at this as an opportunity to develop critical thinking. Students are typically more comfortable with didactic content that focuses on learning, because they want to know what they need to learn instead of this is again, teaching them how to think, not what to think. Because when they get out there, I tell them, and you're on the unit, you're not going to know everything. But if you know how to think and use your critical thinking skills, that is going to help you get to where you need to be. And we need objective measurements of critical thinking with a focus on empirically measuring students' performance. And some of that is with a rubric. The rubrics are not always the best in really being able to evaluate it, but it's a step towards evaluating critical thinking. So I'm going to end with this quote by Albert Einstein. Education is not the learning of facts, but training the mind to think. And that's a lot of what we do, is really training them, giving them the skills, making those virtues be ones that they take on, and having the courage to use their critical thinking in taking the care for their patients. These are references. Okay.
Yes, any questions?
Any questions?
Yes, Doctor, thank you for your presentation.
Okay, yes, what question do you have?
My question is, you were talking about critical thinking for nurses who are students. I would like to inform about talking about critical thinking for nurses working in the hospital. Now we are having a nurse who works in the hospital, and how we gonna teach him critical thinking? As much as Dr. 1 minute, my baby waits. So just 1 minute. I'll put her to breastfeeding.
That's okay. How old is she?
She's I put her in my boob. So she's 1 year and 5 months.
Oh. Go ahead. Oh, a pediatric person. I like that sound of baby crying.
So how to teach is already in the hospital about critical thinking. I try as possible when I do competency to ask a question, like give them scenario and how they will act to measure their critical thinking. But I put a nursing education framework, and I put part of it like a soft competency, not a skill competency, about critical thinking, like to do presentation, to teach them about critical thinking. So how I can emphasize critical thinking in nurses already working in the hospital. I know as a nurse, when I start as a student, it was sometimes feeling like, oh, I feel something wrong with the patient, but I don't have this critical thinking. It's come only with experience for me after 15 or 16 years to be a nurse.
So is your question to me, what is your question to me?
My question is how to emphasize critical thinking in nurses working inside the hospital already, not students.
So I think you can use a lot of the information from this for even nurses that are already working. I know where we are, they use nursing logs. I've worked with them writing reflectives. I think that the nurses as well, things that they can do are making presentations about different topics and engaging the staff on asking questions and using critical thinking. So I think you can still use these skills in the nursing environment. It would also take probably more time and more staff to have maybe on each unit where we are in pediatrics, there is a clinical specialist who is a nurse educator. So the nurse educator on that unit could take on this role and have activities like this. The hospital is welcome to come over and use our simulation lab to give scenarios using the simulation lab. They should be doing things like meetings with regular case studies. They can do journal clubs. So a lot of the things that we mention here are things that really should be continuing into the clinical setting to help, especially that new graduate, develop their critical thinking skills. I remember when I was a new graduate and I worked on a cardiac unit, and I'd sit and listen to report and they'd rattle off all these abbreviations for cardiac anomalies. And I said, how am I ever gonna learn all that and know what to do? So I did have a mentor, and that's really important. And again, this comes to money. Really good mentorship programs are really important so that a student just doesn't get thrown on the unit, or a new graduate just doesn't have a 6-week orientation. I think we also need to do longer orientations with using a lot of these skills with critical thinking. My daughter had a year-long orientation to an ICU. It's amazing the difference by the end of it in developing critical thinking, because she had a mentor for all those 10 months, and that helped her develop those critical thinking. So I think the hospitals have to get on board as well and provide the environment and be willing to pay the money to have different orientation programs that last longer, where students can develop these skills of critical thinking. I hope that answered your question.
Yes, you answered me. But my other question, you talk about very important barrier can affect the critical thinking, and one of it is the environment. So we have in my hospital a lot of nurses from Asia, and they don't have this personality to talk to the doctor about their mind or something.
Right.
So how I can change the environment to help them to speak up their mind, or at least even they are worried about it's wrong or somebody will laugh about their accent, how I can change this environment and this mentality.
And that is a real, and I think I just, even with mentioning that with culture, is that can
be something that can interfere with it because they don't feel comfortable speaking up. That's not part of their culture to question a doctor's orders. If they really know and feel that that's not appropriate for that patient. I think, you know, again, it's going to go back to having that support system in the hospital that will allow them to feel safe. And maybe there needs to be, I don't know what kind of policies that are present in your hospital that would prevent a nurse from feeling like she could suffer from retaliation from maybe questioning, speaking up, asking a question, even to ask them to someone to really explain why they're going to be doing that with a patient. That is, you know, that is a challenge. And that as well takes time. I don't know if it would be helpful if you do have a staff nurse or a leader who is of the same cultural background that has a stronger personality that could be a mentor for them and could have meetings with the nurses who you feel that feel intimidated speaking up and give them skills and even, you know, like acting out, you know, acting out a situation where they don't, the first time they ask someone is not threatening because they're asking another peer. But this way they have the skills and maybe feel a little bit more confident in approaching someone who they feel intimidated by in order to make sure that, because they feel this is not what really should be done for the patient, or I don't really know, why are you doing that? So maybe doing sessions within, not only with them in themselves, but with other nurses as well, to give them the confidence. So they're not always up against someone who they feel there's that power issue, is that if they've approached and really acted this out and practiced this, they may feel more comfortable when it comes to the time that they do have to confront someone. And they should have, and to see if there's policies intact that will protect that nurse from suffering from retaliation for questioning someone of a higher, you know, degree.
I understand. Thank you.
Yeah,
Thank
it
you.
can be, you know, I know our students go internationally. Not this year, they haven't been able to go internationally, or last year because of COVID, but they do come back and talk about their experiences, and their experiences are different because in the United States, they are that, you know, part of our culture is especially, you know, it is to go up in question. It is not one that, especially it started that way, but it is ingrained now more in the students. And so there is more of that supportive environment for students. But I know that students do talk about experiences in other countries, and they found that it's not as safe in other countries for nurses to speak up and question, rather just do what the doctor says. So I know that that is a concern and has been an issue that they've even voiced when they come back from going to some other countries and practicing.
Thank you a lot for your presentation. I get so much benefit and open eyes.
Yeah, and if you want to email me, I don't think I have my email up here, but my email is,
chat?
Well, I'll put it, no, how do I get to the chat here?
Yes, you can text here.
Excuse me?
Yes, you
You
can
go
text
down in the screen and you will find participant chat, report.
Oh, participants, I see. Oh, okay, I'll put it in the participants, okay? Oh no, I'll put it, I don't have the chat.
How come you don't have it?
I'm trying to see
Go
how I
to
get
the view and go to the side by side or speaker.
You can find in chat box. In chat box, there is a chat box. You can mention your email ID. You can find a chat box in bottom of the screen. Chat box.
Let's see, because I usually see a chat on the bottom.
Shall we? Yes, I'll be sharing your mail ID. I'll be sharing your mail ID.
You know, I could tell it to you, and you can, because I can't find the chat here. Or you maybe
just to be on
new share participants. Is that where it go?
Just to be on.
I had the chat up before. Let's see.
Jean, while you're looking for that, I've got a question as well.
Sure.
I'm a nursing professor. This is Dr. Tracy in Las Vegas, Nevada. And so I have the fun opportunity to teach bookend nursing students, meaning I've got my nursing fundamentals students who I love as my baby nurses. And then I teach critical care for my last semester nursing students. And I see a good shift in, of course, their ability to be critical thinkers, as we hope we should by the time they're ready to graduate. But I find that those fundamental nursing students, they really struggle with critical thinking because they really want to be, they are concrete thinkers. And, you know, when we think about teaching them to think outside the box, our little fundy students are trying to learn right now what's in the box. And so what are your suggestions for really effective learning strategies to help them, even at the fundamentals level, start to understand and grasp what is critical thinking?
Well, you know, I think, you know, some of the things have to be present as well for them to develop critical thinking. You know, they have to feel like they're in a safe environment. We have to make sure our instructors know how to ask the right questions, are open-minded, and the students don't feel that they will be criticized for either asking the wrong question or saying the wrong thing. So you need to start with the instructors to make sure that they're having that, providing that environment for the students. And I think we just start with small. You know, we start doing the concept maps early on in their program. We start concept maps and reflective writing, both in fundamentals. And so, you know, we're not expecting them to be able to decide what a patient, you know, use those critical thinking skills that have been developed that they have by the end of the program. But I think, you know, starting small and starting with the environment that promotes critical thinking. You know, post-conference is a great time to do critical thinking, where you could take one of the patients who the students cared for and together work through a concept map with them, together work through what they think the major concerns are and what you would do and what you wouldn't do. What makes you think that this is a priority for this patient? What are the subjective and objective reasons why you look at that? So I think starting small and starting with even just doing it as a group together in a post-conference, in an environment where they feel safe asking those questions. And also, you know, the use of reflective writing has helped tremendously with the students and also developing their critical thinking, because they're really looking at how they practice and what impact how they practice has on their patients. So start with narrative writing, making sure the instructors are on board and that the students feel safe. Because I know there's a real range with me of, you know, when students feel safe asking questions, I feel like I can't ask that question. Or if I give the answer and it's the wrong answer, I'm going to be ridiculed. Versus the students who are making rounds with an instructor who is open-minded, who even if they ask a question, they may say, well, why did you know, let's look into that question, or give an answer, say, yeah, I can understand why, but, you know, maybe who else has maybe some other ideas to help support this? So I think working as a group when they start fundamentals may be a way to do it as well. But and do it in post-conference, start the narrative writing. I do have a whole presentation and information and guidelines on how to do narrative writing as well. So I could send that to anyone who's interested, but we have really found, we started just in pediatrics and now it's in every one of our specialties, as well as the fundamentals, as well as when they go internationally or even within the United States, they do reflective narratives on their experiences.
That's great. Thank you for sharing those good, tangible ideas.
All right, thank you. I hope it helped.
Any questions, ma'am? Any further questions?
And I'm still looking for that area where I can put my email address.
Yes, we have mentioned your email ID.
Okay, I'll send it to you, and then you can send it out. Would that be helpful, or?
Yes.
I don't know.
Yes, we have sent to your email ID. Everybody can receive your email ID.
My email.
Yes, we have mentioned already. Just you can see in chat box in bottom of the screen. You
know what I think the problem is? I don't see a chat box here.
Oh.
That's why I don't have a chat box on the bottom of my screen, because that's what I was looking for, a chat to enter the to enter it, but I don't have a chat box on the bottom of my screen.
But we have sent, that is JNC.
JNC, small j, small n, small c, 37
at the rate CU
at columbia.edu.
Yes,
so
yes.
JNC 37
Yes,
at columbia.edu.
Yes, we have sent to everybody, they have received it.
Okay.
Yes. Any further questions to Dr. Gianna Chachil? Any further? Just if you have any questions, you can text in chat box. We'll be asking behalf of you.
Okay. All right. Thank you for giving me this opportunity.
Yes, thank you. Yes, thank you. Thank you very much, madam, for participating in this event. On behalf of Organizing Committee member of Nursing Education Congress 2021, we want to thank you for instant presentation. Looking forward to you meeting again next time in physical event if everything goes well. Yes, now we ask Dr. Tracy Long from Arizona College of Nursing from USA to join the event and start presentation. As she is the second.
Everybody, it's so nice to see everybody around the world. Very fun and nice to see that one blessing of this crazy worldwide COVID is that we've all really kind of figured out how to navigate the whole Zoom world and technology that can bring us together and share our information, our expertise and ideas worldwide. And I love that. And so we as a world, I hope, are turning that nasty virus lemon into lemonade. Well, I wanted to share with you some research that I'm interested in and then have also conducted. And it had to do with regarding the topic of the image of nursing. I'm very interested in that because I'm proud to be a nurse and I love nurses and I love traveling. And one thing I love is combining both. So every year, except for 2020, I take nurses and nursing students internationally and we do volunteer medical missions in general medical clinics. So I'm also very interested in what different countries feel about the image of nursing. So just wanted to share with you kind of in a little historical perspective of what is the image of nursing. There's been some substantial research on this, but moving forward, there's some really interesting insights. So I love the origin of a nurse. In the beginning, God created nursing. He said, I will take solid, simple, significant system of education and an adequate, applicable base of clinical research. And on these rocks will I build my greatest gift to mankind, nursing practice. And then on the seventh day, he threw up his hands and he's left the rest up to us. So of course, that's just tongue in cheek, but many nurses feel like they really were born to be a nurse. They have that within them. So when I ask my nursing students, well, who was the first nurse? Most of them will say Florence Nightingale. And of course, I have to give them a little more insight to say, you know, the very first nurse was a woman, but it was way before Florence Nightingale because women instinctively are nurses. And when we look at the root word of nurse or nutritious from Latin, then that just means to serve, to nurture. And that tends to be the core of the value that many nurses feel. I love this statement. It would be safer for the public welfare if nurses were educated instead of lawyers. So we do love Florence Nightingale because she comes on the scene and changes the image of nursing, and we'll review that here in just a minute. So the earliest reference we have to nursing or nurses is in the Bible, in the Old Testament, usually as a labor nurse or nurses who would be caring for the aristocrats, like even when we look back at Noah, and he was plucked from the River Nile and then nursed. Did I say Noah? I meant Moses. See if any of you caught that one. So when we look at, again, definition of what is a nurse then, nursing is protection, promotion, and optimization of health and abilities, prevention of illness and injury, alleviation of suffering through the diagnosis and treatment of the human response. And that's a big differentiation that I make with my nursing students because I'll ask, what is the difference between a nursing diagnosis and a medical diagnosis. And it takes them a good semester to really kind of figure that out. So nurses are about that lived human response to illness, disease, wellness, grief, and all of that, different than the medical response. And so that's what we specialize in. And we are advocates of the care of individuals, families, communities, and of course, populations. So interestingly, when we research and ask nurses, how do you see yourself? These are the values, the characteristics that nurses say, this describes us. So the core values we say is we're honest, we're responsible, we're in the pursuit of new knowledge, we have belief in the human dignity, we believe in the equality of all patients, we are hard workers, we have great physical endurance, emotional stability, good judgment, and we desire to prevent and alleviate suffering. And truly, I think any nurses who are on this conference would agree, yeah, we're rock stars. We can do all of this stuff, right? So then the next very humbling question is, well, how does the public see us as nurses? We see ourselves as these wonderful characteristics personified, right? Well, so let's do a little bit of a history of how did or do people, the public, see nurses. Well, nurses originally, historically, again, were altruistic, philanthropic. We did everything we did based on that goodness of our heart to alleviate suffering. Again, a core value of nursing. And so the impact of Christianity on that and all religion was that was the core of nursing function, caring, compassionate, selfless, right? And so that's originally how we began. And so through time, things have morphed a little bit. In the Dark Ages, so the nurses of those early, middle, and Dark Ages were the deaconesses, the virgins. And so the image of nursing was pure and undefiled. Then, in addition, because of that, if you were an aristocrat, if you were wealthy, you could afford this private duty nurse into your home to raise your children. And that demonstrated much trust in that person. Then interestingly, in the late Middle Ages, there's this time period where the women who were nurses were a little more promiscuous. And perhaps it's because they were out in the public. So then somewhere between 1500, 1800, religious orders started to clean things up and say, are you kidding me? You know, the only ones that could be trained as nurses were the prostitutes or the very impoverished. And part of that had to do with war. For example, if in the military, as men were sent to war, they needed more nurses. And so they would grab anyone off the street and begin to train them. Well, with that became some untoward kind of personalities. And so the leadership in nursing was definitely the prim and proper nuns in the Catholic religion, and they tried to clean things up. Well, it was on this time period that Florence Nightingale now comes onto the scene. And she had within her, like many of us do, this calling to become a nurse. Well, she was born in an aristocracy, and her father said, no, you won't be a nurse, because the reputation is that a nurse is filthy, there are prostitutes at night, so he forbade her to be a nurse. Well, there was not any real great nursing training. The training at the time was under the tutelage of a physician. And so she begged physicians to allow her to shadow them to learn about nursing. Well, in Perfection of World, how life unfolds, she now steps on the scene of the Crimean War, where they're begging for nurses. And so she gets a physician to allow her to shadow with him. And she has just a critical thinking, above and beyond her time way of looking at health and wellness and disease. And she begins to separate people based on their diseases and their processes and body systems. And so she literally becomes the first one to develop a nursing ward. And she sets everybody who's got a respiratory issue, let's put you together. And everybody who's got wounds from war, let's put you together, and let's not make those two switch. She opens up windows, she cleans linens, and she begins to manipulate simple environmental factors that contributed to illness and disease. She even put a potted plant on one windowsill, and she observed that when the light was open and the window was open, the flower in the daytime turned and opened up to the light. And she thought, if a flower could do this, surely the human organism could. And so she began to turn patients to the light and to the open air, which was very controversial at the time, because pre-germ theory, they thought all the illnesses were coming from the air. So she began to really change things. And of course, we call her the lady with the lamp, as she then would lock up her nursing students to prevent them from going out on a side hustle job in the evening. And she would walk the 6 miles of a hospital corridor to check on all of her patients. So she was also, of course, the first to really develop nursing theories and establish nurses had a unique body of knowledge. I love Florence Nightingale because of her thinking and how she really changed the image of nursing. So here in the nursing, in the Florence Nightingale Museum in London, England, you see some of her artifacts, and you can read through her whole life. And of course, it was on that scene where then now they are developing the image of nurse was white, this white shirt, at least the apron, but then the nurse's cap. She then, of course, we see the duties of a floor nurse circa 1887. So in addition to caring for your 60 patients, each nurse will follow these regulations. Daily sweep and mop the floors of your ward, dust the patient's furniture and window sills, maintain an even temperature in your ward, bring in the scuttle of coal for the day's business, and then goes on to talk about light is important. So you should trim your wicks for the kerosene. So that was nursing back then, which was amazing. Anyway, then she talks about writing nurses' notes. And so it's important that you whittle the nibs of your feathered pen to create these nursing notes. Anyway, it goes on. And the image of nursing was these prim and proper nurses that were kept in line by whom? By the doctors. Now, we see then as the image of nursing changes based on the wars, World War I, World War II, you see this virtuous woman who's calling to arms the soldiers and glamorous. Now, the one on the right, that doesn't look like any scrubs we're wearing. Then we see this glamour and the love stories of the virtuous nurse and, of course, the soldiers who were falling in love with them. And that was the image of nursing at the time. But in addition to that, a nurse was the handmaiden of the doctor. She was not her own thinker. She just followed orders. And so here she is holding, right, the hands of patients, helping with surgery only in the sense that she's there to be the handmaiden. She also then becomes the victim of whatever the doctor is trying to research. And that was part of the image. Now, at the turn of the century, we see a little bit of a twist, and that we see that in addition with the opening of the role of women in general. Now, instead of necessarily the doctors in control of the hospitals, you see here on the right side, this is the charge nurse. She's the glamorous nurse. And then there are her nurses and students who lived in the hospitals still because they couldn't trust the nurses to go out, right? Now, then we see the development and the advancement of the nursing role as technology advanced. The doctors then would pass down their information, their knowledge, their technology to the nurses. And so slowly, the nurses began to have more knowledge. Then hits World War II. And of course, we still see the vision of this virtuous nurse. So in the blessings of wars created more skill development for nurses, the expanding role, autonomy, advanced knowledge, and professional respect. And so that's kind of a odd thing to say is how wars helped bless, right? Now, 1950s, we see now younger girls are getting more modernized. The image of nursing is expanding. And we see now where we're looking at 1960s, the age of expansion of the image of nursing. Nursing theories, research, clinical specialties, growth of organizations, managed care, international nursing, men in nursing, shared governance, and the APRN role. So that is a wonderful little brief history of nursing, and we would say all is well. And so now we did, of course, some additional public views of nurses, and we have Hollywood and the media to either thank or be angry at for now this kind of developing image of nursing. So we have two polar opposite images. We have movies that show the nurse Ratched and the nurse Jackie, who are out of control, versus we have nursing still as voted the #1 most trusted profession by Gallup polls every year, except for 2001. And of course, that was 9/11, where firefighters very gratefully stepped into the first line of most trusted profession. The year after that, nurses were back on. 2020, the year of the nurse, declared by the American Nursing Association, truly became a very odd celebration in nursing, as we got a lot of public media press in way favor of nursing. So when we looked at this other image, study that was done, and it looked at the media's portrayal of nursing, we see huge differences. From nurses are 99% they're female, they're white, they're single, they don't have their own children, but they're less intelligent. They're nurses who couldn't get into med school. But the doctors, 92% of them are male, they're an older father figure, they're smarter, they're more compassionate. So that was media up to 1980. I think now, since 1980 and beyond, 40 years, we've seen some interesting changes. Some good, some not so good. Now we see, of course, this other media image of the naughty nurse, the nurse Ratched, that nurses work for doctors. This was a study done in 2010 still. So 10 years ago, these are still some of the stereotypes, that a nurse is the one that wears white uniforms and white hats. All nurses are female. If there is a male nurse, he's homosexual. Nurses cannot advance anywhere beyond the bedside. Nursing duties are really not that hard. Nurses are women who can't get into medical school, and we work for the doctors. So there's still some barriers to overcome. Now, public perception of nurses 2021. Still, nurses are someone who assists the doctor during and after the treatment of illness. We give medications as ordered by the doctor. We are a patient advocate, but we really don't have any power to make changes. It's still ultimately the doctor or the hospital's decision. Some dissatisfiers with people towards nurses is if they have minimal nurse contact, that they have lack of personalized care, they don't know what's going on, and then they can't even tell who the nurse is because everybody's wearing the same colored scrubs. So that's been kind of something that's interesting, as we need to be aware of that image. Now, some studies that I have completed in several countries are the following. That's what I wanted to share with you is the populations that I studied were patients that were in general medical clinics in Peru, Colombia, and Mexico. Now, in those, we saw many others from different countries, and so you'll see what that is. So overall, we just collected 200 of these surveys. They were done in person. 67 were male, 133 were female. The ages varied from 21 years old to 75 years old. The countries included all of these because some of them were immigrants or travelers, but then we also did a comparison study of some Americans. The study was a survey, a Likert scale, 10 simple questions while they were waiting. So here was question number 1. A nurse's weight affects the ability to give good nursing care. And the Likert scale was from strongly disagree, neutral, agree, strongly agree. So 36% of the Latinos agreed, whereas 50% of the Americans agreed. And what became a very strong theme, country after country, was that in the Hispanic, Latino population and culture, being overweight or obese was not seen as negative. It was seen as actually a positive, because if you have a heavy, overweight, or obese wife, that says to your community, I am rich enough to afford food to provide for my family. So the results were very interesting based on the cultural values. Question number 2 said an obese nurse cannot be a role model for health and wellness. Only 32% of Latinos agreed, 35% of Americans agreed. Now, if we added in the strongly agreed and just agreed, the American viewpoint went up to 75%. So that was kind of interesting. These were on the strong opinions. Question number 3, a nursing instructor who is obese cannot be a role model to students. So 46% of Latinos agreed, which was interesting. 47% of Americans agreed. And the next series of questions, a nurse who smokes cannot be a role model for health and wellness. Both 50% of Latinos and Americans agreed, just agreed. And we get into the strongly agreed, both numbers went up to 60 to 75%. So question number 5 said a nursing instructor who smokes cannot be a role model for students. 97% of Latinos agreed and 75% of the Americans agreed. So what was interesting is the weight issue, not a concern for Latinos, but across the board, they recognized that smoking was not good. Now I found this picture, which I found amazing, because this is back 1940s. And back then they're still using that image of nurses as pure, undefiled. And so the marketing was, if we can show a nurse that's smoking, then the very strong nonverbal messages, smoking is healthy, because there was this association that nurses are healthy. Well, that's what this study was exploring, is the nursing of image now still one that nurses are healthy or not? And can we be role models for health, or are we simply just the bedside managers of giving medications, right? So question number 6, smoking affects the quality of care given by the nurse. 95% of Latinos agreed, 74% of Americans agreed. Question 7, I prefer a nurse who doesn't smoke. 83% of Latinos agreed, 62% of Americans agreed. Question 8, I prefer a nurse who is not obese. Only 32% of Latinos agreed and 62% of Americans agreed. So we see some real cultural differences. And what I would love, of course, to do is to expand this study into greater numbers of the population surveyed and explore this image of nursing as a health role model in different countries. Question 9, I prefer a nurse who doesn't have tattoos. 39% of Latinos agreed, and then when we added the strongly agreed, that number went up to 55 to 60%. However, only 52% of Americans agreed. So again, we saw a difference of values, whereas Americans are more open-minded about visual tattoos on their nurses. So that was interesting. The last question, question 10, was I prefer a nurse who doesn't have facial piercings. So we explored weight, smoking or the smell of smoke, facial piercings, and tattoos. So the physical appearance of a nurse and how much of an impact did that make on the patient's perspective of the competency and the ability to be a role model of the nurse. So 50% of Latinos agreed, 40% of Americans agreed. And the basic study conclusions were an overweight or obese nurse, not an issue for Hispanic Latinos, as I mentioned earlier. The younger generation of patients in both countries were a lot more open-minded to facial piercings and tattoos. The older generation did not like the nurses to have tattoos, facial piercings. And when I say facial piercings, I'm talking about eyebrows and nose piercings other than earrings. The Hispanic Latinos don't believe a nurse that smokes can be a role model for health. However, the Americans were like, we don't like it, but most patients prefer a nurse who doesn't smoke, and Americans prefer a nurse who isn't obese. So the weight issue was a bigger concern for North Americans than they were for the Hispanic Latinos. Now, what are the implications of this one study? Nurses need to be aware of how their physical appearance impacts a patient's perception of their ability to be a role model for health and even competent. And that whole term needed to be explored and could be explored in a further study. Application of this knowledge is important for nurses to improve the image of nursing. So the modern image of nursing depends on nurses understanding their impact on patients' perceptions of their own power. Now, I did some additional studies on this image of nursing based on that first preliminary study, because I asked the same questions to nursing students and to nursing faculty. And here's the quick summary of what this was. The number of students was 187, faculty 252. In the genders among the students, we had 15 males, 172 females, faculty 38 males, 214. So clearly there's always more females than males in both faculty and students. The ages for students, no surprise, somewhere between 21 and 35. The faculty 35 to 65. All of this study was done here in the United States. And among those, we had both faculty and students, 52 were active smokers. And though we had, interestingly, 52 who had quit, who were previous smokers. So the average BMI for students was 20, and the average BMI for faculty is 25 to 30. So average for faculty is overweight. Another interesting study conclusion was students prefer a nursing student or a nursing instructor who doesn't smoke. The survey responders, this was interesting, who smoke were more likely to respond strongly against smokers, meaning if you were a nursing faculty and you were a smoker or a past smoker, you had a stronger opinion that smoking nurses could not be role models for health. It's like they were harder on themselves, which I thought was an interesting find. Students prefer a nursing instructor who's not obese. They valued the knowledge of that instructor, but they did not believe that they could be a role model for health. So there was a little important message and disconnect, I believe, for nursing instructors. And this was an interesting one. Instructors who were obese underrated their BMI. So as I was in the back of a conference room, right, passing out these surveys, I could see very quickly, right, is this nursing instructor or nursing professional normal weight, overweight, or obese? And then as I collected them in order, I could see who is it that's completed the survey and what were they really? And that was what was interesting, is an obese nursing instructor did not mark themselves as obese, but as overweight. And so there was a little reality disconnect on that as well. Now, both students and faculty both agreed that a nurse that smokes or is obese cannot be a role model for health. And that was super important because I have a sister-in-law who is an ER MD, and she is obese and she knows it. And she also knows she never talks about weight with her patients because she feels like a hypocrite. And so that's not fair, as she and I talk, that her patients then don't get full information because of her fear of being presented as a hypocrite. So that's a really important finding. Anyway, last little thing was students are a whole lot more open to nurses with tattoos or facial piercings. but they did not want to see them on their instructors. So I thought that was interesting. Now, the big question is then, okay, if that's now 2021 on our image of nursing, actually that was 2020, pre-2020. Another study now needs to be done post-COVID because of the year of the nurse, I believe, hugely skyrocketed our image very favorably. Now, what can we do though to improve the overall image of nursing? We need to be aware of our physical appearance. We need to be aware of our behavior, our communication skills. We need to be aware of letting the public know how much education it takes to be a nurse. We as nurses also have to recognize the competencies, and an interesting thought was reserve the name nurse for only registered nurses, because LPNs can look like nurses, they're called a nurse, but there can be years of difference in education, but the public does not know the difference. We need to be visible to patients and families, improve our own health. Now, so here are some additional references, and these articles will be published in the next couple months on some of these studies. So what I wanted to share was some of those interesting findings and hopefully improve our image of nursing beyond just the physical image, but recognizing the impact of physical image and be able to really be advocates for our own profession. That's the end of my formal presentation. I'd love to take any questions if anybody has some.
Any questions?
Hi, how are you?
Very well, thank you.
Thank you for your presentation about nursing image. I think for nursing image, we need more time to increase the nursing image, as in general, we are spending more time with the patient. We are the one do the critical thinking to find the patient that he need the emergency code blue, or he need the special medication or doctor care, but yet the doctor is more far paid than us, firstly.
Absolutely.
So when the nursing empowerment in the world reach to this point that we are as important as a doctor, I can say the nursing image will change. Second thing, I'm asking about the nursing image also. For me as a nurse, when I pick nursing, I'm Arabic also. So everybody look at me, this is a bad career. Only bad women take this career and everything. Even my uncle, because all my uncle are doctors, 7 of them, they see this as downgrading of me. And it's not smart choice, but it's the very thing I like to do it. And I always, the first 10 years of my life, I felt like man approached me in this way because I'm a nurse. So, yes. So as you say, how we can change this image in our culture or in our society or in our media?
Yes and yes. And absolutely, here in the United States, there was a very popular TV series called ER. And of course, it was one of the dramas of doctors and nurses and all the stories of the patients that are coming in. But every single season, the charge nurse at some point wanted to go to medical school because the doctors would say to her, because she was the major female figure, you're so smart, you should go to medical school. And so season by season, sure enough, that actress would be kind of dismissed from the series, and it was assumed she went to medical school. Finally, they got enough mail from viewers, nurse viewers, who said, hey, wait a minute, being the nurse is our choice and we are smart. So finally, they wrote into one of the last seasons, the charge nurse said to the doctor, I don't want to go to medical school. I know I am smart, and that's why I'm a nurse. And I remember watching that episode with my husband and going, yeah, finally, right? And so I think that because the female profession or the nursing profession has been female dominant, it has created that level of, what do I want to say? role differentiation. Men are superior, women are not, we are inferior. And so that has followed with the profession. The more men that come into nursing, I think is going to help change the image of nursing. When men in nursing say, yeah, I'm as smart as the doctor, and that's why I'm a nurse, because I prefer the bedside. I prefer the nursing knowledge. So and I very, very slowly am seeing the change to an attitude of team instead of the doctor is the God and all-knowing, and seeing the team. But that's very difficult because doctors are not going to want to give up their superior image and hand that over to a lateral colleague. So it's going to take, unfortunately, a long time, but we can still make the strides as we make nursing look attractive to men as a desirable profession that has equal or strong enough economic return. Men will choose that as their profession. And we're seeing this already with nurse practitioners and even PAs. So oftentimes nurses or PAs will go into that position rather than going into medical school because they'll say, I don't want that debt, but I can do the same or similar activities. And I'm smart enough to do either one. So it becomes preference of life and profession balance, which they can find in nursing often better than necessarily going into medical school. So it's kind of interesting. I think it's going to take a while. I think it's we as nurses understanding the power of our role and collectively working together to improve that image. Thank you for your question and comments.
I have one more question. I think before a while, I see one video about nurse was arrested in ER because she prevented the doctor, the police from taking blood from the patient. And she was really, for me, a good example of a patient advocate. So I want to ask from this scenario, the police arrest her because she's a female and she's a nurse. If it was a doctor and male, he will not arrest and he will listen to him. I want to know your vision from the story. What was the reason for the police to arrest her? Because she's a nurse and female? Because if it was a doctor talking and male, he will take silent and he will listen to him. I want to know what happened to this nurse.
Yes. So this was in Salt Lake City, Utah. And so the patient came in, they were a suspect. The police, of course, then come in. They are demanding the lab specimens. They want blood alcohol levels. They want drugs in the system because that would be a case against this patient towards his suspected crime. She then, recognizing, as the doctors did, no, we can't do that without a legal subpoena, and the patient has a right to privacy for their own medical information. So yes, of course, we believe that there was a male-female dominant issue involved with that. And I believe you're right, that if it was the physician that had stepped up and said, no, we cannot legally give you anything, the dynamics would have been different. But because a female was standing up to the male policeman, it became a small riot in that hospital, and she was hauled up. There was a huge public media response to that, and the policeman lost his job, and the nurse. So justice was served, and the nurse became a champion among nurses here in the United States because of her courage. What was a shame is that the doctors who were there did not stand up for her at the time. I think all of this happened so quickly that she gets cuffed and she gets thrown in the police car. It was like so fast. Everybody was like in shock, like, what? How in the world did that just happen? Now, of course, if we rewind and we learn from that experience, it would have been nice if the physicians had absolutely stood up and been an advocate for her. But it took a while, but justice was served. And that was a great movement forward for the positive image of nursing. So that was good.
Thank you. Thank you.
Any questions? Yes, we have got a questions from Dr. Sisi, madam.
Thank you so much for letting me share that research and that message. And thank you for all that you do in each one of your corners of the world. I'll take myself offline now so our next speaker can step up to the podium.
Yes, just you got a question from Dr. Yes, fine. Next. Thank you very much, madam. Thank you very much for speaking up in this meeting and providing industry. Thanks for sharing your tips with us. Looking forward to meeting again next time. Thank you for your second time as a speaker, as we are participating in this event in second time. Now we ask Dr. Rajini Sharma, the Assistant Nursing Superintendent from Homi Baba Cancer Hospital and Mahatma Pandit Madan Mohan Malviya Cancer Center from Varanasi from India to join the event and start presentation. Yes, madam, you can start your presentation.
Hello, am I audible?
Yes, madam.
A very good afternoon, a very warm welcome, and my regards to all the speakers, co-speakers, and my regards to the organizing committee for giving me this opportunity. So, I will share my screen.
Are you going to share your
I'm
screen?
not able to share my screen.
Yes.
Are you sharing my screen?
Yes, I'm going to share the screen.
Yeah, please. Is anyone sharing my screen? I'm not able to share. Hello.
Hello.
I'm not able to share. Is someone is sharing my screen?
Okay, you can share from the slide that is on the bottom. There is a green. The green one is, you did now.
Yeah.
You did. Okay.
So here I'm invited to speak on palliative care challenges during COVID-19, the lesson learned and recommendation from India. Next slide, please. Next slide, please.
Hello. Make it large. And you can make it large and you can enter for the next slide. Make it large.
It is showing host is disabled participant is screen sharing.
Display. It is making large. This next to that. What you did. Yeah. Now.
I'm not able to.
Yeah, you did now.
I'm not.
Yeah, you did. Yeah, you did.
Okay, so COVID-19 has caused unprecedented societal turmoil, triggering a rapid, still ongoing transformation of healthcare provision on a global level. So in this new landscape, it is highly important to acknowledge the challenges this pandemic poses on the care of the particularly vulnerable cancer patient and the subsequent psychosocial impact on them. Next, please. Shall I screen sharing from my laptop to avoid this delay?
Yes, you can go, madam.
Hello. Shall I start?
Yes,
screen sharing from my system?
If you're okay, you can start sharing, madam. Is it possible? Just
Actually, it is showing it is visible. It is showing.
You share.
So January 2020 marked. I want to share.
Just shall I stop sharing from here? Yes, madam. Shall I stop?
So so that we can avoid this delay.
Yes, I'll be stopping.
Please. For me, it is showing disabled. Screen host disabled participant screen sharing.
Actually, madam, just to go to the, you can find at bottom of the screen, you can find a share screen with the blue color, green color. So you can,
but it is showing host disabled participant screen.
Just a bin. May I know the name? Vaishali Sharma?
Vaishali.
Yes, now you can do. Yes, now you can do.
Okay, thank you very much.
Yes.
Yeah, now it's here?
Yes, it's going to start.
Can you see my slides?
Yes, madam.
Okay, I'm sorry for this unnecessary trouble. So January 20 marked as the beginning of the World Health Organization as Year of Nurse and Midwife. The current COVID-19 outbreak affecting 180 countries and territories across the 6th continent, taking its toll on healthcare system globally. In particularly, there is a growing pressure on the concern for the triage and palliative care departments. It has been reported that the incidence of SARS-CoV-19 infection is higher in a patient with the cancer in the general population, and that patients with the cancer are at increased risk of developing severe life-threatening complications from the COVID-19. There are many studies was done on this topic, and it has been seen that there is for the cancer patient, palliative patient, because they are already immunocompromised. Increased transmission and the poor outcome noted in emerging data on patients with cancer and COVID-19 call for aggressive isolation, minimization of nosophageal exposure. By the late spring, the world was in full global COVID-19 pandemic with the end nowhere in sight. Public health infrastructure proved that to be inadequate to support the hospital and healthcare workers, and without a coordinated national population, the local level established effort to control the virus at the local level. Many healthcare institutions struggle to procure needed personal protective equipments, cleaning supplies, therapeutics, and mechanical ventilators to care of the critically ill patients with the COVID-19. And it was a major problem that we have faced in India, especially because no one is prepared for the pandemic, and we have not expected that we will run with the shortage of the support system, PPE and all. And during that time, we have struggled a lot for taking care of the patients. Palliative care and the oncology provides are posed with the unique challenges due to the ongoing COVID-19 pandemic. Throughout this unprecedented time in society, oncology nurses have worked tirelessly to provide uninterrupted life-saving cancer care to the patient in a hospital and outpatient setting despite of the lockdown. Early on, oncology nurses knew that the cancer wasn't going to stop for the COVID-19, so neither could they. Too often, they have been the only human being in the room at the end of the life to assure the patient do not die alone, even during the pandemic. So many of the nurses, overtime duties, even in India, due to the shortage of the nursing and healthcare providers. So their work is really remarkable. So healthcare challenges, if I talk about as in India as a focus largely on the responding to the threat from the COVID-19, it has been forced to turn a blind eye to the death from the other preventable causes as a result of highly restricted access to the healthcare during the lockdown. And what we observe in our setting, that many of the curative patients landed to the palliative, the consultation, delay in the surgery, delay in the radiotherapy. So many of the curable patients that landed and came after 2 months, 3 months, 6 months in a palliative phase, and still, and maybe have lost so many lives because patient was not treated who are in remote areas. They don't have access to the analgesic, to the pain care, opioids, etc. The supply of essential drugs has been badly hit, as has been the attendance and workforce participation of the hospital person. This was another challenges that we face because many of the drugs, chemotherapy drugs in India are exported from the outside of the control like China, and also due to lockdown, we were in the scarcity of the many of the important chemotherapeutic drugs also. Slot availability for the teleconsultation was another challenges because we are in all the hospital in India, we have made of the teleconsultation, we have fixed the number in the teleconsultation, that too. Network issues are very prevalent in India, deferral of the radiotherapy dates, delay in the radiotherapy dates, a long waiting hours beyond the appointment time, transportation problem from the residents to the hospital, restriction of the visitor, attendance to the hospital was another challenge, deferral of the surgery, delay in the surgery of the tumor, delay and deferral of the advice of the nutritionist, extension of visa are also one of the challenges. Then unavailability of the people support services, psychological counseling session, difficulty in maintaining precautionary measures, availability of chemotherapy medication, availability of the chemotherapy slots in daycare, what the site faced by the cancer patient at level 1 cancer center. A study from China also suggested that the cancer patient infected with COVID-19 have a 3.5 times greater risk of mechanical ventilation, isolation, or the death as compared with the patient who do not have cancer. Here in India, they have made a few centers, they have marked few centers in the district administration or at the state level, they have marked few of the centers as to treat the COVID patient exclusively. So for treating cancer patient, we used to shift the patient to the medical colleges or the area. Because of the expected shortage of the hospital supplies and healthcare resources in general, difficult decision about how and when to provide cancer treatment have become necessity. Triage of the patient with respiratory symptom is critical to reducing the exposure of the patient and the staff. Outpatient posing the risk of COVID-19 to a larger population. Who is at the specific risk? So there are other two groups of the patient have been identified as a patient of therapy. A, who have completed a treatment or have a disease under control of therapy, and the patient under treatment, neoadjuvant or adjuvant curative treatment or the treatment for the metastatic disease. B, under category B, patient with the active disease can be eligible for surgery, chemotherapy, or the radiotherapy, biological therapy, endocrine therapy, immunotherapy, either in adjuvant or in a metastatic setting. So for all the type of category of the patient, A and B, it is mandatory to provide the health education, avoid crowded places, wear PPE when you attend hospital for visit and treatment, correctly wash your hand according to the World Health Organization guidelines, do not have contact with friends and relatives with COVID-19 symptoms or living in endemic zone. Guarantee social distancing with all people, protect yourself and to the others. For a patient receiving active treatment, like the patient who are in category B, living in epidemic zones or not in hospital, should identify a specific pathway in order to guarantee timing of the treatment with curative intent, and when possible, also the patient with a metastatic disease. Outpatient visit of the cancer patient should be reduced to safest, most feasible level without jeopardizing patient care. For a patient receiving oral treatment for which monitoring can be done remotely, drug supply should be provided for at least 3 courses to reduce access to the hospital. Blood monitoring for the patient can be done in the local labs close to the time. So this is what we did in our hospital. So the patient who are on oral chemotherapy or on the hormonal therapy, we made them to do the investigation, the follow-up investigation in the near local labs, and they can send us, because we have a total online system, so we make them to upload the photos, upload the investigation, so that the treating consultant can monitor and advise according to the reports. In palliative cancer patient categories are risk include patient receiving chemotherapy or who have received chemotherapy in the last 3 months, patient receiving extensive radiotherapy, patient who had bone marrow or the stem cell transplantation in the last 6 months or who are still taking immunosuppressive agent, people with some type of blood or lymphatic system cancer which damage the immune system even if they do not have not needed treatment, for example, chronic leukemia, lymphoma, or a myeloma. So this indicates the patient who are in chemotherapy, radiotherapy, these patients are actually already immunocompromised, so they are more prone to get COVID-19. Specific risk group in the cancer patient with an impaired immune such as leukocytemia, low immunoglobulin levels, low lasting immunosuppression, steroid and antibodies. So special attention should be considered in the case of the recent new symptoms such as fever, coughing, sore throat, difficulty in breathing, muscle pain, tiredness, insomnia, dysgeusia. In such situation, recommendation include test for the confirmation, if not clearly done. RT-PCR, SARS-CoV-19 testing should be proposed to all patients undergoing surgery, radiotherapy, chemotherapy, immunotherapy, if feasible, and ideally before each treatment cycle. So this is what we made in our setting. Before, in the pre-op patient and the pre-op patient who are receiving radiotherapy, we make them to do RT-PCR mandatory, but for the patient who are coming for the chemotherapy on the daycare basis, we used to admit those patients. We are not in a daycare basis, and with the strict policies, with strict precaution, we are giving chemotherapy to those patients. It is also proposed to the patient in a follow-up or cancer survivors if they present with a symptom suggestive of COVID-19 infection. Serology, if available, should be proposed to identify previous COVID-19 infection in all cancer patients. If a capacity is limited, RT-PCR SARS-CoV-2 test can be proposed to all the patients with the suggestive symptoms of COVID-19 infection being in active treatment, in a follow-up phase, or a survivor. If a serology is limited, it should be proposed to all the patients undergoing surgery, radiotherapy, chemotherapy, immunotherapy, or any active anti-cancer treatment. Assess severity by clinical, radiological, lung function, and a biological test. Evaluate the need of the patient in terms of hospitalization in a dedicated units. Cancer care prioritization. So according to this, patients are classified into 3 categories. First is the high priority. So patient condition is like we do triaging. So in the high priority, patient condition is immediately life-threatening, clinically unstable, and the magnitude benefit qualifies the intervention as a high priority, significant overall survival gain, and substantial improvement in the quality of life. So in medium priority, the patient situation is a non-critical, but delay beyond 6 weeks could be potential impact overall outcome, or the magnitude of the benefit qualifies the intermediate priority. In category 3, that is a low priority, patient condition is stable enough that services can be delayed for the duration of the COVID-19 pandemic, or the intervention is a non-priority based on the magnitude of the benefit. For example, that is no survival gain with no change, no reduced quality of life. So the recommendation continue. We suggest implementation of the telemedicine services. We advise to delay all follow-up visit. More intensive surveillance should be used during the treatment for the patient with the lung cancer or who received previous lung surgery, and for the older patient or those patients with other comorbidities. Intensive measures should be undertaken to avoid nosocomial spread. There should be a strict and safe triggering procedure to assess any COVID-19 symptom and the urgency and the necessity of hospitalization in order to regulate the access to the cancer hub, establish checkpoint area screening for early detection of the potentially infectious person. Clinical staff responsible for the checkpoint should be trained to wear PPE. That is very important. Individuals who meet the criteria for highly communicable diseases requiring isolation, such as novel COVID-19 or other emerging infection, must be placed in a private exam room as soon as possible, as per the infectious control guidelines. They should be tested and transferred to the COVID dedicated areas. Expanded approach using the other additional stuff such as staff, space, system, sedation, separation, and communication equity. So in this, first thing is the stock. They are advised on stocking medicine such as morphine, haloperidol, midazolam, and scopolamine. This would provide a comfort to the critically ill palliative patient. Also advise stocking of a personal protective equipment for palliative healthcare providers for a long-term care. Call for the suspension of the regulations that bind the availability of the injectable opioids. Adequate staffing with a clinician who have experience in palliative care. All frontline care providers need a brief training in palliative care, management of acute respiratory symptoms, and also ensure the safety. Allied healthcare staff should be trained to provide support to the patient, bereaved family members. So I'm continued with the recommendation. So here the recommendation continues with the optimum utilization of the hospital space and resources. Separate what needed to earmark for the COVID-19 patient. Palliative care unit for dying COVID-19 patients are needed. A triage system need to be adopted to determine which patient requires specialist palliative care consultation and which patient can be seen virtually. Telemedicine can be used effectively and would also reduce infection risk. Palliative care provider groups can be formed for a support and coverage. Here, the problem in India with the telemedicine is that the majority of the patients are coming from the rural background. They are not that much techno-friendly to use the teleconsultation services. And here, on OPD basis, daily we are in our OPD, daily 1,500 patients are reporting, out of which 20-25 registrations on average 20 to 50 registration we are getting, patients are registering as a new patient. So teleconsultation is a challenge, one of the challenges that we have faced in India. Palliative sedation plan need to be placed for those who are refractory to the common comfort medication. Video calling should be initiated to connect dying and critically ill patient with the family members, especially if they are separated because of the infection risk. Communication is the key to the palliative care, the authors write. The team says the communication and the need to uphold the patient wishes are paramount. Equity in a care is a vital. All patients, irrespective of their group, disabilities, trauma, socioeconomic status, and access to palliative care need to be cared for. So I can conclude my topic here. So the importance of the self-care should not be overlooked. As in our center, so many of the nurses got infected with COVID-19, but thank God no one, everyone has recovered well. The authors, right? Today, the leadership of the incident command rotates every 2 weeks to assure needed downtime. To many of us, has become the healthcare challenge for our generation, one that modern cancer therapies has never had to face. We will prevail, and when the pandemic ends, we will all be proud of what we did to our patient and each other in the critical moment of the humanity. And it tries system that doesn't integrate palliative care principle is unethical. Patients who are not expected to survive should not be abandoned, but must receive a palliative care as a human right. So I'm here with winding up my topic. I would welcome if any questions are there.
Yes. Any questions? Any questions to Dr. Rajini Sharma? Any questions? Thank you very much, madam. Thank you very much for speaking up in this meeting and during it. I think you are in a hurry in preparing your PPT as you joined yesterday only. Yes. Thanks for sharing your yes. Thanks for sharing your tips with us. Looking to forward to again next time in physical event if everything goes well. On behalf of Organizing Committee members of Nursing Education Congress 2020, we want to thank for instant presentation. Looking forward to meet again next time. Now we welcome Dr. Michael L. Blackwell, School of Nursing from France, Care Missionaries of Our Lady University from USA to join the event and start presentation.
Hi, thank you. Can you give me permission to share my screen?
Yes, definitely. Yes. Is it fine, ma'am?
It still says host disabled participant screen sharing.
Yes, you can do it.
Ah, got it. All right. Thank you so much for having me. So I'm going to review a study on nursing student dropout behavior using event history analysis. And I'll talk about what event history analysis is for those of you that don't know. So the problem for this study was nursing student shortages, declining enrollments, and high rates of attrition in baccalaureate nursing programs present a public health concern. We're experiencing a nationwide nursing shortage, so we need more nurses to graduate nursing school. The ill-understood nature of nursing student dropout behavior leaves nursing programs guessing at ways to improve student retention. Nursing program attrition is as high as 50% overall and up to 85% for underrepresented groups. Some attrition is inevitable, however. The need to assure client safety and maintain professional standards outweighs the risk of lenient retention policies. So we do have that duty to protect the public from students who will not be clinically competent, but we could definitely do better than 50%. The purpose of the study was to examine student level data to identify factors that predict student dropout from an undergraduate nursing program. The retention efforts can be targeted to students who most need them, facilitating both cost-effective efforts, because we all know that retention efforts in universities are very expensive, but it's also very expensive to lose students. So that revenue-saving retention of students would also be definitely a plus. Event history analysis allows us to study the longitudinal nature of events such as student attrition and allows prediction of the timing of student dropout so that retention efforts can be better utilized and effective. The conceptual framework for this study was Jeffrey's Nursing Universal Retention and Success Model. It includes multiple influencing factors, including student profile characteristics, environmental factors, student affective factors, academic factors, and professional integration factors. And I have some examples of each of those factors there on the slide for you. These factors combine in unique and varying ways, contributing to the student's ability to complete a nursing program, their decision to stay in a program or drop out, and their ability to pass the licensure exam, but also their decision to stay in the profession of nursing after graduation. The research questions for the study were which student level variables predict nursing student dropout risks over time, and which variables predict nursing student retention over time. When are nursing students most likely to drop out? The null hypothesis for the study was that there is no difference in the risk of student dropout among the student level variables. As I said, this was an event history analysis, which is a type of linear regression that measures the likelihood of an event, in this case, student dropout, at a particular time, and in this case, it was semesters in the nursing program, based on covariate factors. We can investigate the probability that an event will occur as a linear function of one or more explanatory variables, and we can investigate what factors explain whether and when an event will occur. It can account for censored data, so that data from cohorts that are still enrolled in the program at the conclusion of data collection but have not yet completed the program, those students' data can be used. We don't have to lose their data just because they're still in progression at the end of data collection. The data source for the study came from a single undergraduate pre-licensure baccalaureate Bachelor of Science in Nursing program. All students admitted to the program for a period of 4 years were included in the study. The 2019 first-time pass rate on the licensure exam for this particular program is 100%, but current retention rates are between 44 and 56%. The program is accredited by local, regional, and national accrediting bodies. Variables for the study, the dependent variable, of course, was time to drop out. Independent variables included exogenous variables that do not change throughout the program. So their age and enrollment, gender, ethnicity, and race, pre-nursing GPA, entrance exam score, grade in the prerequisite pathophysiology course, and then some time varying regressors that do change as the student progresses through the program, such as their financial aid status and their semester specific GPA. The survival function is the survival probability of a subject surviving beyond a particular time, and the hazard function is the probability of the event occurring at a given time. And in this study, time was measured in discrete units, particularly semesters in the nursing program. So 498 students entered the program between fall 2015 and spring 2019. 121 students experienced dropout during that time. Of those 121, 82 were dismissed from the program due to course failure, and 39 were eligible to return but chose not to. Of those 39, 14 of them had already failed one nursing course, and the progression policy in this program is a second course failure would result in program dismissal. On average, students who experienced dropout were older, so 25 and a half versus 24 years, had lower pre-admission GPA, so 3.0 versus 3.2, and entrance exam scores were slightly higher in those who did not experience dropout. Okay. The study population was predominantly female at 89%, predominantly white at 65%. Most students, so 79% of students, had at least some form of financial aid at program entry, with an average age of 24, an average pre-nursing GPA of 3.17, and an average entrance exam score of 82. This chart represents the hazard ratio for all the variables. The hazard ratio is a comparison between the probability of event occurrence in one group compared to the probability of event occurrence in another group. If the hazard ratio is 1, the probability of occurrence is the same in both groups. If the hazard ratio is 2, the probability of the event is twice as high as in the other group, and so on and so forth. If the hazard ratio is below 1, then the probability, like for example, if the hazard ratio is 0.5, the probability of the event is half as high as the other groups. So for each additional year of age, the risk of dropout increased by 3%. Compared to Black students, white students were 41% less likely to drop out. Risk of dropout decreased by 62% per unit increase in pre-admission GPA, so that was a big difference, and a 6% decrease per unit increase in entrance exam score. So the entrance exam score was less predictive, but still predictive. Compared to having a grade of A in the pathophysiology course, which is a prerequisite for this particular program, having a grade of B, C, C+, D, D+, or F in the pathophysiology course was associated with a higher risk of dropout. That risk ranged from a 1.4 times higher for a grade of B to 8.6 times higher for a grade of F in their first attempt at that course. They are allowed to repeat the course, but the association was only significant for grades of C, D+, and F. Let's see, although the risk of dropout was lower when comparing students who received only scholarships versus students who had no financial aid during their first semester, there were no statistically significant associations when comparing other categories of financial aid versus no aid. In the baseline covariate adjusted model, the age and letter grade in the pathophysiology course first attempt were not statistically significant predictors of dropout. Among Asian students, the risk of dropout was more than 3 times as high as among Black students. There was no difference comparing other racial categories versus Black. Although there was a 40% reduction in risk of dropout per unit increase in pre-admission GPA, this did not attain statistical significance. And the risk of dropout decreased by 3% per unit increase in entrance exam score, but this association did not attain statistical significance either. In adjusted models, including time-varying covariates, only semester-specific GPA was statistically significant predictor of dropout risk. For every unit increase in semester-specific GPA, the risk of dropout decreased by 59%. So students who did better each semester were more likely to persist. Semester-specific financial aid was not included as a time-varying covariate because while scholarships only category appeared to be statistically significantly associated with the risk of dropout in the unadjusted models, there were many students who also received scholarships in the combined category. So this variable was therefore excluded in the adjusted regression model to avoid a biased inference. Because of the complexity of financial aid packages and how one student's financial aid package may change over time, financial aid was recoded as a dichotomous variable using the categories some aid versus no aid. And compared to students who had no financial aid, the risk of dropout was more than twice as high in students who had some financial aid during their first semester. However, risk of dropout was lower among students who had some aid during the second, third, fourth, and fifth semesters compared to students who had no aid, although this association did not attain statistical significance for the third and fourth semesters. So it's an interesting, unexpected result there. So the Kaplan-Meier survival curve is the cumulative probability of surviving a given time, and that is seen on the y-axis there. You'll notice the decrease in likelihood of experiencing dropout at each subsequent level. The likelihood of experiencing dropout drops dramatically as the students progress on through the program. So older age at admission, with the risk increasing by 3% per year, was a predictive factor. So we should further examine the perceptions of older students to determine if it's lack of peers, a difficulty with technology, because we do employ a lot of technological resources. We have an ebook package and that kind of thing. Additional commitments or a combination of these that contribute to the increased risk of dropout for our older students. They do tend to have more responsibility, families and that kind of thing, than our younger students do. Students of color, particularly Asian students, are at the highest risk. So this could be a lack of role models among classroom and clinical faculty that may contribute to social isolation for Asian and Latinx students at the study institution. There's also the model minority myth that we have to take into consideration, where stereotyping Asian students as a high achieving group negates the academic diversity within that group, and it creates pressure to achieve success without much assistance. Faculty must not assume that Asian students understand class material because they did not ask questions in class. So we need to be careful with that. Lower grades in the pathophysiology course were predictive of dropout. And that pathophysiology provides a foundational knowledge upon which the students build their nursing knowledge throughout the program. So a really strong foundation in pathophysiology contributes strongly to success in the program. But the grading scale, interestingly enough, the grading scale for the pathophysiology course is the same as the grading scale for the nursing program. So all of the other nursing prerequisite courses are under the university standard 10-point scale, but the pathophysiology course, because it has an NURS prefix, it does use the 7-point nursing scale with the lowest C as 80%. So a C in the pathophysiology course percentage-wise does translate to the same letter grade in a nursing course. So for each unit increase in semester-specific GPA, the risk of dropout decreased by 59%. Students who have already failed one course, so their GPA is dramatically lower for that semester, are at highest risk for dropout. But we also cannot discount those students that are not currently identified as at risk. Our current retention plan involves intrusive advising for students who are repeating a course, but once they pass that course and move on, even though they are out of progression and they are still at risk of dropout with one more failure, they are not currently followed with that retention plan. So we need to expand who we identified as at risk. Students who had scholarships only in the first semester were 59% less likely to drop out, but this did not hold significance in any other semester. But when financial aid was examined as a dichotomous variable, students with some aid were more likely to persist than those with no aid in the second through the fifth semesters. Obviously what we totally expected to see was that, and those of you who are nurse educators will know it's completely expected that the first semester has the highest attrition. Beginning a nursing program is a major challenge for students. Many of them underestimate the time, effort, and organizational skills required. Help with time management, organization, study skills, that kind of thing can help, but students' families also need information so that they can have a realistic expectation of what the program will be like for these students and a better understanding of their need for support. So some implications for practice that come from this study. We need a family orientation for incoming students to improve family understanding and support and provide a realistic expectation of time commitments. The institutional advancement team can target efforts toward increasing scholarships. Results from the study can be used as evidence that scholarships do impact nursing student persistence and can be used in a case for support for charitable giving. Our retention resources should be focused in the first semester courses and the pathophysiology course, because these are the courses that most significantly influence dropout. A peer mentor tutor program for upperclassmen and first semester students may prove more successful. Staffing organized paid peer tutors at the institution has been problematic because so many of the senior students are reluctant to give up their own study time to serve as a paid tutor for the university. Implications for policy, there may need to be a curricular change in that pathophysiology course. It may be offered in an alternate format. They may be able to include some anatomy and physiology review modules, and have smaller sections. Currently, those sections are between 50 and 60 students. The plan for the upcoming fall semester is to have smaller sections of no more than 20 students. Incidentally, that plan is because of COVID and social distancing and classroom space availability, but I believe that it will help with student attrition as well. Campus initiatives for diversity and inclusion are another major need. Students of color are more likely to experience dropout, and so at the time of data collection of the study, there were no campus programs, student organizations, or anything aimed at diversity and inclusion at the study institution. Nursing programs also have to consider that minority groups are not the only students who need support for inclusion. Diversity in nursing also means male students, older students, veterans, as well as students of varying religions and sexual orientation. The limitations of the study included the fact that the data was collected from a single small private institution. Only 4 years of student data were used, and it only examined those student profile characteristics and academic factors, not any of the other domains of that NURS model. So suggestions for further research involve collecting data from the other domains of the model, the affective factors, perhaps surveying the students for self-efficacy, that kind of thing, other environmental factors, family support, employment, and then professional integration factors like participation in student organizations, the Student Nurses Association, that kind of thing. Another suggestion would be data mining of their transcripts, so performance in specific courses such as anatomy and physiology, where they went to high school or college, whether they obtained any of their prerequisite credit through dual enrollment, that kind of thing. None of that was collected and would provide perhaps some more insight. Conclusions for the study: nursing student dropout is a complex, multifactorial problem. The results demonstrated that previous academic experience, age, race, financial aid, and ongoing academic performance were predictive of nursing student dropout to some degree. This study is a good start in understanding nursing student dropout behavior and suggests avenues for further research in this area. There is no need, however, to have every aspect of the dropout equation accounted for in order to take action. Even small gains in student performance can be used as evidence to enhance and expand retention efforts. I have a very brief reference slide for you, which will be available. And then here is my contact information. Does anybody have any questions?
Yes, any questions? Any questions? Any questions to Dr. Maichil Blackwell? If you have any questions, you can text in chat box. We'll be asking behalf of you.
Thank you.
Hey, this is Dr. Long in Las Vegas, Nevada. Michelle, thanks for your work and your research on that. And I teach at a college that has a lot of the majority non-traditional students. And we do see the classic attrition first semester. And a lot of that can be just their own self-awareness of, hey, this isn't what I thought it was. And so I'm moving on. And for those students, I applaud. How do you deal with a student who wants to be a nurse, who is just really not understanding the concepts? They're scoring poorly. They've got life barriers. You know, we want so much to help them. We try, and yet they still are just not doing well. I have never said out loud to a student, maybe this isn't for you. So what is another better way to say that to a student?
Yeah, that I'm the retention coordinator for the undergraduate nursing program here at Franciscan University, and we I have to have those conversations all the time with students, and I'm the person they come to. All of their faculty send them to. You need to go talk to Dr. Blackwell. So here they sit in my office, and I have to have those conversations with them all the time. And and you're right, it's very difficult to tell a student, I just don't think you're cut out for this. So what we do is we talk to them about their studies. What kinds of time are you putting in? How are you organized? And give them just a much better idea. I have like a sample calendar that I show them that has study time blocked out in the appropriate amounts for a 4-hour didactic course plus clinical time. Our first semester nursing courses, they take a 3-hour pharmacology course and a 7-credit-hour fundamentals course, which is 3 hours didactic and 4 hours of clinical. And I lay out for them, this is how many hours you should be studying every week. This is how many hours you are in class. Here's how many hours you're in clinical. Here's an example of what a calendar would look like. Now, what does your calendar look like? And a lot of times they come to the realization that, wow, I haven't been doing anything like that. I haven't been studying nearly that much. And so then we'd have that conversation about, okay, well, what's keeping you from doing that? And is it because you just don't feel like putting in that kind of time, or is it because you have all these other commitments, or what can we do to get you to where your calendar can look like this? And sometimes they decide, I can't put in that kind of time commitment. And so then we figure out, well, could you withdraw this semester and sort of get your life together and then maybe come back next semester where you have more time. Some of them decide they're just not really mature enough to do it, and they want to have that more traditional undergraduate college experience. And we're a commuter campus. We don't have teams. We don't have games to go to and lots of big student organizations. We don't have residence halls. So they're missing out on a lot of that undergraduate experience coming here anyways, but sometimes they just decide, I think I want to get a more traditional experience first. And sometimes it's very expensive as well. And so sometimes they sort of self-select out because of financial reasons. But you're right, it's always a very difficult conversation. But I try to help them see this is kind of what it's going to take in order for you to be successful, and how can I help you get to this point, or can you, or do you want to, And yes,
right. I think those are excellent ideas. And even for like our nursing fundamental students, we literally show them a 24-hour time period and then a week period calendar. And I actually have a little game with them, and they put little markers that represent 2 hours. And there's always a big aha. And that's on day one. But I think as the semester goes on, they still don't really understand. So I just sent you a little chat. Thank you so much for your presentation, but I would love to see if you have a sample calendar for a typical semester one. And I can manipulate the differences of our credit hours compared to yours, but even if you had a template, that would be super helpful.
Yes, I'll send it to you.
Thank you so much.
You're
I think our
welcome.
programs sound very similar, and that's good. Thank you.
You're welcome.
Yes. Any questions further? Any further questions? Yes. Yes. Thank you very much, madam. We have enjoyed your speech. Pleased with your topic. Looking to meet you again next time.
Thank you.
Yes. The next speaker will be Dr. Juliet Albro from University of Port Harcourt, teaching in hospital from River State of Nigeria.
Just a minute, please.
Yes.
Can you see me?
Just start sharing your PPT, madam.
Just a minute, please. Good day, everybody. Can you see me?
Yes, just sharing your
Dr.
PPT.
Renato. Okay.
We don't find your PPT.
Good day. All right. I'm with you. Greetings from Nigeria. It's my pleasure to be one of the speakers I am delighted, and I want to appreciate the organizers of this program. Can you see my slide? Okay, permit me to share my slide.
Yes, just start sharing your slide.
All right. Can you see that? Not yet. I'm having some issue here.
In bottom of the screen, you can find with the green color share screen. Just you can upload your PPT through share screen. It will be available. It will be visible to everybody.
Okay. Can you see my screen now?
No, not yet.
Okay. Who's disabled participant? The host has disabled my screen sharing.
Just will you share to us? We'll be playing behalf of you. Just you can go to WhatsApp and you can send your PPT to me.
Okay.
Meanwhile, we'll go with alternate speaker instead of wasting time.
Okay, please just give me a privilege to be the next speaker.
Yes, yes. So
thank you very much. Let me be the next speaker.
Yes, yes.
Thank you, so that I can organize my.
Yes.
Thank you very much.
Yes. It's better to go with the next speaker. Dr. Nadi Sylvia and Inovine Organizes from University of Nigeria, from Nigeria as well, to start the presentation. Just you start playing your PPT. Yes, Doctor Sylvia, just you can start your presentation. Sylvia Nadi.
Yes, I'm here.
Yes, you can start your presentation. Just start sharing your PPT on the screen. Yes, you can start your sharing the PPT.
Yeah, I said I need a few minutes to do that. I thought I was the next speaker.
Yes.
Now, so somebody can start. Somebody else can start.
Just you can take, or else we'll do one thing. Just we'll take a 5 minutes break and we'll rejoin again.
All right. That would be nice.
Yes. So, dear participant, just we'll take our 5 minutes break and we'll join sharp by 12. We'll be joining around 12:40 according to EDT. Yes. Yes, madam. Shall we start the program? Hello, Dr. Juliet. Shall we start the program? Yeah, doctor. Shall we start the program?
Oh,
Yeah, doctor. Shall we start the program?
unmute you. Hello, can you hear me?
Yes, yes. You can go with your presentation.
Okay, okay. Good day, everyone.
Yes.
It's my pleasure to be one of the speakers for this summit. Please, can you hear me?
Yes, it's fine.
All right. Can you see my screen?
Yes.
Okay. So, pregnancy is a thing of joy. In Africa, and especially the area where I come from, if a woman is pregnant, the community, the family, everybody's happy. But sometimes this pregnancy does not end up successfully. Some are eventful, while some are uneventful. Now, the challenges some women had during pregnancy, it brings about convulsion, bladder edema, high blood pressure. With this, I introduce the topic, the prevalence and causes of preeclampsia amongst pregnant women attending antenatal clinic in Central Hospital, Warri Delta State, Nigeria. This is all about me, Juliet Alabra, PS nurse, a registered pediatric nurse, a midwife, senior officer, Central Hospital, Warri Delta State, Nigeria. Preeclampsia has been described as hypertensive disease of Africa, which accounts as one of the leading causes of maternal mortality in Africa. Citation Nakimuli et al., 2013. It is often referred to as hypertensive disease, and it was reported to be a common condition that prevails in any of the cases of obstetric morbidity, hypertension, and proteinuria, according to Heros et al., 2012. Early diagnosis of preeclampsia by medics showed that medical strategies applied by developed countries using a combination of early detection strategies and increased access to hospital care for women who develop preeclampsia reduced its prevalence and mortality by about 90%, according to Kim et al., 2013. It is often referred to as hypertensive disease, and it was reported to be a common condition that prevails in any of these cases. I think I've taken this before. Now, in my screen here, can you see this in this picture? There is a teenager who is pregnant and diagnosed with preeclampsia. She was delivered of twin boys, and that's the mother carrying the babies. The mother is giving the babies kangaroo mother care, because it is a challenge for teenagers to give birth. This lady or this girl cannot take care of the children. The mother is taking care of the babies. Then another thing, with the challenge of preeclampsia, it's a big problem. I worked in the labor ward for 2010 to 2015 before I went to specialize in pediatrics from 2017. While I was in the labor ward, there was a day a woman was rushed down to the labor ward. She was convulsing a pregnant woman. Immediately, they attended to her with other medical staff around and other health personnel, health team. Emergency CS, cesarean section was performed, and she was delivered of a baby girl, but the baby had severe birth asphyxia because of this condition. It is seen as a problem. Apart from that lady, another instance again, the group of women went to antenatal clinic and suddenly one of them fell down. She was rushed down to the labor unit too. And when we took the vital signs, her blood pressure was about 180 over 120. Then what happened? She did not know that she has high blood pressure. So with these few examples I've given, or this instance, it's a problem worldwide. According to the World Health Organization, in 2013, approximately 289,000 women died globally from pregnancy-related causes. 99% of deaths occur in developing nations. Preeclampsia and hypertensive disorder of pregnancy were reported as one of the leading causes of maternal mortality and morbidity amongst pregnant women in the world, according to Osunbade and Ike 2011. The objective of this study is aimed at assessing the prevalence and its associated factors of preeclampsia amongst pregnant women in Central Hospital, Warri, Delta State, Nigeria, between the period of January to June 2019. The table here, table 1 here, shows the prevalence of preeclampsia among pregnant women. And during this study, some questions were asked in order to get data from these women. And some of them, we find out that it was their first pregnancy. About 48 of them agree that yes, this is their first pregnancy. Then those that were currently on prescribed medication to lower their blood pressure, out of the 200 responded, 46 of them were on medication to lower their blood pressure. Those that carried their pregnancy that lasted more than 6 months were 156, while 42 of them could not carry their pregnancy to 10. And those that their pregnancy could not stay more than 6 months, about 18 of these women and 24 of the respondents. During the study also, some of them had preeclampsia and eclampsia, even toxemia, 28 of them, while 137 of them were positive. Protein in their urine also, those that had seizure, 2 of the women had seizures during the study. High blood pressure also, were positive. 16 of these women came up with high blood pressure. These other issues during the study, indication of cesarean section, 6 of them had cesarean section, and 12 of them had fetal distress. There is also an indication for abruptio placenta. 6 of these women had abruptio placenta. Then those that were currently on drug during the study, 24 women were on drug during this study. And the level of proteinuria, 144 of them were normal, 56 had abnormal during test. Now, because of this challenge, it poses problem to the society. Now, the economic impact on this case, when there are no funds to access medical facilities, to pay hospital bills, antenatal investigation, and so on, it is difficult to diagnose the condition, thereby resulting to complications leading to maternal fetal morbidity and mortality. there are some things that we can use to control these measures. And some of these control measures of preeclampsia include health education to the public on preeclampsia, because there are a lot of persons out there, they don't know what this condition is all about. Like in Nigeria, the parts where I come from, those women that I told you people at the beginning of this presentation that were rushed to the hospital, some of their relations were surprised and say that they've not seen a case where a pregnant woman is convulsing. That could it be what they have done? Like in Africa here, sometimes they bring some traditional belief to conditions that affect them or some diagnosis. They relate some African traditional belief. And one of the relation was asking that faithful day that could it be that the woman has done something wrong, that she should come out and say to the family member. So the public need to be educated on what preeclampsia is all about. And if they get to know what preeclampsia is all about, when they see conditions like this, they will be immediately take this person to the hospital or advise the person to go and see medical expert. But when the public, they don't know what the condition is all about, they have poor health seeking behavior. Even going to the hospital is a problem. They will not go to the hospital and they have challenges. Before they get to the hospital, what happened? It's already late. So the public need to be educated on the condition. The antenatal screening need to be done, proper antenatal screening. Every woman that comes to the hospital for antenatal care, they should screen them for what? For preeclampsia. The hospital should be well equipped to be accessible and also to be affordable. If the hospital is not accessible, the pregnant women find it difficult to go to the hospital. And if the hospital bills is not affordable also, it becomes a problem. Like in my facility, the Delta state government decided to render free maternal care to every pregnant woman. So from the first day you are pregnant till the day of the delivery, whether normal delivery or cesarean section, they give them free maternal care in Delta State, Warri, where I work. Why is the government doing this? They want to help and assist pregnant women, and in order to reduce maternal mortality, because preeclampsia is one of the causes of maternal mortality in Africa. Then there should be adequate diet also. Some of them, because of their socio-economic state, they want to maybe go on and eat whatever they like in our part here. They like eating junk, a lot of junk food, fatty food. And by the time you start taking a lot of fatty food, what happens? It increases the cholesterol level in the blood and thereby narrowing the blood vessel, which increases the blood pressure. Then there should be adequate rest and positive attitude of health workers. I will say much on this. Health workers need to intensify their attitude. When there is positive attitude of health workers, it encourages clients to come to the hospital. It encourages them to access the health facility. But when the health workers have negative attitude, nonchalant attitude towards emergency, towards caring for patients, and you see people don't like going to the hospital. Like the area where I come, I always use that as an example. You see people running away because of the attitude of health workers. But in my facility, Central Hospital Warri, we are trying our best to see that the health workers give support to those accessing the hospital. We try to go against negative attitude, because when the health workers have negative attitude, people don't access the hospital and they decide to go to the quack, or they patronize the traditional birth attendant, or they go to tradomedicals to encourage. For us to encourage them, we need to do what? To put up positive attitude. The antihypertensive medication is also used to control these measures. If they are properly screened and they notice that their blood pressure is high, they place them on antihypertensive. The causes of preeclampsia among pregnant women is unknown, but there are some risk factors Some of those factors include history of high blood pressure. So prior to pregnancy, the family history of high blood pressure prior to pregnancy also, family history of preeclampsia, history of obesity, history of diabetic mellitus, kidney-related problems. When they have kidney-related problem and the woman is pregnant, coupled with the pregnancy hormone, it will now increase these chances of having high blood pressure during pregnancy. There is a table that shows the causes, those risk factors that were related to them. And during the study, 65% of the respondents strongly agree that high blood pressure is one of the causes or related factors. 45 of them agreed, 52 disagreed, 24 strongly disagreed, and 14 of them were just neutral about it. Also, the family history of preeclampsia also contribute to this condition. 41 of them strongly agreed, 62 agreed, 54 disagree, while 21 strongly agree. Then you go down, you see also concerning obesity, concerning history of diabetes mellitus, also kidney problems related to it. Some of these women agree, while some don't agree about it. Then pregnant women carry more than one baby, that's multiple pregnancy. 36 of them strongly agreed, 66 agreed, 42 of them disagreed, and 32 strongly disagree, while 24 of them, they're just neutral about it. Poor nutrition also contributes to it. Then having complicated pregnancies prior to a new pregnancy, it's also a contributing factor to this condition. These other parameters that were used also concerning the blood pressure, proteinuria on admission, gestational age on admission, then those that perform ultrasound scan to know what's going on and to know the gestational age and the number of fetus in their womb. Those that had cesarean sections also, and the body mass index was also one of the categories that were used on this study in order to know those that were obese. And out of the 200 women that were on study, 2 of them had underweight, 20 of them had normal weight, while 124 of them were overweight, and 54 of these women out of it, 200 respondents were obese. Now, like I said, that it is really a problem, and the health personnel, we need to intensify on these issues. The conclusion of this study, the study investigates the prevalence and the suggested causes of preeclampsia among pregnant women attending antenatal clinic in Central Hospital, Warri, Nigeria. The study clearly demonstrated the causes of preeclampsia to include the history of high blood pressure prior to pregnancy, a family history of preeclampsia, history of obesity and diabetes mellitus, kidney-related problems or diseases, poor nutrition prior and during pregnancy, as well as complications of pregnancies prior to new pregnancy, among others. Now, my recommendation is that based on the prevalence and causes identified in the present study, women should be counseled prior to, during pregnancy. Pregnant women should be adequately supervised during antenatal in a hospital with appropriate facilities in caring for women with severe preeclampsia and other pregnancy-related conditions. Healthcare providers should give nutritional counseling to pregnant women and ensure to advise them to avoid drinking alcohol or smoking tobacco during pregnancy. I hereby advise for further research is done to understand more of the risk factors for preeclampsia, particularly as regards their dietary habit, hereditary, and living standards. This is where I draw the conclusion of my presentation. These are my references. And thank you so much for your attention. Let's see. I remain Juliet Alabra from Nigeria.
Yeah, any questions? Any questions to Dr. Juliet? Any questions?
Hi, Juliet. This is Dr. Long in Las Vegas, Nevada. Thank you for your presentation. And it's so fun to hear your beautiful accent and that beautiful background where you are. I'm curious about, you mentioned that the people tend to rely on their, if the term was correct, their quack practitioners or their native indigenous healthcare workers more than the nurses and the physicians. Is that due to cost or traditional beliefs?
Okay, I said healthcare workers should put up a positive attitude, because if those that are attending the hospital or accessing the health facility don't have positive attitude, it will make these people to resort to attending or going to quacks and meet patronizing traditional birth attendants and those traditional medicines. So we need to put up a positive attitude as health workers to encourage people to access the hospital, to access the healthcare facility. I don't know if I answer your question or I...
Well, yeah, my question is, do the people prefer their local, you say the quacks.
Traditional, okay.
Yeah. Do they prefer them because they're less expensive and more accessible?
Okay, let me come up with this. Some of them, when they have complications, they now run down to the hospital. We ask them, so why are you coming now? He said, because I don't have money. Some of them will say it's too far, because in my hospital where I work, we have some of our patients coming from the riverine area. They travel from the river, they cross through the river and come to our hospital, like 1 or 2 hours distance in the water, and come to our hospital for healthcare. Most of the time, it's when they had complications already. That is when they now run down to the hospital. We now ask, why are you coming now? Say, I don't have money to take a boat to the hospital. And some of them will say, I don't have money to buy medications and all that. And like I said in my presentation, the government in my hospital tried to bring up a program called free maternal care and also free under 5. Currently, I work in the children emergency. Some of those conditions we have, the free under 5, those children under 5 years. I don't know, you understand me?
I think so, yes.
Yes, so those that were attended to, the free under 5, what happened? They remain where they are. When the case is not complicated, that is why they now rush down to the hospital. But those that are within the city where I work, they come, those that are within, they come to the hospital and access medical care. But those that are coming from a distant place, they will tell you that because they don't have money for transportation and they don't have money for medication, that is why they decided to go to the local herb, or they decide to use local herb, or they decided to use the nearby person that is close to them. We call them quack. Some of them, they have what we call the Patent Medicine Dealers Association, those that they sell drugs, over-the-counter drugs. So those in the community, they prefer going there because it's close to them. Are you with me?
Yes, so it sounds like there are barriers for them getting to the hospital, and that's why they rely on the maybe untrained medical personnel in their local community. So what is the government doing to try to provide more local resources for them?
Yes, like what I said earlier, the government tried to make it free. Because when you come as a pregnant woman, you're not going to pay for delivery, you're not going to pay for blood investigations, even as far as cesarean section. In Central Hospital Warri, Delta State, Nigeria, cesarean section is free. When you have normal delivery, it's free. As you are going home, you go home with your baby. You don't pay hospital bill. The same thing with those that had children under 5 years. But if your child is more than 5 years, you pay hospital bills. But if the child is less than 5 years, they give them free medication. Those that came with diarrhea, measles, at the end of the day, you give them ORS, you give them anti-malaria drugs, those with malaria, those with malnutrition. We teach them adequate diet, how to go about to the mother, to use the local food that we have, to provide and to make adequate diet for the mothers or for the children to eat.
Very good. Thank you.
Yes.
Thank you so much.
Yes. Any further questions to Dr. Juliet? Just if you have any questions, you can text in chat box. We'll be asking behalf of you.
Yes. I'll be available. Thank you so much. I appreciate the organizers of this program for counting me worthy to be a speaker in this program. And I appreciate the previous speakers also and other participants. Thank you so much. God bless you.
Thank you so much, madam, for participating in this event. On behalf of organizing committee members of the Nursing Education Congress 2021, we want to thank you for your insight presentation. Looking forward to meet you again next time.
Thank you so much.
Yes. Now we ask Dr. Nadi Sylvia as well as Inovine Organizes from University of Nigeria, to start presentation by uploading their PPT.
Can you hear me?
Yes, madam. Just you can continue.
Okay. Yeah, good day. I'm Sylvia Nadi from Nigeria, and I'm so glad to be part of this wonderful conference. Hope I can share my screen. Can you hear me?
Yeah, it's fine, madam. Yes, we can visible your PPT.
Okay, I'll be talking on the demographic, economic, and cultural predictors of facility-based delivery after antenatal attendance in selected hospitals in Enugu, Southeast Nigeria. In wealth in production, Nigeria is still struggling with high maternal mortality, which is underreported. Despite efforts to improve maternal health services. An estimated 40,000 pregnant women died in Nigeria in 2013, with 576 maternal births per 100,000 live births. Now, despite there has been some increase made on antenatal care utilization over the years, but use of a facility with skilled delivery skilled birth attendants is still below accepted standards. The National Demographic Health Survey of recent showed that 61% receive antenatal care, whereas only 36% of women delivered in the facility. Why wouldn't they deliver? The purpose of this study is to deliver.
Hello. Madam, we didn't please unmute, madam. Hello.
Hello, yeah. Hello.
Yeah, can you hear me now?
Yes, it's fine, madam.
Okay.
Please start sharing your.
I can't share my screen. It's showing stop share. Did you stop it? It's showing stop share. I can't share my screen.
Just to be online. Just to be online.
Okay. Hello?
Yes, there was a problem from your side. Just we have made a co-host. Just start sharing from your side.
It's showing stop share. Okay.
Yeah. Hello. Yeah, if possible, yes.
Can you hear me now? Can you hear me now?
Yes, it's fine.
Hello? Okay.
You know, we don't find your PPT. Again, it disabled.
Okay. So
Just start sharing your
sorry,
PPT.
I'm having a little challenge.
Okay, it's fine.
Yeah.
Yeah, it's fine, madam. We can
Is
see
it
your
fine
topic.
now?
Yes, it's fine. We can
Okay.
see your topic on the screen.
All right. So I said there's a descriptive survey design and the University of Nigeria Teaching Hospital and the Cottage Hospital. This is in an attempt to the federal hospital, a state-owned hospital, and a cottage hospital. This the sampling procedure. I'm using a purposive sampling technique to select these 3 hospitals. And then systematic sampling was used to select the number of respondents per hospital, while simple random sampling was used to select the respondents. The sample size was 417 mothers, and then after the study, we were able to use just 401 respondents when some of the questionnaires were not properly filled. The table shown here shows the sample size for the study. The instrument used was a questionnaire developed by the researcher. It was pilot tested using person moment correlation with an alpha of 0.9. Data was analyzed using simple descriptive statistics of frequency, percentages, mean, and standard deviation. The chi-square test was used to test for association between variables at 0.05 level of significance and 95% confidence interval. The criteria mean was set at 2.5. And the SPSS version 20 was used. Now, for the results. Actually, the results in Enugu was quite different from what was shown by the National Health Survey for Nigeria. With facility delivery was 331, that's 82.5% of the respondents actually used the facility to deliver, while only 17.5% used the non-facilities. The non-facilities from the study included churches, traditional birth attendants, and those who delivered at home. This finding is quite interesting because it revealed that people in Southeast Nigeria actually make use of hospitals for delivery more than other parts, like the northern parts. However, the study has further revealed that despite the high number of facility deliveries, which was 82.6%, it was still less than the antenatal attendance, which was as high as 98.2%. That is, almost all the respondents from the study attended antenatal, while only 82.6% delivered in the facility.
This finding also agrees with several other studies in Africa, which discovered that the proportion of women who use antenatal were more than those who used the facility for delivery. Facility-based delivery with skilled birth attendants in this study, unlike what the National Demographic Health Survey shows for Nigeria, that's just 36%. Enugu has a very high facility delivery. So one of the reasons that could explain these results is that the southeastern part of Nigeria is quite more advanced in education than the northern parts, which had only 12% facility delivery. Now, to the predictors, we tried to find out what could have resulted in that 17.5% of respondents who could not use a facility for delivery. We tried to find out what brought about such. From this study, we can see this table. We saw the age, marital status, and level of education. We also looked at religion. Most of the respondents were Christians. We also looked at parity. We looked at antenatal attendance for each pregnancy, and they also looked at distance to the nearest hospital, as shown on this table. Now, for the results of the predictors, we discovered that age was a high predictor for facility delivery. The study showed that high use of facility-based delivery was associated more to older mothers and least to younger mothers. We saw that the older the women get, the more likely they are to deliver in a hospital. We also looked at educational level, which has a p-value of less than 0.01. It shows that there was a relationship with educational level because we discovered that high use of facility delivery was associated
Yeah, doctor, just we can't audible your voice. Yeah, doctor, just I think you are getting the same problem again. Just better to choose a proper network and start presenting.
Can you still hear me, please?
Yes, I think you are facing a network problem.
Okay, so why did we stop? So I can start from there.
Yes, yes. Just start sharing your PowerPoint.
Okay. Do I go back? Hello?
Yes, yes, you can start your presentation. We can visible your PPT.
Yeah, I want to know why the network went off, so I can continue from there. Okay. So just as a little bit of revision.
So we are getting the same problem.
that age was a very strong predictor for fertility delivery. We've seen that mothers, the older the mothers get, the more likely they are to deliver in a hospital. And the younger mothers were less likely to deliver in a facility. I've also said that educational level was a strong predictor for facility delivery, because the study has shown that high use of facility delivery. Can you hear me, please?
Yes, yes, you can go on.
Okay. High use of facility delivery was associated most to mothers with higher education. That's those with secondary and tertiary education, and least to those with primary education or none at all. Antenatal attendance also proved to be a predictor for facility delivery. The study has shown us that mothers who attended antenatal care up to 2 to 3 times and 4 times and above were more likely to deliver in a facility than their counterparts who attended only once or not at all. The distance was not found to be a predictor for facility delivery. All the respondents believed that irrespective of the distance to the nearest hospital, they are willing to deliver in a facility if other factors were met. Religion was also found not to be a factor, because most of the respondents are Christians, and they all believe that hospital delivery was the best. Parity was also not a predictor. The use of a facility for delivery was the same for mothers, irrespective of number of children. Those who had 6 children, those who had 1 child, it never mattered. Okay, I have this table here showing the economic predictors of facility delivery. The economic predictors of importance were employment status, husband's employment status, and then estimated family monthly income. What we've discovered is that respondents who were civil servants and those who were employed in a private organization were far more likely to use the facility to deliver, unlike those who were self-employed, students, or who were unemployed, that's housewives. Then the husband's employment status was also a factor. The study shows that husbands who were civil servants, who were privately employed or employed in a private organization, were more likely to support their wives to deliver in a facility, unlike those who were married to men who were self-employed or unemployed. Family income was also a major factor. Families who earn less than 10,000 naira were less likely to use a facility to deliver, while those who are earning very high, like more than 50,000 naira, had a higher chance of delivering in a facility. This should be very clear because of costs. Okay, this is what I've just explained.
Yes, you can go on.
Then for the cultural predictors, we asked a lot of questions on culture and how it affects delivery in a hospital. All the questions we asked, like were your cultural beliefs respected in the hospital? Was it your culture to deliver at home? Is it against your culture to deliver through cesarean section? Because we see that a lot in these parts. That, this cultural belief that when you deliver through a cesarean section, you are not a natural woman, you are not a full woman. And then we also asked them if they had problems with a male doctor or a male nurse taking their deliveries. All these questions didn't give a positive response except for one, which is the decision maker of the family. Almost all of our respondents agreed that when they make this decision with their husbands, when there's a joint decision with the husband as to where to deliver the baby, they are more likely to deliver in a facility. However, if their mother-in-laws or their husbands alone make this decision, they end up delivering in a traditional birth attendant or at home. That means that the only cultural predictor of note was the decision maker in the family. In summary, this study has shown us that there was a consistent rise in facility delivery, what type of delivery mothers adopt. Marital status also predicted what delivery type they adopt, because we've seen higher use of facility delivery in women who are married more than those who are single. And that can be understood because married women are more likely to make decisions together with their husbands. They're also more likely to be financially independent of the husband, and that helps them to pay for the costs. While those who are single are more likely to be unmarried, they are also more likely to be young, and this will affect their use of the facility. Educational level and antenatal attendance were also found to be strong predictors. The more women attend antenatal, the more likely they are to deliver in a hospital, because they are already used to a hospital environment. They've been given health talks on the need to deliver in a hospital. However, when they don't attend antenatal at all, nobody tells them the importance of doing this. The more educated these women are, the more likely they are to deliver in a facility. When the least educated they are, they end up going to traditional birth attendants, they go to parks, they deliver at homes, and then they come down with all sorts of complications that keep increasing the maternal mortality and morbidity in Africa. Economic predictors of note were mothers' employment status. Women who are civil servants, who work for private organizations, are more likely to deliver in a hospital. This is also quite understandable because when they are civil servants, they earn, they are income makers. They don't depend on their husbands, they don't depend on their mothers, they don't depend on the family to pay for their bills. They are able to finance hospital care. They are also more confident, they are empowered, they can take care of themselves. Unlike women who are self-employed, who have private businesses, they may be trying to save money and save costs. The only cultural predictor of significance we've seen was the decision maker in the family. Women need to be encouraged to have discussions with their husbands and not allow the mother-in-laws to take such sensitive decisions. Recommendations made in the course of this study include that the education of the girl child or acquisition of vocational skills is very important to assure a good source of income, which is a key to successful achievement of Millennium Development Goal 5. When the girl child is well educated, she's more confident, she's empowered, she's more likely to be a worker, she's more likely to get a job and be able to finance the cost of delivery. Now, this part of Nigeria, unlike what the previous presenter talked about in Delta State, where they have prematernal delivery, it's not obtainable in this part of the country. Women actually pay for deliveries and the cost can be quite intimidating. Other recommendations made include that the government and other NGOs should create more jobs, both in the public and private sectors, so that because self-employed mothers and those with self-employed husbands showed the least facility delivery, probably in a bid to save costs. The more employment women have, the better they are to take care of themselves. Safe motherhood support groups should be formed in communities to hold advocacy meetings on the importance of skilled birth attendants. This should be done with opinion leaders, heads of families, elderly women. These elderly women they're the mother-in-laws we're talking about. They need to be sensitized, they need to be informed, they need to understand how important it is and to encourage expectant mothers to go for good antenatal attendance and also deliver in a facility. Other recommendations include that hospitals and health policymakers should put more effort to reduce the cost of delivery so that mothers with lower income can afford them. Also, during antenatal care, more attention should be given to women who fall into the group with least facility attendance. These include young girls, poorly educated girls, unemployed girls, and unmarried girls. When you meet them during antenatal, they should be given more attention to ensure that they deliver in the facility. All this is in a bid to reduce the maternal and mortality rates in Nigeria. Thank you very much. My contact information is shown on the screen, and I think I'm ready to entertain any questions. Hello.
Yes. Any questions? Any questions to Dr. Sylvia Nadi? Yeah, madam, you can find from chat box from Dr. Sisi. Dear Sylvia, thanks for you. Question number 1. Religious is a predictors factors. What will your recommendation? Are you?
I didn't get that.
Yes, you can read from chat box. You have the question from Dr. Sisi.
Okay. Okay. Religion is a predictor factor. What will be your recommendation? No, well, from my study, I've said that religion was not a predictor. However, if religion was to be a predictor, the recommendation will still be the same thing, education. Education is the key, because irrespective of religion, when women are well educated, they are informed, they understand the risk they take when they go to unqualified people to deliver their babies. So I will still say that the best thing to do there is education, educating the girl child. Okay, culture was predictors. Which one good about culture? Well, the cultural predictor we've seen there is the decision maker. African culture is in such a way that usually the husband takes important decisions in the family. The husband decides where the woman goes, he decides where she delivers, and so on and so forth. Now, that is so much more prevalent in situations where the woman is a housewife. When she doesn't have a job, when she can't earn, then she's totally under her husband and can't take decisions for herself. So we're encouraging the same, empowerment for the girl child. When a woman is empowered, she's in a better position to take decisions for herself, especially those that has to do with her health. I don't know if I was able to answer your question.
Any questions to Dr. Sylvia again? Further questions? Any questions? If you have any questions, just text in chat box. We'll be asking you. Yes, no more questions. Thank you very much, madam. Thank you very much. We have enjoyed your speech.
Right.
Please, we got somewhat little bit due to internet problem. Looking again, no problem. Looking forward to meeting again next time.
Thank you very much.
Yes, yes. The last talk of the session before video presentation will be of Dr. Martha K. Ruper. So we invite Dr. Mehran Tariq Khan, Department of Medical Surgical Nursing, Habur School of Nursing from Zanjan University of Medical Sciences from Iran, to join the event and start presentation.
Can I present it?
Yes, you can go on, sir.
Hello, everybody. My name is Mehran Tariq. I'm a faculty member of
Just you can start sharing. Just you can start sharing your PPT, sir, so that I can.
Start it again.
You start sharing your PowerPoint. Start sharing your PowerPoint.
Yes.
Yes, you can go on. You can go on.
Can I start?
Yes.
Yes. In the name of God. Hello, everybody. My name is Mehran Tariq. I am a faculty member in Department of Nursing Education at Paris School of Nursing. Zanjan University of Medical Science and Iran. My study is about education needs of the medical sciences staff to research area working in hospitals of two hospitals in the state of Zanjan in 22. It is necessary to get acquainted with different area of research and acquire necessary skill for it. In order for people to be able to identify their research needs, they need training to become familiar with the areas of research and skills need to conduct research. Today, the issue of assessing the training needs of employees in scientific systems and training them, who are a large segment of the workforce working in the organization, has been organized as an essential issue. If the identification of educational needs and its prioritization is done well and correctly, the implementation of education process will be easier and more effective. One of the benefits of education and familiarizing people with the fields of research is creating new and specific solution and using it to solve problems and remove obstacles according to the facilities available in that organization. In the present study, according to the research needs that were felt in the clinical ward and
excuse me, sir. Just are you visible to your PPT? I am going to share. I've started sharing.
Excuse me.
Are you able to see your PowerPoint? I am going to share on the screen.
Continues or not?
Yes, you can continue.
Okay. Yes. This present according to the research need that were felt in the clinical ward and in Ayatollah Musavi Hospital in Zanjan and Al Gadir Attar Hospital, the researchers decided to identify the educational needs of different research areas and prioritize them to hold a workshop. For this, the main idea and the main aim to this study is investigation to educational needs of research area for the educational science staff working in two hospitals of Ayatollah Musavi Zanjan and Al Gadir Attar in 2020. Method. This is we use descriptive cross-sectional study in this study on this descriptive cross-sectional study conducted on non-faculty staff members of hospitals in the state of Zanjan. In this study, a research made questionnaire including two sections of demographic information and educational needs was used. Questionnaires were systematically and randomly distributed among nurses, medical and paramedical, except nurses, and administrative group, and data were analyzed in species software. Result: 433 people participate in this study, of which 20.8% were men and 343, 79.2% were women, with mean age of 30.78 and work experience almost 10 years. The highest education need of both hospitals was associated with the improvement of specialized English language level of the research staff with 68.5%, and the lowest was the design of poster for accept papers from Congress and conferences was 39.8%. This table describes about the 30 questions that used in this study in the question 1 to question 3, and this question was reliable and validity with faculty members in nursing schools, and this priority show this table. Discussion in this, the overall purpose of this study was determination of educational needs. In this study, based on finding this reached highest education priority in the field of research, including English language improvement only in the field of research, familiarity with database and research methods in them, and the lowest is poster design for article accept from Congress and conferences in the both of the hospital. In this conclusion for this study, identifying educational need in various areas of research and priority among hospital medical science staff, in addition to reduce resource waste, leads to the production of required knowledge and promotion of community health level. Health workers, including hospital medical science staff, can utilize this study as a guide for medical science staff training, needs assessment calls, and quantities with various areas of research. In this study, this is the references to use this in studies.
It's completed, sir?
Yes.
Yes, yes.
Thank you very much for this officer and for the people that this prefer to this program and to congresses.
Definitely. Thank you very much, sir. Any questions to Dr. Mehran? Yes, thank you very much, sir. Unfortunately, you have made a very quick time response. We have made the PPT presentation.
I don't have enough time for this prepare this PowerPoint, but thank you very much.
Yes, we do understand, sir. Within short period,
participate in this congress.
Yes, we do understand. In short period of time, you have made this PowerPoint presentation.
Thank you very much, sir.
Thank you very much. The last, so we'll go with the video presentation of Dr. Martha K. Ruper from Wellesley State Community College of Alabama from USA. It is a video presentation. We request all the participants just look at this video.
Good afternoon. My name is Martha K. Roper, and I'm a registered nurse as well as a certified nurse educator at Wallace State Community College. Wallace State Community College is located in Hanceville, Alabama. Hanceville, Alabama is located in the southeastern portion of the United States of America. Today, I would like to discuss with you my project, A Spirit of Awareness to Increase Student Engagement and Competency Outcomes. This project was implemented in the Department of Nursing at Wallace State Community College. The Department of Nursing provides education to associate degree as well as licensed professional nurses. It's a program that educates at least 200 plus nursing students each year. We are also a National League of Nursing designated Center of Excellence for the years 2016 to 2020, as well as the years 2020 to 2025. This makes us the only college and university to earn this designation for 2 consecutive terms. Today, we will discuss my project, A Spirit of Awareness to Increase Student Engagement and Competency Outcomes. In order to really understand a spirit of engagement, we need to first identify a few key terms. The first 2 terms are about student learning, traditional learning versus virtual learning. Traditional learning we have all heard of. We mostly as educators and as nurse professionals have learned through traditional modalities. We went to class, we opened a textbooks, and we saw our instructors in person. We were evaluated in person. We went to clinical with actual patients. It is a traditional form of education that we are all used to. When the COVID pandemic hit, things changed drastically. We were no longer allowed to go to our classrooms. We were not allowed to fill our lecture halls with students. Instead, terms like socially distancing, wearing your mask, good hand hygiene was the normal language. So for education, the world shifted into virtual learning. Virtual learning consisted of things different than a traditional classroom. Instead of students walking into a traditional classroom as they have done forever, they instead woke up, turned on a computer, and had class in a remote session. They had classes through Zoom meetings, through Collaborate sessions. And instead of face-to-face contact, they saw a teacher through a video camera. This has really impacted student engagement, student morale, and competency outcomes. The third term there is awareness months, which we will use throughout our project. Awareness months are designated months that are nationally recognized to promote awareness of specific diseases. For example, in America, we have National Breast Cancer Awareness Month, which occurs during October. During that month, local, national, and city governments provide extra education, preventative screening tools, signs and symptoms of the disease in order to make the population more aware and hopefully increase the early awareness of the disease and decrease prevalence of that disease in a certain population. The fourth key term there is Healthy People 2030. Healthy People 2030 is a set of objectives designed by the U.S. government. It is a list of over 350 measurable objectives for each type of disease process. It basically gives health providers a set of guidelines and baselines, as well as target ranges for each type of disease process, which forms as our goal for the next decade. The fifth key term there is National Patient Safety Goals. National Patient Safety Goals have been identified by a Joint Commission. There are several different types of National Patient Safety Goals that can be used to care for patients. Some of those National Patient Safety Goals are used more in mental health care settings. Some are used more for home health care settings, while others are used for a hospital care setting. National Patient Safety Goals are basic standards of care that nurses should strive to follow in order to provide safe, efficacious care to their patients. The purpose of a spirit of awareness is to determine whether pre-licensed associate degree students enrolled in the nursing program increase engagement and competency outcomes through participation in the program. We noticed a huge difference between engagement and morale when switching from traditional coursework into virtual learning. We wanted to impact that by providing a program that would help get students engaged and boost morale while they were working their way through the curriculum. We also wanted to increase their awareness of Healthy People 2030 goals so that they would be more aware of their goals as a healthcare provider for the next decade. We also felt that it was important to increase their awareness of national patient safety goals, which they would use daily as they care of patients with different disease processes. We also wanted to implement ways to increase the students' ability to implement safe care for identified topics each month. We chose monthly awareness topics based on several different factors. I have a list here of all of the different monthly topics we used. Some of those examples include Congenital Heart Defect Awareness Month, which I believe is February, Child Abuse Prevention Month, Stroke Awareness Month, Ovarian Cancer Awareness Month, Breast Cancer Awareness Month, Colorectal Cancer Awareness Month, as well as a multitude of others. March happens to be National Kidney Disease Awareness Month. Each of these monthly topics is coupled with a specific color that represents that monthly topic. This month, National Kidney Disease Awareness Month, uses the color orange to represent that disease process. There are a multitude of monthly topics we could have chose from. There is a vast array of different disease processes that students are exposed to and that patients are diagnosed with. But when choosing specific monthly topics, we looked at several different factors. One of those factors was the curriculum itself. We wanted to choose topics that the students would learn about in class. We also wanted to choose topics that fully covered not just adult med-surg care, but also pediatric care, maternal health care, and mental health care. So if you'll notice from the monthly topics, there are several different areas of pediatric awareness, such as pediatric cancer awareness, cystic fibrosis awareness months, as well as congenital heart defect awareness month. There's also some areas of mental health topics that we covered and chose based on those monthly topics. For example, Alzheimer's Awareness Month and Autism Awareness Month. We also chose some maternal and OB monthly topics in order to pull those areas of the curriculum together. Another reason we chose specific monthly topics was based on the disease prevalence in the communities that we live and serve. We wanted to ensure that the students would learn about topics that they would one day hope to take care of once they have graduated from nursing school. Based on where we live in the southeastern portion of the United States, we have an extremely high rate of kidney disease. We also have an extremely high rate of congestive heart failure, myocardial infarctions, and hypertension. So we chose things like Kidney Disease Awareness Month, American Heart Association Month, Stroke Awareness Month, in order to increase knowledge among the nursing students so that they would know more about the topics and the disease processes that they're going to take care of in the future. While implementing this topic, we chose monthly awareness months, one for each month of the curriculum. Students were encouraged to wear specific color t-shirts to support each awareness month during the virtual class sessions. So this month is National Kidney Disease Awareness Month, and the color is orange. Students would be encouraged to wear an orange t-shirt rather than their scrubs or their uniforms to the virtual class session. This was supposed to increase engagement and increase morale so that they could think outside the box, express some creativity, but still support a good cause. A slideshow was also created about the specific awareness month, which included statistics about the disease process, symptoms of the disease process, Healthy People 2030 goals that were correlated with a specific disease process, national patient safety goals associated with the disease process, and a patient safety goal challenge. I have included several examples of these in the following slides. This next slide is an example of a Healthy People 2030 goal for Chronic Kidney Disease Awareness Month, where the color is orange. You can see the Healthy People 2030 objective is to reduce the proportion of the U.S. population with chronic kidney disease. You can see that the baseline as of now, which they were established in 2020, is 14.1% of the U.S. population had a diagnosis of chronic kidney disease. Our target and goal for the next decade is to reduce that number to 12.8%. By showing students specific objectives, specific goals for the next decade, we felt that it would encourage preventative care measures. It would encourage students to really take part and take initiative, as well as take responsibility in achieving those goals for patient care. The next example is an example of a national patient safety goal. We've listed those here as use alarm safety, as well as the specific national patient safety goal number. The actual verbiage of the goal reads, make improvements to ensure that alarms on medical equipment are heard and responded to on time. In addition to reading that verbiage and understanding what our standard of care is as healthcare providers, we also included a national patient safety goal challenge for each month. The challenge this month includes a patient scenario where you are caring for multiple clients on a dialysis unit, because this month is National Kidney Disease Awareness Month. The alarm sounds on another nurse's patient. However, the nurse appears to not hear and not respond to that alarm. So there are a few rhetorical questions that we ask those students during those virtual sessions. The first question that we ask is, should you respond to the patient's alarm? Which is a very realistic, very real example of something that could very easily happen in any type of unit. So we ask students, what should you do? Should you go take care of the patient? Should you question the nurse? And see what students' response is. Then we also ask a thought-provoking question. The thought-provoking question here is, can monitor fatigue impact patient care? We've all heard of monitor fatigue. We've all probably experienced monitor fatigue, and it's a very realistic thing that can happen, unfortunately. So it allows students to discuss real things that impact patient care, as well as how implementation of a national patient safety goal to identify and respond to things quickly can really impact care and prevent a poor outcome for that patient. When we researched this project, we found that this project was extremely efficacious in the students' engagement, morale, as well as their competency outcomes. 20 out of 30 students, which is about 67% of the students surveyed, felt like it did increase student morale. They felt it did increase student engagement to be able and allowed to wear a specific colored t-shirt in class, as well as go over a specific set of PowerPoints about a monthly topic. About 90% of students, 98% of students, or 29 out of 30 students, felt that they were more aware of Healthy People 2030 goals related to each specific disease process, as well as they felt better versed in national patient safety goals and how to implement those into patient safety care. In conclusion, we felt that this project was extremely useful, especially for students in a virtual environment. The purpose was basically to retain engagement, increase morale, and help students learn some basic ideas, basic goals, and basic ways to care safely for patients diagnosed with specific disease processes. We picked monthly topics, allowed students to look into those topics on a more personable level by allowing them to wear t-shirts into the class in the virtual setting instead of their uniforms or mandatory required scrub attire. In the virtual session, we went over signs and symptoms of the disease process, Healthy People 2030 goals and objectives, national patient safety goals, as well as scenarios on how to implement national patient safety goals. During research, we decided that this program was extremely efficacious. Students enjoyed being allowed to wear t-shirts to class. They felt it boosted their morale. It made them want to attend, want to participate, want to learn more. They also felt it was very beneficial in their ability to apply specific objectives and goals into patient care, as well as national patient safety goals into specific patient care. This was a quick and easy way to increase students' virtual engagement and competency outcomes through a spirit of awareness.
It was a video record presentation from Dr. Martha Keruper. So this is the sessions we have completed today. If you have any questions, we can discuss within 10 to 15 minutes. We will be closing today's program. Any questions we can discuss from here. Yes, doctor.
Hello.
Yes, sir. You can go on.
Hello.
Yes, sir. You can go on.
Okay, and Sisai, and organizing this program is not a simple task. I know that it is a difficult task. So thank you for your organizing this program.
Yes,
well, you are doing well. We learned a lot of things from this program. So I would like to thank you and continue on this way. At least it is better if we have 2 times per year. Okay, and this and
yes, sir.
different situation. So I would like to thank all the presenter as well as all are doing well. If we have 2 times per year to share, I would like to thank. I will ask someone who have to cover some costs and who have an access for different issues, especially from developed country, to cover different costs because it is not easy things. It needs a lot of money and different issue. So the simple task, it is not simple. I would like to say thank you. And it is better to discuss further and to share our email and different things to share experience rather than this meeting. So I would like to say thank you. Goodbye.
Yes. Thank you very much, sir, for your feedback, for your suggestions as well. So definitely we will intimate to my higher authority regarding your advice. Any suggestions as well as feedbacks from the participants? We hope you have enjoyed our event. We would like to thank you from the entire team of Virtual Nursing Education Congress 2021. Yes. Thank you very much for all the participants in the events. On behalf of organizing committee members of Nursing Education, we want to thank for instant presentation. We take this opportunity to extend our most sincere thanks to all the keynote speakers, plenary speakers, students, delegates, media partners who have joined from different destinations around the globe for their support and cooperation in this virtual event. We would like to gratitude to keynote speakers of the Day-2, that is Dr. Mary Estelle Bister as well as Dr. Jelena Roganvik from the Croatia, as well as the plenary speakers of the day 2 will be Dr. Jakob, Mr. Anas Ramay, Dr. Tracy Roy, Dr. Mohammed Shoban, Dr. Safia, Dr. Pirbux Jukio, Dr. Jinia Juchel, Dr. Sise, Dr. Umarani, Dr. Elizabeth, Dr. Yolanda, Dr. Mehren, as well delegate presenters, especially those who are asking questions, Dr. Hanan, as well as video presentation, Martha. We also wish to express our gratitude for this minute-to-minute guidance and support for the provide encouragement at every point of time in this organization at this every time. Let us thank speakers who have responded so well to our invitation to participate in this conference. We have received several papers which will aim to all the basis of our discussion in these various sessions. Let us thank you all the association with this conference by your presence. It's a special thanks to Program Manager Mr. Ronald Thomas as well as Ms. Shilpa for her continuous effort in the putting all us together under one platform. Finally, we extend our appreciation to each of you for your participation in this conference. We hope you enjoyed this conference and that your time spent here will be contribute to your professional development and enable you to build a new collaboration in this important and rapidly emerging field of nursing education, especially during this COVID-19. You will be getting electronic certificate as well as electronic handbook will be sent through email in 2 to 3 working days after the completion of the conference. Thank you. Thank you very much. This is signing off Madhu Bhupati. Just we are going to close the conference.